National Medical Congress for Students and Young Doctors.
We warmly welcome the Vice Rector for Education and Didactics, Professor Camil Torres.
Witam Państwa. Czy jestem słyszalny? Tak? Witam Państwa bardzo serdecznie. Cieszę się, że możemy się już spotkać 7. raz. Gratuluję organizatorom i wszystkim nauczycielom, wszystkim katedrom wspierającym, zwłaszcza Katedrze Epidemiologii, ale przede wszystkim gratuluję studentom. Gratuluję wytrwałości i gratuluję czegoś szczególnego, co ta konferencja ma, mianowicie pomysłu, bo pomysł, jak wiecie, jest bardzo ważny. Konferencji, w których możecie uczęszczać, to jak policzyłem ostatnio, było przynajmniej 3 lub 4. Natomiast ta jest wyjątkowa, bo pomysł jest szczególny. Miło mi również widzieć naszych absolwentów, którzy jeszcze do niedawna byli studentami, dzisiaj są praktykującymi lekarzami i to też czyni tę konferencję szczególną, że ci absolwenci chcą tutaj z nami być. Jeszcze raz serdecznie gratuluję, życzę owocnych obrad i życzę dobrego, edukacyjnego dnia. Dziękuję.
Thank you very much. We would like to welcome the organizing committee of the conference, headed by its supervisors from the Department of Epidemiology and Clinical Research Methodology, Professor Agata Smoleń and Dr. Marcin Lewicki.
Witam Państwa bardzo serdecznie na 7. edycji Międzynarodowej Konferencji dla Studentów i Młodych Lekarzy 21st Century Medicine, organizowanej przez Organizację Młodych Medyków Uniwersytetu Medycznego w Lublinie oraz naszą Katedrę i Zakład Epidemiologii, Metodologii, Badań Klinicznych Uniwersytetu Medycznego w Lublinie wraz z partnerami pod patronatem honorowym Jego Magnificencji Rektora Uniwersytetu Medycznego w Lublinie, prezydenta miasta Lublin, Lubelskiej Izby Lekarskiej oraz Polskiego Radia Lublin, Radia Centrum i MedTube. Jest to konferencja, która skupia się na interdyscyplinarnym podejściu do medycyny oraz na nowych osiągnięciach i wyzwaniach w szeroko pojętej medycynie i naukach pokrewnych. Poza naszymi uczestnikami, do których głównie kierowana jest ta konferencja i wynikająca z niej wiedza, chciałabym przywitać wszystkich przybyłych gości, przedstawicieli władz Uniwersytetu Medycznego i miasta Lublin. Oczywiście szczególnie witam naszych młodszych kolegów, wszystkich studentów i młodych lekarzy oraz przedstawicieli środowisk naukowych uczestniczących zarówno stacjonarnie, jak i online w naszej konferencji. Jak Państwo doskonale wiecie, problemy, z którymi mierzymy się na co dzień we wszystkich specjalnościach medycznych, są ciągle inspiracją do kolejnych dociekań naukowych. Te interesujące zagadnienia zostaną zaprezentowane na naszej konferencji, która jest również okazją do nabycia umiejętności praktycznych podczas towarzyszących warsztatów. Życzę Państwu, organizatorom i uczestnikom dotychczasowego entuzjazmu i zapału do pracy, dalszych sukcesów naukowych i realizacji wszystkich planów na dalszych etapach rozwoju zawodowego, pokonywania trudnych wyzwań z należną satysfakcją. Niech zawsze przyświeca Wam moje ulubione motto per aspera ad astra. Szanowni Państwo, konferencję uważam za otwartą i chciałabym przekazać głos organizatorom, współorganizatorom, kolejnie wykładowcom, którzy uświetnią naszą konferencję ciekawymi prelekcjami.
Drodzy goście, to zaszczyt móc przewodniczyć tak wielkiemu przedsięwzięciu. Jest mi niezwykle miło, że mogę widzieć Was tutaj na żywo, a nie tylko przed ekranami komputerów. Przez rok dokładaliśmy starań, aby chociaż częściowo przywrócić formę konferencji sprzed pandemii. Czasy się zmieniają. XXI wiek to nieustanna gonitwa nowych możliwości i poszerzania perspektyw. Mam nadzieję, że naleciałości te odnajdziecie w wielu atrakcjach, jakie dla Was przygotowaliśmy. Życzę owocnych dyskusji, nowych znajomości i mile spędzonych chwil podczas tej konferencji. Dziękuję.
Thank you very much. After a short welcome, we would like to move on to the lecture panel of the conference. We are going to hear speeches of 3 people connected with totally different fields of medicine. Each of them, however, will raise issues which are appropriate for the 21st century.
As has already been mentioned today, we are slowly coming back to the reality after the brutal and unexpected attack of SARS coronavirus pandemic. Many claim that the COVID era is coming to an end. Should we really be breathing a sigh of relief? Are we by any chance standing in the shadow of another pandemic? These questions will be answered by our first lecturer and at the same time the conference supervisor, Dr. Marcin Lewicki.
Witam Państwa serdecznie. Bardzo dziękuję. Jest mi niezmiernie miło, że mogę uczestniczyć w tym wydarzeniu. I coś ode mnie tym razem. Drodzy Państwo, 2 słowa o małpie ospie i przewrotne pytanie, czy jesteśmy w cieniu nowej pandemii. Wszyscy wiemy, że przez ostatnie lata borykaliśmy się z pandemią SARS-CoV-2, z infekcją COVID-19. Na pewno nie jesteśmy przygotowani psychicznie na nową rzecz. Z drugiej strony świat odrobił też lekcję epidemiologiczną, więc to, że reagujemy w ten sposób tak dużymi emocjami, świadczy o tym, że będziemy monitorować sytuację, jeśli chodzi o choroby zakaźne. Ale do rzeczy. Mamy ospę małpią. Jest to wirus MPX, czyli popularnie zwany monkeypox. Jest infekcją wirusową wywoływaną przez wirusa ospy małpiej. Należy do rodzaju orthopoxvirus. Jest to grupa, której nie kojarzymy absolutnie z ospą wietrzną, bo to będzie zupełnie inny gatunek. Natomiast najbliżej ospie małpiej będzie jednak do ospy prawdziwej, czyli tej jednostki chorobowej, która w dalekiej przeszłości była dla nas dużym problemem i tak naprawdę stała się podstawą do tworzenia jednych z pierwszych szczepionek, bo jakby trup ścielił się gęsto. Małpia ospa została po raz pierwszy zidentyfikowana u małp, stąd nazwa, ale nie do końca jest to takie wiążące, dlaczego to zaraz Wam powiem. Natomiast sama choroba została po raz pierwszy zidentyfikowana u małp w roku 1958 roku, więc od tej pory wiemy o tej jednostce chorobowej. Pierwsze potwierdzenie w modelu ludzkim to jest rok 1970 w Demokratycznej Republice Konga. I do niedawna zostawało mniej więcej w tamtym miejscu, czyli kilkanaście krajów, bo ten katalog się rozszerzał, zawężał. Możemy wymieniać Benin, możemy wymieniać Kamerun, Republikę Środkowoafrykańską, właśnie Demokratyczną Republikę Konga, Gabon, Wybrzeże Kości Słoniowej. W 2016 roku dołączyła Sierra Leone, Południowy Sudan, Nigeria, Kongo. I do tej pory patrzyliśmy na tą jednostkę chorobową jako na jednostkę występującą endemicznie. Co ważne, takie pierwsze zachorowania europejskie czy w Ameryce Północnej to nie są czasy nam obecne. Te przypadki były importowane i medycyna podróży wiedziała o małpiej ospie już od jakiegoś czasu. Takie pierwsze potwierdzone zakażenia w Stanach Zjednoczonych czy w Wielkiej Brytanii to już rok 2003. Najczęściej oczywiście z potwierdzonym kontaktem i z ewidentnym wywiadem podróży w tamtych regionach. Rezerwuarem wirusa są małpy, są gryzonie, może nawet przede wszystkim gryzonie, stąd nazwa może być trochę myląca, bo w pierwszej kolejności wymienia się szczury gambijskie, wiewiórki, myszy pasiaste, ale też małpy naczelne. Przy pierwszej transmisji był to ten typowy model transmisji z naczelnych, stąd nazwa się przyjęła i została z nami. Notowane są przypadki zakażeń u ludzi i tak było na etapie endemicznym poprzez ugryzienie, bezpośredni kontakt z krwią, z płynami ustrojowymi, ze zmianami skórnymi, które zaraz Wam pokażę, oczywiście w kontakcie z zakażonym zwierzęciem. Do tej pory, do momentu, w którym rozmawiamy, do zachorowań u ludzi dochodziło bardzo rzadko. Mówiliśmy o zachorowaniach w Afryce subsaharyjskiej, o chorobach przywiezionych po ekspozycjach turystycznych. Tak, żebyście znali mniej więcej epidemiologię, to było, nie wiem, 14 zachorowań w Republice Środkowoafrykańskiej w 2018 roku, 88 w Kongo, około 100 przypadków co roku w Nigerii, więc tak, żeby zapamiętać jakąś prawidłowość epidemiologiczną, powiedzielibyśmy, że do tej pory około 100 przypadków na rok i będzie to bliskie prawdy. Natomiast w tym momencie mamy zakażenia małpią ospą, które są potwierdzane w całej Europie, w Stanach Zjednoczonych, w Australii, no i na całym świecie znajdujemy coraz więcej przypadków. Jesteśmy teraz na etapie badania rozprzestrzeniania się choroby, no i zaczynamy zastanawiać się, nad znaczeniem dla społeczeństwa, bo lekcja COVID jest zbyt bolesna i zbyt niedawna i być może wcale nieskończona, więc reagujemy tak, jak reagujemy. W dniu 7 maja 2022, bardzo niedawno, Wielka Brytania zgłosiła pierwszy w Europie zawleczony przypadek ospy małpiej. Była to osoba podróżująca z Nigerii. Przeskakujemy trochę w czasie i w piątek 20 maja potwierdzono pierwszy przypadek już bliżej nam, czyli u naszego bezpośredniego sąsiada, bo pierwszy przypadek znaleziony w Niemczech. Do czasu, no dzisiaj, takich godzin nad ranem, czyli do 3 czerwca, w Europie zanotowano łącznie 681 potwierdzonych przypadków zakażenia. Na świecie 772. Zwykle w tych analizach, przynajmniej na początku tej fazy, będzie około 50 osób, które są podejrzewane w tym momencie i testy są weryfikowane, więc to mówimy w tym momencie o około 825 osobach. Co ważne i wymaga podkreślenia w tym momencie, to to, że Polska jeszcze nie odnotowała żadnych zakażeń. Pewnie nie ma się co oszukiwać, jakieś będą. Kiedy? Ciężko powiedzieć, w najbliższych dniach pewnie będziemy izolować też i u nas przypadki małpiej ospy. Tak to wygląda w chwili obecnej, bo tutaj też działają te systemy, które na bieżąco zliczają dostępne dane, jeśli chodzi o zachorowania. No to zobaczcie, że europejsko w tym momencie najgorsza sytuacja jest w Wielkiej Brytanii, bo mamy 207 potwierdzonych przypadków, 1 potencjalnie do tego może dojść dzisiaj. Hiszpania 156, Portugalia 138, pozostałe kraje jak Niemcy, jak Holandia, jak Francja mniej poniżej setki. Tutaj macie wymienione wszystkie kraje poza europejskimi, dorzucamy Stany Zjednoczone, mamy właśnie Australię, bo stamtąd dane spływają. Całościowo to ta liczba 772, którą Wam przedstawiłem. Od razu pewne teorie spiskowe się pojawiają, jest to pewnie naturalne w takiej sytuacji, więc pojawia się popularny serial kreskówkowy, również popularny w naszym kręgu kulturowym, bo Simpsonowie i od razu memy typu, że Simpsonowie przewidzieli różne rzeczy typu wybór prezydenta Trumpa, zakończenie gry o tron i między innymi małpią ospę. Okazuje się, że jest to troszkę fejkowa sytuacja, bo jest to zestawienie dwóch print screenów zupełnie innych odcinków i o coś innego chodziło. Na tutaj zdjęciu po drugiej stronie faktycznie Homer ma objawę ospy, ale raczej od swojej córki i ospy wietrznej. Więc tutaj tą sytuację uspokajamy. Tak a propos Simpsonów, to jeszcze też sytuacja podejrzana wymaga wyjaśnienia, bo przewidzieli wybudowanie w Londynie tego wieżowca Shard na parę lat, zanim były w ogóle pomysły i co ciekawe trafili dokładnie z umiejscowieniem, co też widzicie tutaj na zdjęciu, ale w przypadku ospy małpiej mówimy zdecydowane nie. Dlaczego teraz i o co chodzi? Wydaje się, że obecne rozprzestrzenianie się może być związane z zaprzestaniem stosowania szczepień przeciwko ospie prawdziwej, tej zwanej ospą czarną, o której mówiliśmy. Zakończono je w roku 1980. No dlaczego je zakończono? Dlatego, że była eradykacja pełna tej choroby, nie było żadnych przypadków, więc stwierdzono, że wycofamy się z tego w kalendarzu szczepień. No i w tym momencie jesteśmy na etapie wygasania odporności u osób zaszczepionych szczepionką przeciwko ospie prawdziwej. No i możemy pokusić się o wstępny wniosek, czy szczepionka przeciwko ospie prawdziwej chroni przed zachorowaniami na małpią ospę. Dane niewiążące, ale sugerujące około 85% skuteczność szczepionki przeciwko ospie prawdziwej, jeśli chodzi o ochronę przed małpią ospą. Stąd ta odporność krzyżowa była gwarantowana. Jeśli wygasza się odporność po ospie prawdziwej, być może to tłumaczy tą sytuację. Na pewno przypadki małpiej ospy zaczęły przeciekać do populacji europejskiej już jakiś czas temu. W tym momencie obserwujemy po prostu jasne zaznaczenie tego trendu. To myślę, że trwa już od jakiegoś czasu. Sama infekcja ma swoje dwie odmiany, tak zwaną zachodnioafrykańską oraz środkowoafrykańską, które różnią się ciężkością przebiegu. Obecnie te przypadki, które mamy w Europie, są spowodowane odmianą zachodnioafrykańską. Dla nas dobrze, bo odmiana zachodnioafrykańska ma łagodniejszy przebieg. Bardzo ostrożnie, jeśli możemy mówić o śmiertelnościach w przypadku tych jednostek chorobowych, tutaj około 1%, natomiast w środkowoafrykańskiej około 10%. Dla porównania ospa prawdziwa powyżej 30 lekką ręką, więc tutaj mamy ten jakby łagodniejszą odmianę, która występuje w Europie i te zdjęcia, które mogliście widzieć ostatnio w serwisach informacyjnych, które też Wam pokażę o intensywnych zmianach pęcherzowych, które pojawiają się u pacjentów chorych na małpią ospę. Pamiętajcie, że są to najczęściej zdjęcia z odmiany o cięższym przebiegu, nie z zachorowań jeszcze rdzennie tutaj europejskich. Źródłem obecnych ognisk na obszarze Europy jest wirus linii zachodnioafrykańskich, to mówiliśmy. Wstępne badania, bo już są, czyli te wstępne badania materiału genetycznego nie wykazały na obecną chwilę mutacji wirusa, która mogłaby tłumaczyć przyczyny szerzenia się przypadków w Europie. To też jest informacja dobra, bo trudno nie robić porównań na bieżąco z COVID-em. Pamiętajcie, że COVID był nowym wirusem, wirus małpiej ospy absolutnie nowym wirusem nie jest, bo wiemy o nim od dawna i wydaje się, że struktura pozostała taka sama. W sytuacji takiej epidemiologicznej mówimy też o tak zwanym zjawisku superspreading, czyli transmisji poprzez zakażoną osobę lub osoby o dużej liczbie bezpośrednich kontaktów społecznych. To by tłumaczyło obecną sytuację w Wielkiej Brytanii. Wirus łatwo szerzy się między ludźmi, na co musimy uważać, to na drogi transmisji. Przede wszystkim kropelkowa, z dróg oddechowych podczas bezpośredniego i długotrwałego kontaktu twarzą w twarz. Porównanie z COVID-em zdecydowanie trudniejsza transmisja małpiej ospy niż COVID-u, więc wydaje się, że nawet jeden pacjent zakażony zarazi mniej kolejnych pacjentów niż to miało miejsce w przypadku zakażenia SARS-CoV-2. Kolejna sprawa to bezpośredni kontakt z płynami ustrojowymi osoby zakażonej, kontakt błony śluzowej lub nienaruszonej skóry, te zmiany skórne, kontakty seksualne również, no i oczywiście przedmioty skażone wirusem, pościel, ręczniki, odzież. Te rzeczy będą źródłem infekcji przez dłuższy czas, nawet do miesiąca, tak się wydaje. Okres inkubacji małpiej ospy to zwykle od 6 do 13 dni, może być dłuższy, nawet do 21. Objawy choroby początkowo mocno niecharakterystyczne jak w większości infekcji wirusowych, czyli wysoka gorączka powyżej 38 stopni, takie uogólnione miejscowe powiększenie węzłów chłonnych. Ten odczyn węzłowy jest zupełnie nietypowy dla ospy wiecznej, więc tutaj jest użytecznym objawem w diagnostyce różnicowej. Bóle głowy, bóle mięśni, ból pleców, znaczne osłabienie i dopiero potem na etapie późniejszym choroby, czyli po 1-3 dniach takich objawów dziwnych, rozwija się wysypka, na którą czekamy, bo będzie ułatwiała nam rozpoznanie. Zaczyna się ta ewolucja dermatologiczna od plamki, po grudkę, potem te pęcherzyki, które mogą się nadkażać. Wysypka zazwyczaj zaczyna się na twarzy i będzie się rozprzestrzeniała na inne części ciała. W czasie występowania wysypki osoba na pewno będzie zakaźna. Wysypka utrzymuje się przez 2-4 tygodnie, stąd 2-4 tygodnie będzie naszym potencjalnym czasem zakaźności. Z rzeczy ważnych, jeśli chodzi o jakiś tam follow-up, no to te blizny po odpadnięciu z trupów są dosyć głębokie, będą pozostawały, ale są szanse, że po jakimś czasie będą zanikać. Tak wyglądają podstawowe zmiany skórne, jeśli chodzi o małpią ospę, więc widzicie, że to są dane afrykańskie z tych zmian nasilonych. W Polsce jest mniejszy wysiew po prostu tych zmian, tego na razie obserwujemy mniej. Za początek okresu zakaźnego uważamy początek wysypki. Uwaga, bo wydaje się mocno prawdopodobne, że osoby będą zakaźne również w fazie tych objawów prodromalnych, czyli tego rozbicia, tej gorączki, tych bóli mięśniowych. W tym momencie mamy już nasze własne regulacje polskie. No, trzeba było je tworzyć na bieżąco, no bo jakby małpia ospa nie była chorobą, która występowała w Polsce, stąd ustawa o zwalczaniu i zapobieganiu chorób zakaźnych nie wypowiadała się na temat małpiej ospy. Pamiętajcie, że te zakażenia podlegają zgłoszeniu przez lekarza do Państwowego Powiatowego Inspektora Sanitarnego na numer telefonu alarmowego, który łatwo znajdziecie na stronach internetowych. Dodatkowo formularz zgłoszenia choroby zakaźnej. Wszystko może być zrobione elektronicznie przez gabinet gov. Osoby, które są podejrzane o zachorowanie na ospę małpią, podlegają obowiązkowej hospitalizacji do czasu ustalenia innej etiologii, że jednak to nie było to i do kończenia diagnostyki. Osoby, u których potwierdziliśmy już laboratoryjnie zakażenie wirusem, będą podlegały obowiązkowej hospitalizacji w myśl wytycznych ministra zdrowia przez czas wskazany przez lekarza, czyli najczęściej do całkowitego wygojenia się pęcherzy i odpadnięcia z trupów, czyli zobaczcie, że to będzie dosyć długi okres czasu. Mówimy o potwierdzeniu laboratoryjnym. Będzie to robione dokładnie tak samo, jak już się nauczyliśmy i z czym się oswoiliśmy, czyli będą to testy PCR, mogą być z krwi, mogą być z materiału pobranego ze zmian skórnych. Tutaj czekamy na ostateczne decyzje diagnostyczne. Co z osobami z kontaktu tak zwanego, czyli te, które miały styczność z osobą podejrzaną o zachorowanie, no to zgodnie z decyzją Państwowego Powiatowego Inspektora Sanitarnego te osoby podlegają obowiązkowej kwarantannie, ewentualnie nadzorowi epidemiologicznego i tu znowu do czasu ustalenia innej etiologii zachorowania u tej osoby, z którą miały kontakt, bo wtedy będą szybko zwolnione z tego, albo wykluczenia zakażenia wirusem ospy u osoby, która miała być tym potencjalnym źródłem zakażenia. Inaczej będzie wyglądała sytuacja dla osób, które miały bliski kontakt z osobą, u której potwierdzono zakażenie na ospę małpią, więc te osoby podlegają obowiązkowej kwarantannie przez okres czasu trwający do 21 dnia, licząc od dnia następującego po ostatnim dniu kontaktu. Tak to będziemy liczyć, czyli zobaczcie, że kwarantanna tutaj będzie długa, ale to wynika z okresu inkubacji i z okresu potencjalnego wystąpienia tych objawów. Z naszej działki, słuchajcie, prawdopodobieństwo przeniesienia wirusa na pracowników ochrony zdrowia określane jest jako bardzo niskie pod warunkiem stosowania podstawowych środków ochrony indywidualnej, które macie wymienione tutaj. To musi być ochrona w stopniu nie mniejszym niż jednorazowy długi fartuch z długim rękawem, rękawiczki ochronne, ochraniacze na buty, maseczka klasy FFP2, gogle lub przyłbica, więc wtedy powinniśmy być w miarę bezpieczni. Z rzeczy ważnych w tym momencie, no to wiemy, że według amerykańskiego CDC szczepionka przeciwko ospie prawdziwej może być skuteczna w co najmniej 85% w zapobieganiu małpiej ospie, chociaż w tym momencie nie ma jeszcze na ten temat danych wiążących, ale wydaje się, że tak może być. W przypadku wystąpienia zakażenia musimy powiedzieć, że w tym momencie nie ma kierunkowego leczenia w przypadku ospy małpiej. Stosujemy leczenie objawowe, będziemy używać wszelakich leków przeciwwirusowych. Natomiast są dowody na skuteczność, które płyną z badań in vitro. Mówimy o skuteczności cydofowiru, brincidofowiru i tecovirimatu. Ten ostatni był testowany już w warunkach nawet europejskich, bo Wielka Brytania ma pewne doświadczenia w trakcie właśnie leczenia pacjentów z importowaną małpią ospą. No to tam poprawiało stan pacjenta, ale przede wszystkim skracało okres hospitalizacji zastosowaniem tego leku. Kwestia szczepionki pod znakiem zapytania. Tutaj też byśmy to podkreślili, że mamy na starcie o wiele lepszą sytuację w porównaniu chociażby z COVID-em. Jest szczepionka pod różnymi nazwami. W Europie jest zarejestrowana pod nazwą handlową Imvanex. Jest to preparat zatwierdzony w 2019 roku przez FDA, ale też przez Europejską Agencję Leków. Jest zarejestrowana w zapobieganiu ospie prawdziwej i uwaga, bo ospie małpiej u osób dorosłych w wieku od 18 roku życia. Pamiętajcie, że jest to tak z punktu widzenia też Stanów Zjednoczonych jedyna, bo są dwie szczepionki dostępne, natomiast ta jest zatwierdzona też do użytku niewojskowego, bo standardem w armii amerykańskiej na przykład jest szczepienie przeciwko ospie prawdziwej w ramach tam szkolenia tego bootcamp takiego podstawowego przed jakimiś misjami, to tam jest inna forma tej szczepionki. Szczepionka zawiera zmodyfikowaną postać wirusa krowianki ze szczepu, tak zwanego szczepu Ankara. Dobrze stworzony preparat nie będzie wywoływał choroby u ludzi i nie jest w stanie replikować w naszym organizmie, stąd szczepionka bezpieczna. Podobieństwo wystarczające do struktur antygenowych wirusa ospy, żeby generować odporność też i u nas. Ta szczepionka jest dostępna, jest zarejestrowana w Europie, no i na stan mojej wiedzy toczą się teraz właśnie intensywne zakupy, co bardziej ogarnięte kraje zaczynają skupować tą szczepionkę, czy troszkę na wyrost, kwestia otwarta do przedyskutowania, no ale odrobiliśmy tą lekcję, więc wiem, że Stany Zjednoczone się towarują, na pewno Dania się towaruje na potęgę, Wielka Brytania i Hiszpania również. Drodzy Państwo, na tym etapie wstępne wnioski. Przede wszystkim jeden uspokajający, zakaźność pewnie nie będzie tak duża. Drugi uspokajający wniosek to taki, że nie jest to nowy wirus, nie jest to nowa odmiana tego wirusa. I wstępny, ostrożny wniosek mówi o tym, że małpia ospa nie spowoduje ogólnokrajowej epidemii takiej, jaką znamy i pamiętamy z COVID-19, ale też pamiętajmy, że nie można bagatelizować sprawy. Jest to poważny wybuch poważnej choroby i musimy tę sytuację traktować poważnie. Bardzo dziękuję za uwagę. Korzystając z okazji życzę owocnych obrad na kongresie i widzimy się niebawem.
Thank you very much. Are there any questions to the doctor? Okay, thank you very much.
Thank you.
As the name of the event suggests, our conference is about continuous improvement and moving forwards with the times. It is easy to talk about such things within the walls of a university, where you constantly hear about the latest medical innovations. But how does this knowledge translate into real life and everyday functioning, for example, in the office of a primary care physician? These questions will be answered by another lecturer, the originator and chairman of the first and second edition of the conference, Dr. Jacek Skup.
Witam Państwa serdecznie. Dziękuję przede wszystkim organizatorom za zaproszenie. Jest mi bardzo miło, bo czuję się jak na 7 urodzinach swojego dziecka, także dziękuję serdecznie za to, że widzę, że to dziecko rośnie, kwitnie, rozwija się i z roku na rok jest coraz piękniejsze. Drodzy Państwo, chciałbym Wam dzisiaj opowiedzieć o rozwiązaniach telemedycznych, telediagnostyce i telemonitoringu w gabinecie lekarza podstawowej opieki zdrowotnej. Zaczniemy sobie od tego, jakie wyzwania stoją przed naszą polską medycyną w XXI wieku. Przede wszystkim jest to olbrzymia zapaść kadrowa. Szacuje się, że w tym momencie na rynku pracy brakuje około 15 000 specjalistów medycyny rodzinnej. Ta liczba znacznie się zwiększy w roku 2024, kiedy wejdzie w życie nowa definicja lekarza podstawowej opieki zdrowotnej, która odbierze uprawnienia funkcjonującym dzisiaj lekarzom internistom i pediatrom w podstawowej opiece zdrowotnej. Kolejnym problemem jest demografia. Widzimy starzenie się społeczeństwa, widzimy gwałtowny skok chorób cywilizacyjnych i trzecim takim wyzwaniem, które stoi przed nami, jest cyfryzacja, czyli dostosowanie tego, co mamy, dosyć archaicznej, jeszcze jak na warunki przynajmniej europejskie, dokumentacji medycznej i systemów informatycznych, które są też niejednolite, w taki system, który byłby funkcjonalny i w każdym właściwie miejscu uniwersalny. Teraz tak, 2 słowa, czym jest ta medycyna. Jest to wykorzystanie technologii informacyjno-komunikacyjnych do transferu danych medycznych z jednego miejsca do innego celem polepszenia stanu zdrowia. Ma ona stanowić wsparcie dla personelu medycznego i jest szeroko stosowana w poszczególnych specjalizacjach lekarskich. Tutaj jedno słowo jeszcze takie, żebyśmy nie traktowali 1 do 1 telemedycyny i sztucznej inteligencji. One oczywiście się przenikają. To wszystko są sprawy, które jakby czerpią z siebie nawzajem, natomiast jakby sztuczna inteligencja jest zupełnie czymś niezależnym od telemedycyny, natomiast często występują razem. I tutaj widzimy na kolejnym slajdzie, jakie gałęzie wchodzą w skład tej telemedycyny. Są to telekonsultacje, telediagnostyka, telemonitoring i tym się będziemy zajmować właśnie tymi 3 w gabinecie lekarza podstawowej opieki zdrowotnej. Kolejnymi elementami są teleoperacje, telerehabilitacja i telenauczanie. Teraz tak, jak odnosi się prawo do kwestii telekonsultacji? Cytat z ustawy o zawodzie lekarza i lekarza dentysty. Lekarz orzeka o stanie zdrowia określonej osoby po uprzednim osobistym jej zbadaniu lub zbadaniu jej za pośrednictwem systemów teleinformatycznych. Od 2015 roku mamy zmiany prawne, które regulują kwestie recepty, skierowania, zlecenia indywidualnego konta pacjenta. Natomiast pandemia i rok 2020 znacznie przyspieszył działania dotyczące telekonsultacji. Akceleracja była dosłownie olbrzymia. Wcześniej były takie plany, że każda poradnia ma mieć 2 godziny w tygodniu wyznaczone na udzielanie właśnie teleporad, natomiast marzec roku 2020 zmienił to wszystko, gdzie teleporady stały się powszechnym sposobem udzielania konsultacji w gabinecie lekarza podstawowej opieki zdrowotnej. I teraz właśnie wnioski z tego badania. Ministerstwo Zdrowia wraz z Narodowym Funduszem Zdrowia przeprowadziły badania w dniach 7 lipca, 1 sierpnia 2020 roku dotyczący teleporad udzielanych w gabinecie lekarza podstawowej opieki zdrowotnej. Około 70% badanych stanowiły osoby powyżej 45 roku życia, z czego osoby w wieku emerytalnym powyżej 30%. I teraz spójrzmy na wyniki. Z teleporady korzystało 81% pacjentów i zobaczmy sobie na drugi wykres. Zadowolenie, czyli rozwiązanie problemu, zgłosiło powyżej 90% pacjentów. Zobaczmy teraz, jakie są wnioski z badania. Generalnie odbiór teleporad był pozytywny, przynajmniej w tym początkowym okresie. Później się to troszeczkę zmieniło. Jest to potrzebny i wartościowy kanał kontaktu z lekarzem podstawowej opieki zdrowotnej. Badanie absolutnie nie potwierdziło obaw, że osoby starsze nie poradzą sobie przy teleporadzie. I dwie rzeczy na przyszłość. Dla zwiększenia poziomu satysfakcji pacjentów należy skupić się na udoskonaleniu możliwości skontaktowania się z przychodnią, dlatego że większość uwag, które były zgłaszane przez tych pacjentów, te 10% pacjentów niezadowolonych, dotyczyło trudności w skontaktowaniu się z przychodnią. Najczęściej był to problem z dodzwonieniem się, a także przekazywania pełnej, wyczerpującej informacji na temat procesu leczenia pacjentowi oraz wszystkich niezbędnych dokumentów podczas teleporady. W tym momencie jest to kod. Niestety od 3 dni mamy obowiązek w e-zleceniu wydać zlecenie papierowe. Zostało to cofnięte. Musimy to dalej robić w formie papierowej, natomiast funkcjonowało to przez ponad rok w formie elektronicznej. Należy skupić się na systematycznym upowszechnianiu i doskonaleniu teleporad, co wpłynie na poprawę opieki nad pacjentem, zwiększenie dostępności do zespołu podstawowej opieki zdrowotnej oraz umożliwi wdrażanie kolejnych nowoczesnych rozwiązań telemedycznych w podstawowej opiece zdrowotnej. To troszkę było administracji, teraz będzie medycyna. Zobaczmy sobie, tak, to jest jedno z wyzwań, o których mówiłem, choroby cywilizacyjne. Skupię się na chorobach somatycznych, ponieważ tymi się w swojej praktyce zajmuję. Są to choroby układu krążenia, nowotwory, alergie, niektóre choroby zakaźne, choroby przewodu pokarmowego, nerek i inne choroby dotyczące, tutaj cukrzyca i otyłość, bardzo ważne. Są to dwie choroby, które teraz no niestety no są bodajże najczęstszymi razem z chorobami układu ciśnienia, z którymi mamy do czynienia w gabinecie podstawowej opieki zdrowotnej. I teraz zobaczmy jedną rzecz. Na szarych polach mamy wymienione czynniki ryzyka. Są to czynniki ryzyka w głównej mierze modyfikowalne, więc na etapie podstawowej opieki, przed jeszcze rozwinięciem się chorób, mamy możliwość zmniejszenia ryzyka zapadalności na choroby cywilizacyjne właśnie przez redukcję modyfikowalnych czynników ryzyka, co jest bardzo ważne. I teraz zobaczmy. Aby to zrobić, mamy jedno bardzo ciekawe narzędzie. Jest to ISTELCare, który pozwala nam monitorować zdalnie poziom glukozy, ciśnienie krwi, analizę składu ciała, temperaturę oraz badanie EKG. Jest to platforma, z której mogą korzystać zarówno lekarze, pacjenci, jak i pozostały personel medyczny przychodni. Jest to bardzo funkcjonalne, można z tego korzystać na wielu urządzeniach w dowolnym właściwie miejscu. Jest to aplikacja online i tutaj zobaczmy. Wyniki pomiarów przedstawione są w postaci wykresów, w postaci tabelek. Wszystko mamy już właściwie podane, gotowe na tacy. Jest to gotowa analiza wyników badań. Możemy dowolnie dobierać sobie filtry, okresy. Możemy też wybierać wartości nieprawidłowe, dzienniczek godzinowy. Jest to bardzo ważne, szczególnie przy na przykład optymalnym leczeniu cukrzycy. I zobaczmy sobie teraz. System ISTELCare zapewnia szybki dostęp do wszystkich pomiarów pacjenta. Pomiary zapisują się automatycznie. Urządzenia, jeszcze później pokażę te urządzenia, które są kompatybilne z programem, łączą się za pomocą Bluetooth z telefonem, w którym jest aplikacja pacjenta. I wykresy dotyczą ambulatoryjnego pomiaru glikemii, są to wykresy liniowe, odchyleń standardowych, wykres kołowy, więc nadają się te badania także do badań klinicznych, jeżeli ktoś w POZ-cie, a są takie osoby, które w POZ-cie prowadzą badania kliniczne, więc tu jest gotowe narzędzie, które dostarcza nam już przetworzone informacje. Są także alerty pacjentów, zebrane w jednym miejscu wszystkie powiadomienia o niewłaściwych wynikach pacjentów, czyli lekarz, który otwiera tę aplikację, nie musi szukać, prawda, po kolei, tylko widzi, co u każdego pacjenta dzieje się podejrzanego i może zareagować podczas kolejnej wizyty lub też sam umówić taką wizytę. Zobaczmy teraz. System ISTELCare jest to innowacyjne rozwiązanie telemedyczne, które umożliwia zdalną opiekę. Jest to holistyczne i kompleksowe podejście, spojrzenie na zdrowie pacjenta. Pomiary z wielu urządzeń są dostępne w jednym miejscu. Dostęp do systemu jest bezpłatny. Jest ono połączone z innymi aplikacjami producenta. Produkt jest polski, firma jest polska. Powstaje we współpracy z lekarzami i gwarantuje wysokie bezpieczeństwo. Tutaj mam na myśli także bezpieczeństwo dotyczące ochrony danych osobowych. Zobaczmy sobie teraz gamę produktów, które współpracują z systemem. Jest to pełny profil glukometrów. Glukometry bardzo popularne na rynku polskim, bardzo często używane, ale jest to także rejestrator EKG, taki do użytku przez pacjenta, nie jest wymagana tutaj jakby pomoc personelu wykwalifikowanego w obsłudze tego urządzenia. Jest to termometr, analizator składu masy ciała i ciśnieniomierz, czyli zobaczmy, wszystkie te rzeczy, które są dosłownie podstawą, takie podstawowe pomiary są zbierane i analizowane pod kątem właśnie występowania czynników ryzyka i optymalnej kontroli chorób, które już występują. Czyli mamy tą profilaktykę pierwszo- i drugorzędową. Ja bardzo cenię i bardzo jestem pełen podziwu dla naszych kolegów, na przykład kardiologów inwazyjnych za to, że tak wspaniale robią zabiegi naczyniowe, na naczyniach wieńcowych. Natomiast zobaczmy, spójrzmy na to trochę z innej strony, o co nam chodzi w medycynie. Czy bardziej o to, żeby świetnie ratować zawały, czy bardziej o to, żeby ten nasz pacjent w ogóle na zawał nie zapadł. Więc to jest nasza rola. To jest rola lekarzy podstawowej opieki zdrowotnej, żeby pacjenta poprowadzić w taki sposób, żeby on uniknął konieczności tego leczenia wysokospecjalistycznego. Zobaczmy teraz sobie korzyści właściwie dla lekarza, dla pracowników ochrony zdrowia. Pomiary wszystkich pacjentów w jednym miejscu, dostęp do wyników jest szybki i jest możliwy z dowolnego urządzenia i w dowolnym momencie, oby tylko było połączenie z internetem. To przekłada się na poprawę efektywności leczenia dzięki większej ilości informacji o stanie zdrowia pacjenta, lepszy kontakt z pacjentem, który wymaga większej uwagi, u którego te parametry są gorsze i wymagają modyfikacji leczenia, a także skrócenie czasu wizyty. Bo my te wyniki już mamy przeanalizowane, my nie musimy sami się nad nimi pochylać, my już mamy gotowy produkt w postaci analizy wyniku. I zobaczmy sobie teraz na przykładzie, jak taki system wpływa na poprawę zdrowia pacjentów. Wykazano obniżenie parametru hemoglobiny glikowanej w krótkim spektrum poniżej 3 miesięcy oraz długoterminowym powyżej 12 miesięcy. I tak, w tym okresie 6 miesięcy jest to spadek z 3,7 do 6,9% oraz w okresie dłuższym z 8,3 do 7,4%. Przekłada się to także na spadek ciśnienia tętniczego oraz poziomu cholesterolu LDL, który jest naszym głównym celem terapeutycznym w leczeniu zaburzeń lipidowych. W porównaniu do pacjentów objętych tradycyjną metodą leczenia cukrzycy. Kolejnym efektem jest zwiększenie dostępności do profesjonalnej opieki diabetologicznej, wspomaganie edukacji pacjentów diabetologicznych oraz umożliwienie efektywnej kontynuacji opieki zdrowotnej. I już tak podsumowując mój wykład, jakie są główne cele i wyzwania dotyczące telemedycyny? Jest to odbiór społeczny i edukacja pacjentów, dostosowanie rozwiązań telemedycznych do potrzeb personelu medycznego, kwestie umocowań prawnych telemedycyny oraz jest to narzędzie do wprowadzenia koordynowanej opieki zdrowotnej. Dziękuję serdecznie Państwu za uwagę. Jeżeli są jakieś pytania, to chętnie odpowiem. Dziękuję serdecznie.
Thank you very much. The Queen of Medical Sciences, known to everyone, has once again risen to the challenge. What does her sister, surgery, have to say about it? Does it too fit into the realities of the 21st century and offer us innovative solutions? The last speaker of today's event, Dr. Michał Terpiłowski, is ahead of us.
Is presentation is visible? Okay. Okay, hello everyone. My name is Michał Trapiłowski. I am representative of the chair and department of vascular surgery and angiology in Lublin. I would like to present a lecture entitled Modern Methods of Treatment of Chronic Venous Disease of the Lower Limbs. Normally, the veins carry blood from the lower extremities up towards the heart. To ensure that the blood flows in one direction, the veins are equipped with valves to prevent the blood from flowing back. Venous reflux causes blood stagnation in the veins of the limbs, increased pressure of the vein wall, and thus their gradual widening and bulging, i.e. varicose veins, as you can see at the video. Venous changes appear on the legs, at first small, up to 1 millimeter in diameter, blue hair-like veins, which is called telangiectasia. Later, a little wider, up to 3 millimeters in diameter, reticular veins, or even larger, tortuous widening of veins, varicose veins. The next stage in the development of CVD are skin changes on the lower legs, discoloration, eczema, skin inflammation, hardening, and atrophy of the skin. Collectively, we refer to them as atrophic changes. The most advanced symptoms of venous disease is venous leg ulceration, stage 6. In a study assessing the incidence of chronic venous disease, this problem concerned almost half of adult Poles, 51 of women and 38 of men. In addition, varicose veins of the lower extremities are present in about 35% of adults. 62 of chronic venous disease patients had never been treated for it before. Only 1 in 4 was under treatment. The study among the adult Polish population on the source of knowledge on varicose veins of the lower extremities shows that patients obtain information of this subject from the mass media much more often than the general practitioners. As you can see, almost half of the responders learn from television, advertising, the internet, or family members, and just 20% get knowledge from their physicians. Among the responders, the most common methods of reducing symptoms are elevation of the limb, use of ointments, dietary supplements, or cold compress. However, surgical procedures, invasive or non-invasive, account for only 5%. Varicose veins of the vena saphena magna and vena saphena parva is the most common form of varicose veins, causing discomfort. They are most often visible on the medial surface of the limb in the case of varicose veins of the vena saphena magna, or on the back of the calf in the case of varicose veins of the vena saphena parva. Varicose veins can also affect perforators, i.e. venous vessels, in the form of a bridge, connecting the superficial veins with deep veins. There may be more than 100 perforators on one limb. If varicose veins or other symptoms of chronic venous disease are present, Doppler ultrasound of the lower extremity venous system should be performed, and it's a gold diagnostic standard. This examination helps to locate insufficient veins and plan further treatment. The Doppler triplex test allows the assessment of the efficiency of venous valves. Here's an example of healthy and efficient venous valves with no reflux visible in the flow spectrum. In this case, venous reflux is visible, which is a sign of venous insufficiency. Moreover, Doppler ultrasound allows to verify symptoms if there is a suspicion of past thrombosis, trauma, or another vascular disease. Here is an example of thrombosis. Interestingly, that is, in this case, the thrombus is located approximately 10 centimeters above the discoloration on the skin, which was marked by pen I'm not sure that is visible here. I don't have pointer. Sorry, it's hard to, but it's about 10 centimeters above this discoloration, so it's not in the same area. After examining this point, let's turn to treatment methods. We can distinguish surgical stripping, thermal intravenous methods, and non-thermal intravenous methods. In the next part of the presentation, I will describe each part of the treatment options. Here on this slide on the right is the trend of choosing CVD treatment. The number of invasive surgeries, the purple one, performed is significantly reduced, and orange and blue is non-thermal and thermal methods, and they are rising. That is the trend. Until the turn of the 20th and 21st centuries, the only method of treating varicose veins was the Babcock's operation. It consisted of pulling a vein with a steel probe. Moreover, varicose veins were turned out or tied from incisions of a few centimeters long. It is a bloody method. After the procedure, keloids, local infection, hematomas, phlebitis, lymphorrhea, or sensory disturbances in the skin may occur. It is important to perform a thorough ultrasound diagnosis before the operation and to use the correct techniques of the operation with minimal traumatization of tissues. Nowadays, the most commonly used method is thermal intravenous ablation of ineffective superficial veins by means of a diode laser, radio waves, or water vapor. It is a non-surgical, minimally invasive method of treating varicose veins. It is performed on an outpatient basis under local anesthesia, takes about 30 to 40 minutes. The patient can return home after another 30 minutes. After the procedure, it consists in making a small 2 millimeters puncture of the tight or shin skin through which the optical fiber, radio wave, or steam catheter is inserted. Here you can see animation of radio frequency ablation. Recent years have seen the development of laser techniques and system in the treatment of CVD. The greatest technological breakthrough in intravenous laser ablation has occurred in the last few years. The wavelength of laser light use has been optimized and optical fibers have been created, which increase the effectiveness and safety of the treatment. 1940 nanometers lasers are currently the most advanced venous lasers. This allows for the perfect elimination of diseased vessel, saving the surrounding tissues. Here we can see effects of thermal ablation of the vein. On the left you can see effect right after procedure, in the middle right 1 month after treatment, and on the right 2 months after the procedure. The complications of this method are mainly hematomas or hyperpigmentation during ablation, but also a small percentage of skin burns or nerve damage. A specific type of thrombosis that may occur after thermal ablation is endothermal heat-induced thrombosis, EHIT, in Polish we call it EHIT. It may affect up to 7% of patients. Now let's turn to non-thermal methods. Clarivane is one of the minimally invasive non-thermal methods. After placing the tip near the connection of the damaged superficial vein with a deep vein, a rotary mechanism activated that rotates the tip of the catheter. The vascular endothelium of the damaged vein is irritated. During the slow pulling of the catheter, sclerosant is injected into the lumen of the vein, which leads to the obliteration of the vein, as you can see on this animation. As I said, the tip is rotating, and during rotating, the endothelium is irritated, and the sclerosant is injected at the tip of catheter. And after this procedure, the vein is obliterating and absorbed in a few weeks. The biggest limitation of this method is ability to close the lumen of the vein with diameter of up to 12 millimeters. And the Clarivane improvement is the phlebograph system. It is a catheter through which the sclerotizing foam is inserted into the lumen of the saphenous vein. At the end of the catheter, there are metal claws that damage the vein wall, which causes contraction and intensifies the effect of the sclerosant. On the right, you can see animation how phlebograph works. As I said, the effectiveness of the cutting parts penetrating the vein wall is visible on the left. We can see Microsoft shot showing the depth of penetration of the cutting parts deep into the endothelium. And the sclerosant penetrates whole layers of endothelium thanks to that cutting parts. While permanent fibrosis of the vein in classic sclerotherapy is estimated at 70%, according to the research carried out, among others, at the Department of Vascular Surgery and Angiology in Lublin, it amounts to over 90% in 2 years follow-up. Here are examples of effects of phlebograph after 3 months. The results are very encouraging. It is an outpatient procedure without anesthesia, cuts, or scars. Patient can go back to work the next day after the procedure, and in addition, phlebograph can be used in vessels with larger diameters, better than Clarivane system. The newest method, approved by FDA since 2015, is non-thermal treatment of insufficient vein with tissue glue. The procedure is performed on an outpatient basis and consists in injecting a portion of special glue into the diseased vein, which connects the walls of the veins together, as you can see on this animation. As a result, blood stops circulating in the treated vein, which leads to its fibrosis and absorption. The procedure is performed under ultrasound control. The patient may return to his daily activities immediately after procedure. So the glue is injected, and step by step, the vein is glued. The 12-month follow-up shows the effectiveness of this method at over 95%. The limitation is the amount of glue in a single set. Not every time it is enough glue because of diameter of vessel. And opening another set with glue doubles the cost of the procedure. So that's the main limitation of this method, because results are really impressive. Sclerotherapy is another non-thermal method. It consists in applying a sclerosing agent in the foam to the dilated vein, which causes the vessel to close and exclude it from the bloodstream. It is a method much less invasive and safer than surgery for varicose veins. Due to technological progress, this procedure can be performed under ultrasound control, so-called echosclerotherapy, which additionally increase the safety and therapeutic effectiveness on this method. This recording shows the moment of injection and administration of sclerosant to the perforator. We can see the needle, the injection into the vein, and administration of substance. Here we can see an impressive recording by Professor Piotr Terlecki. The sclerosant containing foam spreads through spider veins, causing them to obliterate. yeah, really impressive example of sclerotherapy. Complications after this procedure include primarily hyperpigmentation in the place where the sclerosant comes in contact with the patient's tissue, but also neotelangiectasia. Skin necrosis or allergic reactions are extremely rare. And to sum up my lecture, percutaneous intravenous ablation techniques are a modern and effective methods of treating CVD. Due to its high efficiency and low of complications, thermal ablations are strongly recommended by International Scientific Society as a treatment of choice. Non-thermal ablation, such as glue treatment or Phlebogrif, Clarivane, becoming more and more popular among patients due to their minimal invasiveness. But due to the lack of long-term follow-up, they require further research. Thank you for your attention. Here are some photo shoots from Phlebology Academy organized by our clinic, where young vascular surgeons train and learn how to treat superficial and deep veins. Thank you.
Thank you very much. Are there any questions to the doctor?
Thank you.
Thank you. Dear participants, slowly our ceremony and lecture panel is coming to an end. We would like to sincerely thank you for coming and being present via internet. We warmly encourage you to watch the scientific sessions and participate in the workshops and other attractions.
Today's session include internal medicine, general medicine, surgery, gynecology, pediatrics, and neurology, psychiatry. The workshops take place in 3 rounds, plus you are warmly invited to visit the diagnosis and eye examination stands. Lunch break is scheduled for today from 1 p.m. to 2 p.m. and the evening will be rounded off with a banquet at Hotel Ilan.
For a detailed schedule, including the one for tomorrow, please visit our social media, where we constantly provide the latest news and updates.
We wish you all a successful conference and a pleasant time in Lublin and within the walls of our university. Thank you very much.
session within the 21st Century Medicine International Medical Congress for Students and Young Doctors. The conference is organized by Young Medics organization at the Medical University of Lublin and the
Members are Doctor of Medical Sciences Agata Michalak and Doctor of Medical Sciences Sławomir Mozul.
Before we start the first prelection, let me remind you principles and rules of presentation. Speakers on site will have their presentation turned on by the session leaders. Presenters are asked to deliver their presentation in front of the lectern. Speakers online are obliged to share their presentation on their own. In case of technical problems, we have your PowerPoint on our computer, so we will share it with all participants during your prelection. In the moment you want to change the slide, just say it like the next one. The oral presentation of the original work may last no longer than 10 minutes, the discussion no longer than 3 minutes. The oral presentation of case report or review paper may last no longer than 7 minutes and discussion no longer than 2 minutes. The session coordinator reserves the right to stop the presentation or discussion in the event of exceeding the time limit. At the beginning of the last minute, we will inform you about this fact, but by special sound.
Okay. The online presenting person must be equipped with a computer or tablet with operable camera and microphone. The camera should show the view of the participant, including the whole face and upper limbs. The presenting person is not allowed to move out from the camera view and mute the microphone during the whole time of presentation, discussion, and the time between presentation and discussion. In case the presentation transmission is interrupted and less than 60% of given time has passed, the participant is allowed to come out again at the end of the current session. If more than 60% of the given time has passed, the presentation is evaluated and the participant is not allowed to answer the questions at the end of the current session. And the last rule concerning the assessment criteria obeyed by the scientific committee. Assessment will include the following: the summary, relevance of the topic, the use of research in practice, diligence of presentation, language of presentation, time limit, and discussion.
These are official rules that we need to observe. Do you have any questions or something is unclear? We would be glad to answer any doubts you might have.
The first work, entitled Study of Various Risk Factors in Adult Patients of Glaucoma in a Tertiary Care Hospital, will be presented by Ms. Kavisha Goswami.
Good morning. Am I audible? Yes, we can hear you.
Is my screen visible?
Yes. But we need your presentation.
Is it visible now?
Yeah, we can see that you are starting to turn it on.
Can I start now?
But we can only see the files. We cannot see the presentation.
I have already started the presentation. It's not visible, is it?
Not visible still. Oh,
How
now we
about
can
now?
see. Yeah, we can see.
All right.
Okay, it changes. Thank you very much.
Fine. Okay, good morning, one and all. I am Dr. Kavisha Goswami from India, and I'm here to present my study called Study of Various Risk Factors in Adult Patients of Glaucoma in a Tertiary Care Hospital. As we all know, the classic definition of glaucoma is that it's a multifactorial, idiopathic, progressive optic disc neuropathy, which shows characteristic optic disc and visual field changes, with a high intraocular pressure being the principal risk factor. There are various types of glaucoma, the primary ones being primary open angle and primary angle closure glaucoma, and there are some others, such as normal tension and secondary glaucomas as well. There are various risk factors for glaucoma, such as elevated intraocular pressure, which is more than 21 millimeters of mercury, family history, myopia, hypertension, diabetes, and all of them being others. Testing includes intraocular pressure measurement by tonometry, visualization of the iridocorneal angle by gonioscopy, and examination of optic nerve for any visible damage or change in the CD ratio, the rim appearance, and the vascular changes. Now, why did I take up this study specifically? Because glaucoma is a disease with iceberg where majority of the cases tend to go undiagnosed and people are not even aware about the risk factors or the symptoms that they keep showing. Hence, it was also included in a Vision 2020 initiative that is a very important initiative for ocular diseases in India. Awareness about this risk factors is very less, and that is why we have to study these risk factors more and more. My study objectives include assessment of various risk factors in glaucoma patients. Now, how did we carry out this study? We selected a tertiary care hospital and we carried it out in the ophthalmology OPD. The sample size comprised of a good 158 patients of glaucoma, and we included all sorts of glaucomas in that. And the patients who were willing to give a written informed consent, only those were selected. My study was an observational cross-sectional study in the outpatient department of ophthalmology, as I stated, and the confidentiality of my data was strictly maintained. As I said, the ophthalmological comprehensive evaluation was already done before the patients were undertaken in the study. Now, how did we classify the patients? Based on the gonioscopy finding and based on the Scafford's grading, grades 3 and 4 were considered to be open angle, and grade 2 and less were considered to be occludable. Coming to my results, majority of my patients were in the age group of 51 to 60 years, with 56 years being the mean age group. Most of them were male patients, and symptomatology showed me that the most common symptom apart from the others was blurring of vision, but it is also very important to note that asymptomatic patients were also comprising of a good 32%. Duration of the disease, since glaucoma is a very chronic disease, we had patients with as old history as 20 years to as new history as about a few months. The earliest case was found to be about 6 months old. The results included primary open angle cases to be the most common types, and they were about 114 out of my 158 patients. Now, I would like to go for my probable risk factor evaluation in the primary open angle cases. The most important risk factors that were found to be significant included family history, alcohol intake was not significant, hypertension, diabetes, sleep apnea, use of glasses, all of them were considered to be the most significant risk factors in this study. Alcohol intake, obesity, migraine, and thyroid dysfunction were not exactly evaluated because we had very less patients with such histories. So I cannot exactly say if these are significant or not, but according to my study, they are insignificant. Now, risk factor assessment, intraocular pressure, as I said, it is the most important risk factor. The highest value in my study was recorded to be about 46 millimeters of mercury, and it was found to be raised in about 31 patients despite treatment. That is a very important finding here. Central corneal thickness, the cornea was found to be very thin in about 81% of the patients, and the CD ratio was found to be relatively raised in about 82% of the patients. Family history was positive in about 29% of them, and refractory errors were also positive in majority of the patients. Hypertensive diabetic patients also comprised of about 30% of my patient group. And use of corticosteroids, like I said, could not be established as a risk factor because only 4 of my patients were found to be using corticosteroids topically. Sleep apnea was found to be quite significant. Migraine, again, only 30 patients were having migraine, so that could also not be assessed to be significant. Smoking, alcohol, they have the same problem. We didn't have much history, many patients with such history. Same with hypothyroidism. Now I would like to go for symptom comparison. Here, like I said even before, the blurring of vision was not only the most common but most significant finding we found in our study. And apart from that, ocular pain, watering of eyes, redness, and asymptomatic patients also comprise a good amount. Now, glaucoma, like I said, it is a very important disease because it is not diagnosed properly in a majority of the cases because they tend to go unnoticed and patients are not aware about their own symptoms whenever they start showing, or they are ignorant about it. So our study was not only for risk factor comparison, but it was also to raise a bit of awareness in the society for this disease particularly. In conclusion, glaucoma is a chronic disease and the primary open-angle type is the most common subtype. Ocular risk factors and systemic risk factors, which were considered to be the most putative ones according to my study, included the high IOP, low CCT, high CD ratio, hypertension, diabetes, and sleep apnea as well. Thank you.
Thank you for the presentation. Now is the time for questions to the presenter and discussion. Questions can be asked either by members of scientific committee or by other participants interested in the topic.
Thank you for your presentation, and the topic is very interesting, maybe not so common in our everyday practice. And I've got a question according the results. Did you try to compare the ocular and systemic risk factors of the glaucoma that you were able to find in your study with the already available worldwide data? Were these risk factors similar, or you found some differences in the group of the patients that you examined?
No, ma'am. Actually, we compared many clinical trials and meta-analysis before taking up this study. So my risk factors are not very different from the already established risk factors. So if I say specifically, the ocular risk factors and the systemic risk factors, which are already established, they were showing a quite significant association in my study. But apart from then, some of those risk factors, like I said, that hypothyroidism, use of topical corticosteroids, they are also some of the established risk factors, which I could not establish a significant relationship with.
I see. Thank you for your response, respondent. Do you have any other ideas, plans to broaden the spectrum of this study?
Yes, ma'am. We are planning to go for a more intensive study because this was just an observational study because we could not do many interventions at this point. And we plan to carry this study further, and we plan to include certain interventions such as reducing the intraocular pressure significantly because, like I said, some of the patients still don't see any change in their intraocular pressure findings after treatment. Apart from that, hypertensive diabetic patients have to be really, controlling their values. So we will like to go for a multi-system approach for this as well. We would like to incorporate other specialties in the study as well.
Okay, thanks a lot and good luck in your next surveys. Thank you.
Thank you. Thank you so much, ma'am.
Another question more, please. Although patients with glaucoma are treated, some of them developed completely blindness. Could you tell me how many people, the percentage of these patients developed completely blindness at all? Thank you very much.
Yes, sir. Sir, in my 3-month period of my study, we included those patients who were not having the end stage complication. But apart from that, if I tend to put a tentative figure, I would like to say that out of about 50 patients, if I see per day, out of them, 2 tend to develop at least a very critical stage of the end, very critical end stage disease.
Thank you very much. Thank you.
Thank you so much, sir.
Thank you for the discussion. So I think we can carry on. Now I would like to invite Ms. Adrianna Przydborska to present her work entitled Pulmonary Arterial Hypertension, Rare Does Not Mean Unimportant.
Good morning, everybody. So is my presentation visible?
Yes.
Okay, so good morning, ladies and gentlemen, again. My name is Adrianna Przydborska, and today I'm going to present a case report titled Pulmonary Arterial Hypertension, Rare Does Not Mean Unimportant. So the cause of the case was a 29-year-old female patient. She was suffering from impaired exercise capacity, exertional dyspnea, and decreased endurance. She had also a history of several syncops following physical activity. As she was not treated with any chronic diseases previously, such symptoms seemed unusual for a young patient. Hence, the diagnosing process has begun. First was the physical examination, which showed none of the abnormalities apart from a quiet hollow systolic murmur above the heart on the auscultation. The next step were the laboratory tests. As the results came in, the increased level of the NT-proBNP indicator seemed alarming. Taking into the consideration the normal range, it was nearly 3 times higher than the accurate limit. NT-proBNP, which is an indicator of heart failure, led the doctors to the most possible cause of the symptoms. However, there was an unspoken question. How come the young patient could be suffering from heart failure? Hence, further studies were conducted, starting with the radiological imaging, which showed the pairing of the peripheral vessels, central pulmonary arterial dilatation, and there was no excessive fluid in the pleural cavity detected. The next study was the EKG, which was indicative of the right ventricular hypertrophy. The last, but definitely not least, in this study, the most useful imaging study was the echocardiography, as the doctor have already suspected the most possible cause of the symptoms. According to the previous test results, some specific parameters were assessed, starting with the assessment of the ventricles, the pulmonary trunk, right atrium, and the assessment of the inferior vena cava. The key to diagnose the pulmonary hypertension within the use of echo is the estimation of the mean pulmonary arterial pressure. In this case, it was 70 millimeters mercury, which is, according to the guidelines, highly above the normal range. In way to assess this parameter, other measurements needed to be taken, such as the TRPG, and the estimation of the pressure in the right atrium was also required. At this moment of the diagnosing process, the diagnosis was almost certain. However, other cardiac parameters were measured, aiming to find out how severe the heart failure was. The further cardiac measurements were indicative of the right ventricle hypertrophy with the signs of pressure overload. And however, in the left ventricle, no abnormalities were detected. Now, coming from the theory to practice, I'm going to discuss more precisely the most valuable echo projections, starting with the parasternal projection, which is indicative of the hypertrophy. Then we can see the hypertrophy, also the hypertrophy in the parasternal axial projection. We can see the enlarged lumen of the right ventricle and the right atrium. This echo is one of the most significant projections as within the use of the continuous wave Doppler, the tricuspid regurgitation velocity was measured and the TRPG. These are the key parameters in way to estimate the mean pulmonary arterial pressure, which is a key parameter to estimate the pulmonary hypertension risk within the use of echo. On the other presentation, we can see the enlarged pulmonary trunk, which is an additionally pulmonary hypertension indicator. Here is the other really significant projection. We can see here the inferior vena cava. The main features that are visible on the first notice are the dilated lumen of the vessel and the poor respiratory compliance. These characteristics enable the doctors to estimate the pressure in the right atrium to 15 millimeters mercury. And on this projection, we can see one of the most accessible and therefore useful indicators, that tricuspid annulus plane systolic excursion, which is conducted in the axial position in N-mode projection. It's 17 millimeters, which is the lower norm. However, the most accurate values are around 20. 17 millimeters is standing for impaired systolic capacity of the right ventricle. And here we can see enlarged hypertrophic free wall of the right ventricle is 12 millimeters, whereas the norm is below 6. And on the last echo projection, we can see the flattening of an intraventricular septum and the excessive amount of fluid in the pericardial sac. Coming to the conclusion, echo enabled us to estimate the risk of pulmonary hypertension as the tricuspid regurgitation velocity was above 3.4. Other echocardiological indicators weren't necessary, however, they also occurred, and the risk was risk of echocardiological pulmonary hypertension was estimated as high. As the risk was high, the next obligative and the last procedure to set the final diagnosis was the right heart catheterization, which, according to the gathered information, went well and was indicative of the pulmonary arterial hypertension. I'm so sorry. According to the newest definition, pulmonary hypertension is a condition when the mean pulmonary arterial pressure exceeds over 20 millimeters mercury. Pulmonary arterial hypertension is a subgroup of pulmonary hypertension. It can be caused by many factors such as genetics, induced by toxins or medicines. It can be related to parasite diseases, and as in this case, it can also be idiopathic. Thank you very much for your attention.
Thank you for your presentation. Now it's time for discussion.
Okay.
Thank you very much for your presentation, very nice. You show us a lot of difficult parameters, but what you say, which parameter is the most important from all of them? Maybe from catheterization, yes, of cardiac artery, pulmonary arteries, please.
But in the echocardiology or apart from it? Because in my opinion, the echo is most valuable in this case. Sorry, I didn't catch that.
Which of all of parameters you show us is the most important to diagnose this illness?
Okay, so in my opinion is the tricuspid regurgitation velocity, which later enabled us to within the use of the simplified Bernoulli equation to count the TRPG, which is a tricuspid regurgitation peak gradient. And within these two parameters, it's possible to assess the medium pulmonary mean pulmonary arterial hypertension, and then we can assess the risk within these two parameters and set further treatment and other diagnosing examinations.
Thank you very much.
And could you tell us just in general what kind of possibilities of the treatment can we offer the patients with pulmonary hypertension, just in general?
So within the pulmonary arterial hypertension, we can treat the patients with some diuretic medicines that are aimed to reduce the pressure. There is also a possibility to treat them with some calcium blockers, and in some severe case, there is also the transplantation as the most effective treatment, the pulmonary transplantation.
Okay, thank you for your presentation. Thanks a lot.
Thank you very much.
Thank you for the discussion. Now I would like to invite Ms. Gunda Skudrina to present her work, a case report of acute myocardial infarction caused by bleeding peptic ulcer.
Hello.
Hello.
Where can I don't know where can I put my presentation. Ah, okay, I found it. Can you see my presentation?
Yeah, you can.
Yes? Is it visible?
Yeah, we can see your screen.
Okay, thank you. Good morning, everyone. My name is Gunda Skudrina, and today I'm going to present my case report of acute myocardial infarction caused by bleeding peptic ulcer. So myocardial infarction, or MI, associated with gastrointestinal or GI bleeding, often presents as a distinct syndrome that differs from either disease alone, and type 2 myocardial infarction may arise in the context of various acute medical and surgical conditions, and it is defined as a myocardial infarction secondary to ischemia due to either increased oxygen demand or decreased supply, for example, coronary artery spasm, anemia, arrhythmias, and so on. So it is not uncommon for patients with acute myocardial infarction to be complicated by upper GI lesions or vice versa, and accordingly, when physicians treat such patients, both possibilities should be excluded as soon as possible. So it is really essential to perform an ECG.
I'm sorry for interrupting, but the slides doesn't change.
Okay.
I'm sorry.
So yes. No, you can see.
Still the first slide.
And no, you can see case report, the patient and 82 years old.
No, maybe you can share one more time, and you don't have to.
Okay, I'm really sorry. Now you can see.
We can see the presentation, but you changed the slide?
Yes, now is a case report, the patient 82. No?
No. So maybe we will, yeah, maybe you can just change, now we can see background.
And background?
Background, yeah.
No, you see my
Yeah,
presentation?
yeah, yeah, yeah. And you can just
Okay.
click. It doesn't have to be
Okay.
a show. Yeah.
Okay, okay, I'm really sorry. So moving on, it is really essential to perform ECG and troponin levels before upper endoscopy. So my patient was an 82 years old woman who was brought by her daughter to the emergency department because of melena and infrequent vomiting for 2 days. And in addition, the patient complained of fatigue and dizziness for 1 month. And the important medical history included coronary heart disease, arterial hypertension, heart failure, and lumbar radiculopathy. And her everyday medications was rivaroxaban, torsemide, and also non-steroidal anti-inflammatory drugs like ibuprofen. So upon arrival in emergency department, her blood pressure was 100 to 65, heart rate was tachycardia, and respiratory rate was 16 per minute. Heart sounds were normal on auscultation with no audible murmurs, and the rest of clinical examination was unremarkable. And the ECG showed, as I mentioned, sinus tachycardia with left bundle branch black, and complete blood count was significant for low hemoglobin. Here we can see this blood work, and I want to add that at this moment her troponin levels were absolutely normal. So she was intravenously infused with a crystalloid solution, transfused 4 units of packed erythrocytes, and also administered proton pump inhibitors. And the patient was hospitalized in the gastroenterology department, and during the next few days she received symptomatic treatment because he was unstable at this moment, and therefore endoscopy was delayed until her hemoglobin will reach 90 grams per liter. So on the day 3 of hospitalization, the patient experienced sudden shortness of breath, and we ordered the CT angiography because we thought it will be a pulmonary embolism. But here are the results. Here was a perfusion defect in the proximal and middle segment of the lateral and basal well. So we ordered also blood work where we can see there was a really high sensitive troponin, at this moment a cardiologist was obtained, and it was decided not to perform emergency coronography because the patient was unstable also at this moment, and we continued to raise up her hemoglobin levels, and there are medications was recommended by cardiologist. It was metoprolol and amlodipine, torsemide, also enalapril, and bisorbid mononitrate. So she received this symptomatic treatment until her hemoglobin was were sufficient enough to perform this upper endoscopy. It was day 14, and here was ulcer who was detected. It was by Forest 2C, and on the day 15 we performed also coronary angiography, and there was no significant findings in the coronary arteries. Unfortunately, I don't have photos, so what I can show you because I haven't access to these photos from coronary angiography. But yes, we discharged the patient from hospital after 3 weeks. With the following treatment plan. It was no symptomatic treatment, and as I mentioned in the start, that she have also coronary heart disease, so there was also this rosuvastatin because she have also a high hypercholesterolemia, yes, and edoxaban to prevent further these cardiac complications. And also we recommended her to perform control echo and Holter after a month and repeat the every blood analysis, and then we came back with these results to cardiologist and also repeat upper endoscopy with advice of gastroenterologist. And here are her laboratory when we discharged her. As we can see, hemoglobin is better. Yes, it's 111 at this time, and yes, she had also BNP a little higher at this moment, and here we can see a low density lipoprotein with 3.3. Our case showed that myocardial infarction could be missed in the case of GI bleeding, as the symptoms of MI are overshadowed by severe bleeding. And GI bleeding can lead to myocardial infarction from hypovolemia and myocardial hypoperfusion. And in this case draws attention to not forget about these cardiac complications of GI bleeding and be really cautious about determining the correct type of MI, because it also could be a first type of heart attack. So why it is important? Because the optimal therapy for each MI type is quite different combined with GI bleeding. Yes, so that's all. Thank you for attention, and sorry for these problems with my presentation.
No problem. Thank you very much for the presentation. And now it's time for questions.
Thank you for your presentation, and from clinical point of view it's really essential because we hospitalize such patients with the complications of antiplatelet, antithrombotic therapies with bleeding from GI tract quite often. And I've got a question concerning the best option of the treatment in patients with a history of previous bleedings from the GI tract, in some kind of cardiovascular indications to continue for the continuation of the antithrombotic treatment. And maybe do you know what kind of the drugs, what a certain type is the safest option in such circumstances?
Thank you for your question. In my opinion, it could be edoxaban probably, and of course we can't prescribe aspirin, but it could. I think the best option would be edoxaban as an anticoagulation.
Yes, edoxaban or apixaban, but that's right. And I've got a question according to the results of this patient, because I noticed that she had a quite low level of MCV. Did you assess the concentration of the iron in the blood?
Oh no, sorry.
Because I didn't notice this result, and I was just curious about it.
Yes, iron also was low, but I don't remember, and I didn't put in this presentation. I don't know why.
Because in these elderly patients, sometimes we observe coexistence of some kind of deficiency as the background of the anemia and the presence of active bleeding from the GI tract. Okay, and thank you for your response. Okay, and thank you for your presentation.
Thank you.
Okay, thank you very much one more time. And now I would like to invite Ms. Małgorzata Biernikowicz to present her work, latest therapy option in cystic fibrosis, elexacaftor, tizafactor, ivacaftor.
Hello, can you hear me?
Yes, we can hear you.
And can you see the presentation?
Yes, of course.
Okay. Hello, my name is Małgorzata Biernikowicz. I'm a fourth-year medical student at Jagiellonian University in Krakow. And let me just begin by saying that it is such an opportunity, an honor to have this opportunity to take part in this conference. And today with my colleague, I have prepared a presentation on the topic of elexacaftor, tezacaftor, and ivacaftor, which is a new type of medication used in the treatment of cystic fibrosis. So as you may know, cystic fibrosis is the most prevalent autosomal recessive disease among the Caucasian race. And nowadays, more than 70,000 people worldwide suffer from this disease. And it is caused by mutations in the CFTR protein. And this mutation is responsible for the dysfunction in many organs of the human body. So, for example, lungs, pancreas, gastrointestinal tract, and male reproductive organs, just to name a few. So there are several different types of CFTR mutations, and the most common one is F508del mutation. And up to 90% of patients with cystic fibrosis have this type of mutation. And this mutation causes class 2 defect, so a trafficking defect. It also causes reduced activity, so a class 3 mutation, and it affects the protein stability at the plasma membrane level, so a class 6 mutation. But why am I talking about F508del mutation? Because in October of 2019, elexacaftor, tezacaftor, and ivacaftor was approved as a type of treatment that can be used now in treatment with patients with cystic fibrosis who were aged at least 12 and who had at least one copy of this F508del mutation. So what exactly is elexacaftor, tezacaftor, and ivacaftor? It is a triple combination of CFTR modulators, and those can be divided into two groups. So on one hand, we have potentiators, such as ivacaftor. On the other hand, we have correctors, for example, lumacaftor, tezacaftor, and elexacaftor. Yes, and on the slide here you can see the regimen dosage, recommended dosage of that elexacaftor and ivacaftor and tezacaftor should be used. So the approval of this elexacaftor, tezacaftor, and ivacaftor treatment came from the results of 2 clinical trials. And the names and the authors of those articles based on those clinical trials you can see on the right side of the screen here. And the first clinical trial focused on patients who were homozygous for the F508del mutation. And the study found that there was an increase in the percentage of predicted FEV1 at week 4 by 10 percentage points compared to active control, which was tezacaftor and ivacaftor alone. And there was also a decrease in sweat chloride concentration by 45.1 millimole per liter. And there was an improvement in CFQR respiratory domain score at week 4 by 17.4 points. Moreover, an increase in BMI was observed. And the second study focused on patients with a single F508del mutation. And the study showed similar results. So there was also, at week 4, there was an increase in the percentage of predicted FEV1 by almost 13 percentage points. Also, there was a decreased event rate of pulmonary exacerbation by 63% per year. Also, decreased sweat chloride concentration level was observed. An improvement in CFQR respiratory domain score was observed. Other studies which have explored this particular topic have also shown similar results. The research of long-term adverse events caused by this therapy with elexacaftor, tezacaftor, and ivacaftor is still ongoing. And this study in particular enrolled patients who took part in the aforementioned clinical trials. And the study is still not finished. However, on the screen here, you can see the results of interim analysis of those side effects. And the study reported that the side effects were mostly mild or moderate. And the most commonly reported adverse events were were consistent with typical manifestations of cystic fibrosis. So patients reported, for example, infective pulmonary exacerbation of cystic fibrosis, a cough, a headache, sputum increased. Furthermore, there were no deaths observed by this treatment, and typically adverse events led to few to non-treatment discontinuations. So what more can be done now? So the challenge now is to find highly effective therapy for the remaining 10% of people with cystic fibrosis. So for the people who do not have this F508del mutation, and some studies were done on primary nasal epithelial cultures, and the studies showed that cultures from patients homozygous for M1101K mutation responded to elexacaftor, tezacaftor, and ivacaftor treatment in a way that showed promising results. Yes, and to conclude, it is undeniable that therapy with elexacaftor, tezacaftor, and ivacaftor can be beneficial for patients with 508del mutation. The cost of therapy alone is really high. It costs $24,000 per month. However, the good news is that since the 1st of March of this year, the therapy in Poland, the therapy with elexacaftor, tezacaftor, and ivacaftor in patients aged over 12 and with this at least one F508del mutation is refundable. And also, I would like to point out at the end that while this medicine can be beneficial, there is still a need for symptomatic treatments such as airway clearance. Okay. Thank you for the attention.
Thank you very much for your presentation. And now it's time for questions and discussion.
Thank you for your presentation. As regards cystic fibrosis, do you think that genetic knowledge could decide of the kind of treatment in the future? Thank you. Only genetic knowledge.
Sorry, could you repeat the question? I'm sorry.
Do you think that genetic knowledge could decide of the kind of the treatment we can use in these patients in the future?
I think so, definitely, because up to this day, before the introduction of those CFTR modulators, we mostly treated cystic fibrosis with symptomatic medicine, and nowadays, so we can treat the cause of the disease, so those mutations that cause the disease. So I think it is the future.
Thank you.
And thank you for your presentation. I think it was worth mentioning that the access to the treatment of cystic fibrosis is limited. And I've got a question from the clinical point of view, because at the beginning you mentioned that the presentation of the cystic fibrosis according GI tract concerns the pancreas. And what kind of other abnormalities within the GI tract can we observe in patients with this disease as well, except the abnormalities within the pancreas?
What other? Okay, so as you said, for the pancreas, maybe so there is this diabetes which can also occur, and maybe there are. I'm not really sure right now, but.
I think you must have read something about liver steatosis, for example, or even liver fibrosis and cirrhosis.
Yes.
Because sometimes cystic fibrosis might even constitute the indication for the liver transplantation as well. Okay, thank you one more time for your presentation and for your answers.
Thank you very much.
For the discussion, it's time for the next speaker, Mr. Łukasz Zaremski, with his work, Progression of Liver Failure in a Patient with Hepatolenticular Degeneration, Case Report. Probably Mr. Łukasz Zaremski is absent. We will come back to this presentation at the end. So I would like to invite Ms. Patrycja Niewinna to present her work, Darier's Disease, case report of a 40-year-old woman admitted to a dermatological clinic with new skin lesions on the nape, hands and soles of the feet.
Good morning. Is my presentation visible? Is my presentation visible or not?
Yes, it is visible.
Okay, thank you. My name is Patrycja Niewinna, and I would like to present case report entitled Darier Disease, case report of a 40-year-old woman admitted to a dermatology clinic with new skin lesions on the nape, hands, and soles of the feet. Okay. Darier disease is a rare autosomal dominant ganodermatosis. Skin mucosa and nail symptoms are the result of a mutation in the ATP2A2 gene located on chromosome 12q24.1. This gene is responsible for the proper functioning of the calcium pump in the endoplasmic reticulum, and its defect leads to chromosomal dysfunction and loss of connection between keratinocytes, which results in acantholysis. The disease is chronic and manifests itself by the presence of hyperkeratotic lumps and plaques located mainly in the seborrheic areas. Pointed keratosis foci are observed on the skin of the hands and feet, as well as nail lesions. Notches of the distal part of the nail plate subungual keratosis, white pink longitudinal stripes, and mucosal lesions. And information about the patient. A 40-year-old woman admitted to a dermatology clinic due to severe itching of the skin NRS 8/10 and the appearance of new skin lesions, brown papules on the nape, neck, and neckline. The pruritus appeared 2 weeks after discontinuation of neotigason. Adjacent red-brown hyperkeratotic loops were observed on the skin in the area of the popliteal fossa, soles, hands, elbows, neck, nape, and neckline. Changed skin shows the features of acantholysis and keratosis. The patient was treated from birth, and she had positive family history of Darier disease in brother, father, and father's siblings. Negative history of atopy and allergy. The patient also suffers from multiple sclerosis since 2010. She was treated with interferon. And condition after endometrial amputation in 2005. Treatment. Acitretin for 8 years in dose 25 milligram, topically treated corticosteroids and emollients with improvement of the local condition and good tolerance. And the 3 times CO2 fractional laser treatment was performed for changes in the area neck and neckline. First laser treatment took place in September 2017 with partial improvement, and after 2 more, March and April 2018, observed local exacerbation. And on the picture we can see changes. We can see this like brown papules on the neck and hands. The patient was in general very good condition and dermatological condition. On the skin of the hairy head, face, neck, and upper chest, neckline area, on the elbows, dorsal parts of the hands, the edges of the feet, the knee area, numerous disseminated hyperkeratotic papules with a tendency to coalescence within them to excoriation and erosions covered by scabs. On the hands and soles of the feet, intensified hyperkeratosis, nail plates on the hands and feet notched in the distal part with the presence of single wide longitudinal bands and slight subungual hyperkeratosis. Popular changes were located also within the genital area with maceration of mucosa. treatment of the patient. She got neotigasone 25 milligram per day, once allergic, once tablet per day before bedtime. Ura ointment 30% used externally on the hand and feet twice per day, and emollient emulsion for dry hairy scalp once per day per night. And recommendation for the patient: control and further treatment in the dermatological clinic, control of the lipidogram and liver parameters in 3-4 weeks. There are search new possibilities in the therapy of diarrheal disease, which will be the most effective and will improve the quality of life. In the treatment of localized form of diarrheal disease, it's recommended to use local retinoid and avoid provoking factors like, let's say, sun, UVB. Generally, retinoids are good, but they have also many side effects, and using glucocorticosteroids and emollient seems to be beneficial in the case of irritated lesions. And the case is presented due to rarity of the disease. Thank you for your attention.
Now it's time for questions.
And I've got a question concerning the course of the disease in the family members of the patient that you talked about, because you mentioned that it was already diagnosed in maybe 2 or 3 persons from her family. And was the course of the disease similar? And when was the moment when the first symptoms of the disease occurred?
The first symptoms of the disease appearance in the childhood of the patients. Apparently she got like very itching, her skin was very itching. That's why they went to a dermatologist, and she started to firstly use some emollients and glucocorticosteroids, and later in the future she got some stronger medicine. Yeah. And yes, this disease, it's like connected with the families. It's autosomal disease, and it's like in members of her family had this disease, but I don't know why this is so frequently.
Okay, I see. Thank you. And do you know whether diarrheal disease is connected with increased risk of the development of any certain skin cancer, or there are no such connections?
I didn't read that there is a connection with skin cancer, but possibly it could be, but I can't answer for this question. I'm sorry.
Okay, thank you a lot. Thank you a lot one more time.
Thank you.
And now I would like to invite Mr. Mikołaj Wiśniewski to present his work entitled Home Hemodialysis: What We Can Offer Patients in 2022.
Good morning, ladies and gentlemen, dear committee. My name is Mikołaj Wiśniewski, and I will be presenting my work, Home Hemodialysis: What Can We Offer Patients in 2022? So let's begin. So for the start, a little bit of history. First, hemodialysis were performed as experiments on dogs under the supervision of Professor Abel in 1913. In 1944, the first successful procedure was performed on human in Netherlands by Professor Willem Kolff. And there are some interesting facts about Professor Kolff, that he created that first machine during the Second World War. He was lacking materials, so he to save a patient with acute renal insufficiency. In 1950, first dialysis department was opened in Sweden by Professor Albala. On November 6th, in 1958, first hemodialysis was performed in Poland, in Poznań. And there's an interesting story about that, because for years, Professor Orłowski from Warsaw claimed that first hemodialysis was performed in Warsaw, but after many years of lies, he finally admitted that it was in fact in Poznań. Hemodialysis is a medical procedure during which unnecessary substances accumulated in blood are removed. It is mostly metabolic products and excess water. There are two processes. First is diffusion, where high concentration of substances in the blood pass into the dialysis fluid and are removed with it. And the second one is ultrafiltration, in which excess water is removed due to the higher pressure inside the tubes in the machine. For the dialysis, we need vascular access. There are three types. It's arteriovenous fistula, arteriovenous graft, and central venous catheter. The most used is the first one, so it's arteriovenous fistula. The beginning of home hemodialysis was with Dr. Yukihiko Noze in 1961. He used a domestic washing machine with a frame called dialyzer. And what is old is new again, because after the initial rise of use of home hemodialysis, there was a decrease in the use of that technique. And from the year 2007, we can see that it's rising again. And on the right side, we can see the countries which use home hemodialysis. There are mostly Scandinavian countries, such as Denmark, Finland, Sweden, Norway, but also United States, Australia. Unfortunately, in Poland, we don't use home hemodialysis. Here are some pictures of the top brands that produce machines. On the upper left, we can see NX Stage Medical, and on the bottom, there's Fresenius. And I will talk now about some complications. The first one is vascular access infections. Buttonhole cannulation technique ensure ease of needling and decreased pain, but increase the risk of infections compared with the row bladder cannulation. So we should avoid the buttonhole cannulation technique and use the row bladder technique. And strict skin preparation is also needed. Another complication is heparin dosage. In patient can occur hemorrhage, menorrhagia, decrease in hemoglobin, anemia, so the doses of heparin should be given by the doctor. Another complications are deficiencies associated with enhanced dialytic removal, such as calcium, potassium, vitamin B, C, and L-carnitine. Useful prevention strategies are dietary phosphate restriction can be lifted, adjusting dialysis prescription, decreasing the number of hours of dialysis, decreasing the dialysate flow rate, increasing the dialysate calcium concentration, and phosphate binders can be discontinued in many patients treated with nocturnal dialysis. Psychosocial complications such as anxiety and depression are associated with dialysis. Patients transitioning to home hemodialysis have concerns about their safety, medical responsibilities, and financial burden. Assessment and treatment of potential mood disorders associated with home hemodialysis may be critical to the success of the therapy. Paying caregivers and or providing tax incentives may help to offset some of the financial concerns. Another complications are technique failure, because patients sometimes are unable to, inability to train patients and discontinuation of home hemodialysis. Most failures are in the first year of treatment, and patients claim that the most complex thing for them is the need for self-cannulation. Initial intensive education program with subsequent refresher courses is needed, and a pilot project in Ontario, Canada now is exploring the potential benefits of assisted home hemodialysis with the help, for example, a nurse, similar to assisted peritoneal dialysis. And complications that are associated with machine and procedural problems. Newer machines are being developed, and they have more safety features and are getting better and better with every year. So conclusions are that home hemodialysis has undergone a tremendous change in the last 6 decades. Modern machines are nothing like they were before, and technical advancement ensure a safe and effective treatment for educated patients. There was a rise followed by a rapid decline in use, and now we can see a resurgence of home hemodialysis. But we should remember that adverse events can and still do occur, requiring an ongoing re-evaluation on educational strategies, dialysis prescription, and equipment design platforms. Thank you very much for your attention. I am ready for your questions.
Thank you very much for the presentation, and now it's time for questions.
Thank you very much. A very interesting speech. I'd like to ask you, do you know, are there any patients in your country who use this kind of treatment in Poland?
Well, as I said before, in Poland, unfortunately, we don't use home hemodialysis, so there are no patients, not even one patient who uses this technique.
So there is no patients in Poland. But I wonder what the average age of this patient is. They're young or might be old patients. What do you think?
I think the age may be very different from the patients. This technique can be used by younger and also older patients. So as I read in many articles, the age is very different, so I can tell the specific group age, because there are patients with renal insufficiency who can afford this kind of treatment.
Mm-hmm. But I think that it might be a little bit problem for old people with hemodialysis access, yes?
Yes, of course, because the first thing is that patients who are not trained properly find it difficult for self-cannulation. And as we know, older people, the vascular access is more difficult due to the veins and also that are not that strong, and even for the nurses or doctors it's more difficult to get a good access on the older person. So yes, I think it is more difficult for older person to self-cannulate and get that vascular access.
Thank you for your answer. Thank you very much.
And I've got one more question. And according to your personal point of view, do you think that in the future we will overcome the potential side effects and complications connected with home hemodialysis, and it will become the mainstay of the treatment of the patients with chronic kidney failures? Is it possible, or still it will be just an additional possibility for the patients?
Yes, I think it will get better because the technique is now going a tremendous change. Everything is changing so fast. Modern technology develops very interesting medical strategies. For example, artificial intelligence can calculate the time of dialysis, and I think in the future, if it will be financed properly by governments, it could be a very good chance for patients. Especially that I read that more frequent hemodialysis give better results than the longer ones. So for example, if patients can get a 4, 5 or even 6 times a week dialysis, his survival rates are higher, so that gives hopes for the patients with renal insufficiency.
Thank you for your answers and the presentation of the topic. Thanks a lot.
Thank you very much.
Thank you for the discussion. I would like to kindly remind you about the necessity of turning on the camera during the presentation. And the next work, entitled Interventional Nephrology, Chance for Patients, will be presented by Ms. Weronika Buczek.
Okay, so can you see my presentation?
Presentation is visible.
Okay, and when I'm changing slides?
Sorry for interrupting. Can you turn on your camera?
Yes. Can you see the changing slides?
Yes, but we have a view of PowerPoint. Maybe you should. Yes,
And,
yes. Oh, that's great.
And now, yes? Okay.
Yes.
So I will tell you about interventional nephrology, chance for patients. And what is interventional nephrology? It's subspecialty of nephrology responsible for diagnostics, therapy, and many procedures related to kidney disease. Its main domain is to provide dialysis access. And currently, nephrology has become strictly internal specialization. Interventional procedures previously performed by a radiology, surgeon, or maybe vascular surgery, which affected the comfort and care of nephrological patients. A new idea for restoration of nephrologists to their former wider role is to introduce this new subspecialty. And the American Society of Diagnostics and Interventional Nephrology offers interventional nephrology certification in hemodialysis vascular access procedures, peritoneal dialysis catheters placements, and ultrasonography of the kidneys and bladder to physicians practicing in the US. And the exact number of nephrologists who practice as interventional nephrologists is not known. Most interventional nephrologists today work in outpatient dialysis access centers or ambulatory surgical centers, which are specifically designed, equipped, and staffed for the management of dialysis access patients. And what are the possibilities of interventional nephrology? So it has been proven that kidney ultrasonography performed by nephrologists significantly speeds up the diagnostic process and therapy of patients with kidney disease. And it is related to the shortening of time to performing the ultrasound and the possibility to performing it at the bedside without the need to transport the patient. And one of the most important activities in interventional nephrology is to establish and maintain access to dialysis. And it is a procedure that affects the entire course of treatment and the patient's life. It has been shown that the time from the first visit of patients to the establishment of access to peritoneal dialysis by nephrologists is 7 days, while it takes 1 to 2 weeks to only referral to a surgeon. Vascular access enables the patients to undergo hemodialysis and is often a life-saving procedure. An interventional nephrologist would be able to create an arteriovenous fistula as well as repair any dysfunctions. And here are also the other tasks of the interventional nephrologist. And now, renal osteodystrophy is a bone structure disorder in patients with chronic renal failure. The nephrologist will need to decide when to perform a bone biopsy. As we know, a bone biopsy is performed from the iliac crest. It's technically easy procedure, so it can certainly be performed by a nephrologist. And what about quality and safety? It has been shown that outcomes of these procedures performed by interventional nephrologists were superior to those previously reported by other specialties. And data collected from 24 centers across the US showed a 3 to 8 times lower radiation dose than studies published by radiologists working in a hospital settings. Anytime radiological equipment is used by non-radiologists, there are legitimate concerns about radiation exposure to the patient and healthcare team. So why do we need interventional nephrologists? It's needed field and subspecialty in medicine. A nephrologist has the best knowledge about a patient with kidney disease, knows the entire course of the disease and the treatment, and knows best how to help the patient, especially the one undergoing dialysis. This field would significantly improve the patient care process. And here are the benefits for patients, like standardize the very process of diagnosis and treatment. It could also facilitate patients' access to medical care, its opportunity to receive complete, faster, and standardized help, and reduce for attention.
Thank you for the presentation. Now it's time for discussion.
Thank you for your presentation. Very good ideas, but I have got a question. Is it supposed to be a new specialization for doctors, or is it going to deepen the learning of additional treatment procedures for willing nephrologists, some procedures like for surgeons, for example, or maybe is it enough to change the law, for example, in our country? Thank you.
I think it shouldn't be new specialization, but it's only a subspecialization. It's only for nephrologists. As I said, the nephrologist has the best knowledge about patient, especially the one who's undergoing dialysis. And I think the specialization programs should be only just for nephrologists.
Thank you. Thank you.
And I've got one more question. Thank you for your presentation. You mentioned some data concerning invasive nephrologists in the US. And during working on your presentation, did you find other data concerning this issue in different countries? How does it look like? Or just the data from the US?
I found only the data from the US because it's a new subspecialty and it needs time to spread over the other countries. For example, in Poland, I found only that there's only an interventional nephrology room in Szpital Bielański in Warsaw, and that's all.
Yes, it's true. It's a really new issue. So thank you for presenting it today. Thanks a lot.
Thank you very much for the interesting discussion. And now I would like to invite Ms. Patrycja Niewinna to present her work entitled What is Life Like with Repenning Syndrome, a very rare genetic case of a 10-year-old girl with intellectual disability.
Good morning again. And I would like to say it was a mistake. It's about a boy, but it is my fault. Is my presentation visible?
Yes.
Mhm. Okay, yes, I would like to present a case report about Repening syndrome. On the beginning, I would like to say a few words about the disease. Repening syndrome is an X-linked intellectual disability syndrome caused by mutation in the polyglutamine tract binding protein 1, PQBP1 gene, which encodes a nuclear protein that regulates assembly of pre-mRNA and transcriptions. And Repening syndrome is characterized by intellectual disability, microcephaly, a slim figure, and moderately short stature. A typical patient has a longitudinal triangular face with a large ribbed nose, half-depilate eyebrows, underdeveloped or overgrown ears, slightly sparse hair, often long curled eyelashes, curve-shaped eyes, and up or down-slating palpebral fissures. From an early age, delayed motor and speech development are observed in childhood, and the diagnosis is based scientifically on the clinical signs of Repening syndrome. Can you see another slide?
No, it doesn't change. Now we can see the patient informations.
Mm-hmm.
Yeah. Okay.
Date of birth is 26 December 2012, and the boy has microcephaly, longitudinal triangular face with oblique eyelid slits, half-shaped eyebrows, short lifting nostril, and cup-shaped ears. Patient is under control of clinic's neurology because of microcephaly, nephrology because of kidney problems, speech treatment, delayed speech development, urology clinic for children, autism clinic for children, pedagogical clinic, psychological clinic, and the care of psychiatrists. 24th January 2013, the boy has kidney scintigraphy. Right kidney in the pelvic position, oval, orange, horizontally with the secretory function preserved and excretory function discretely slowed down. Uterus invisible. Left kidney displaced to the right. Urine output is smooth. Resolution of renal function. Left kidney 55.2%. Right kidney 44.8%. Displaced kidneys, left kidney crossed ectopy, right kidney pelvic position, both kidneys preserved excretory function. 26 January 2016, and boy had, there was a psychological study was carried out using the International Performance Elator Scale. The result obtained by the boy was 9, which shows average cognitive abilities. And the next examination was screening test for fragile X chromosome. One allele of the correct size was found. Identification of one allele of the correct size in a male allows with a high probability to exclude the presence of a dynamic mutation in the FMR1 gene. And the test result is correct. It does not exclude the genetic causes of the abnormalities found. Results of the cytogenic tests from 2016, and there was an increased region of heterochromatin on chromosome 9 and decreased region of heterochromatin on chromosome Y. There are morphological variants of chromosomes and have no clinical significance. Chromosome analysis showed normal male karyotype. The test results excluded numerical aberration and large structural aberration, but does not exclude the genetic causes of the abnormality. Logopedic opinion. from 2017. In the field of passive speech, patient understands all simple messages. Patient communicates verbally with single words and sounds. And here, patient is like 5 years old, so he's a big boy. Can you see slide changed?
And now it didn't change. Yeah, now it's changed.
Okay. In 2017, diagnosis of comprehensive development disorders was found. Atypical autism, boy's speech developed with delay. The first words were uttered around 12 months of his life. The active vocabulary was significantly reduced compared to age. He had problems with emotional and social functioning. Disturbances in the perceptions of sensory stimuli in the area of sight and feeling were observed. Another test with the method of comparative genomic hybridization, CGH, the method genomic oligonucleotide microarray, but the test is correct, the result is correct. DNA analysis from 2020. Exome analysis was performed using next generation sequencing. The analysis was performed to identify mutation in genes related to intellectual disability. The patient found a pathogenetic variant in exon 6 in the PQBP1 gene, and mutation in the PQB1 gene are responsible for the occurrence of X-linked intellectual disability repenning syndrome. Psychological opinion, difficulties in maintaining and establishing proper relationship. Boy has the delayed development of speech, impulsive behavior, difficulties in complying with the applicable rules, disturbances of concentration and attention, difficulty in complying, many self-stimulation, confuses accepts yes and no, does not use gestures to compensate for speech deficiencies, difficulties with following the rules of the group, a deficit in the development of the emotional sphere, reacts inadequately to the situation. And recommendations. The boy requires intensive individual and group therapy, in-depth diagnosis towards autism spectrum disorders due to developmental problems of the child, intensive multi-phase systematic speech therapy, pedagogical and psychological therapy, as well as the care of a psychiatrist are recommended. Diagnosis is based on the identification of the clinical signs of Rand-Penning syndrome. MRI of the brain shows no marked reduction in cortical gyruses, which contrasts with over microcephaly. Screening for mutation in the PQB1 gene might confirm this diagnosis. Emotional and social functioning disorders, as well as difficulties in establishing and maintaining peer relationship, were also found. Intensive multi-phase systematic speech therapy, pedagogical and psychological therapy, as well as psychiatric care is recommended for proper development so that the child could develop at a similar pace as his peers. Due to this, in the future, they will have a chance to educate themselves, participate in social life, which will have an impact on mental health and will allow them to build self-confidence and self-esteem. Rand-Penning syndrome is an X-linked recessive pattern of inheritance. Genetic testing enables the identification of carriers and the risk of passing the mutation on their offspring. And there is no cure for Rand-Penning syndrome, but in most cases, life expectancy is shorter.
Thank you very much for presentation, and now it's time for discussion.
Thank you for your presentation of this quite unique case. And you mentioned that Renpenning syndrome is a quite rare occurrence. And according to the symptoms presented by this certain patient, what kind of different disorders could be differentiated with it? I mean, at the beginning of the diagnostics, what could we think about?
We could differentiation with fragile chromosome syndrome, Addison disease, adrenoleukodystrophy, for example. But microcephaly is very typical for this disease. But because of the disease is very rare, that I think that not everyone even know about this disease.
It's true, so thank you one more time for presenting it to us today. Thanks a lot.
Thank you.
Thank you for the discussion. It's time for the next speaker, Mr. Paweł Kozioł, with his work, Sinus of Valsalvia aneurysm, accidentally diagnosed in a patient with saddle pulmonary embolism. The floor is yours.
Good morning. Welcome to the Honorable Committee and other participants. My name is Paweł Kozioł and I represent Student Scientific Association at the Department and Clinic of Cardiology, Medical University of Lublin. My presentation, the title of my presentation is Sinus of Valsalva aneurysm, accidentally diagnosed in a patient with saddle pulmonary embolism. Here is the schedule of my presentation. Firstly, I would like to emphasize the huge role of echocardiography examination. Let's take a quick look at the history of echocardiography, which started over 50 years ago, at the time when first moon landing took place. There is an important difference. Only a few have been in space, but millions have already used ultrasound. I would like to emphasize the role of echocardiography on the example of a patient, the man with the age of 86 years old, with hypertension, dyslipidemia, due to chest pain and syncope a day before. He came to the emergency room with following findings: tachypnea, saturation 90%, and increased blood pressure. Because of elevated cardiac troponins and ST segment elevation in V1, V3 leads, the anterior wall infection was suspected. However, coronary angiography showed no significant changes in coronary vessels. So the next step was to perform angio-CT of pulmonary arteries, because also D-dimers also was elevated and pulmonary embolism was suspected. The angio-CT confirmed massive pulmonary embolism, and in this case, simply the bedside echocardiography made it possible to see saddle pulmonary embolism, in other words, embolus rider. And what is interesting, saddle pulmonary embolism occurs in only approximately 2 to 5% of all pulmonary embolism cases. Doppler ultrasound of lower extremities revealed a feature of thrombosis, which could cause the pulmonary embolism, and intensive intravenous anticoagulation with unfractionated heparin was used, and after stabilization of the patient's condition, new oral anticoagulants was applied. We see that acute pulmonary embolism may mimic acute coronary syndrome. And what I would like to highlight is the fact that 1/3 of patients with acute pulmonary embolism may present with all the manifestations suggestive of acute coronary syndrome, like chest pain, elevated troponin, and EKG changes. This is not the end of the history of our today's patient. The patient was also accidentally diagnosed with sinus of Valsalva aneurysm. The sinuses of Valsalva are located in the most proximal portion of the aorta, just above the cusp of aortic valve. And dangerous in sinus of Valsalva aneurysm is the possibility to rupture to hard cavities, what can lead to fatal complication. Sinus of Valsalva aneurysm is a very rare condition and occurs only in about 0.2% of population. Let's look at parasternal short axis view. On the left we can see normal aortic valve, which shape is similar to Mercedes sign, and on the right side we can see the right sinus of Valsalva aneurysm, which deformed Mercedes sign. A frequent echocardiography control is indicated in this patient, and in movies here we can see the right sinus of the right sinus of coronary aneurysm, which narrows the right ventricular outflow tract. And going to the summary, I would like to say that this case deserves attention as it shows the great value of echocardiography. Simple application of the transducer enables immediate detection of massive pulmonary embolism. It is clear that angio-CT provides more information, but its availability is much less compared to the echocardiography examination. Moreover, in this case, due to the use of echocardiography, a very rare pathology was accidentally diagnosed, which is the asymptomatic right sinus of aneurysm. Thank you for your attention.
Thank you so much for your presentation, and now it's time for questions.
One question, please. Sinus of Valsalva aneurysm is very rare, but what is mortality in these cases? Could you tell us, please?
So the data connected with patient with sinus of Valsalva aneurysm it's not a big amount of data on PubMed, but this condition can be connected, for example, with Marfan disease, with connective tissue diseases, and the treatment for this patient is rather observation. For example, in this patient, observation, echocardiography examination every 3 months.
Thank you for your answer.
Thank you for your presentation, and I was about to ask about the certain background of the possible cases of Valsalva aneurysm, but you mentioned disorders of the connective tissue. So it is a major background, or can we think about any other risk factors of this pathology?
Also the possibility to this sinus of Valsalva aneurysm is also, for example, hypertension, but we know that hypertension is also trigger to, for example, dilatation of ascending aorta and aneurysm of ascending aorta. So I think that the possibility of sinus-invasive aneurysm is much more bigger in connective tissue diseases than in population without connective tissue diseases.
Thank you. And just a short question, just due to my curiosity. Do you know what was the level of D-dimers in this patient?
D-dimer, I don't know whether I could remember, but about 2,000-3,000.
Okay, thank you. Thanks a lot
Thank
for
you.
the presentation.
Thank you very much one more time for interesting discussion. And now I would like to invite Ms. Małgorzata Słaboń to present her work entitled Wunderlich Syndrome as a Cause of Acute Abdominal Pain, a Case Report.
Good morning. Is my presentation visible?
Yes, we can see your
And
PowerPoint. Oh yeah, now
Okay.
it is.
okay. and
Yeah,
the-
it
okay.
changes. Okay, very good. Thank you.
So good morning, my name is Małgorzata Słaboń and today I will present you with a case report paper on Wunderlich syndrome as a cause of acute abdominal pain. So the Wunderlich syndrome is a rare condition in which spontaneous, non-traumatic renal hemorrhage into the subtubular and perinephric spaces occurs. The German physician Karl Reinhold August Wunderlich published the first case description of the syndrome in 1856. And it's also worth mentioning that it is he who is remembered from defining the physiological temperature of the human body. Let us turn to the causes of the Wunderlich syndrome. The main causes include the renal angiomyolipoma, bleeding, and the renal cell carcinoma. Of course, there are many other less common causes, such as the drug-induced vasculitis, pheochromocytoma, or renal cyst. The length triad is associated with the symptomatology of Wunderlich syndrome. As you can see in the diagram, it consists of the acute flank pain, the hypovolemic shock, and also the flank mass. The treatment depends on the hemodynamic stability of the patient. If the hemorrhage is self-limiting, the patient can be managed conservatively, and the angiographic selective embolization can be performed. But when the patient is hemodynamically unstable, the only option is the emergent nephrectomy. Let us now turn to the case description of our patient. She's a 65-year-old woman who presents to the hospital emergency department with diffuse abdominal pain and peritoneal symptoms. Sorry. I will now show some images from the CT scan of the patient. The yellow dashed line marked extensive bleeding in the extraperitoneal space around the right kidney. Here with the yellow arrow, we can see the active extravasation of the contrast, which indicates the atrial bleeding. On the CT scan, we can see a large heterogeneous exophytic mass in the upper pole of the right kidney, composed mainly of adipose tissue. The lesion displays the renal parenchyma. Demonstration of fatty attenuation in the renal tumor on the CT is virtually diagnostic of an angiomyolipoma. Okay. Additionally, the study revealed inhomogeneous parenchymal enhancement of the liver manifest as hyper and hypodense areas, which was the effect of accompanying increased perfusion disorders. In conclusion, the patient was diagnosed with the extensive active bleeding into perirenal extraperitoneal space due to the ruptured tumor of the right kidney. It was finally decided to perform a right-sided nephrectomy. And I would like now to say a few words about the most common causes of the Wunderlich syndrome, which is the angiomyolipoma. As most of you probably know, it is one of the most common benign mesenchymal tumor of the kidney. It is twice as common in women as in men. And it is also interesting that in 80% of cases, the disease affects only the right kidney. The lesion is most often found sporadically
and is detected incidentally during radiological examinations. However, in about 20% of cases, AML may occur in the course of the phakomatosis, such as the tuberous sclerosis or neurofibromatosis. Angiomyolipomas can be detected by various imaging studies. This includes the ultrasound, CT, or MRI. Ultrasound showed them to be usually hyperechoic and homogeneous due to the presence of macroscopic fat. Sometimes angiomyolipomas may also cause acoustic shadowing. But sometimes it's really difficult to make the diagnosis of the lipid-poor renal AML with the ultrasound. Hypoechoic lesion of the kidney almost always requires further differential diagnosis. The CT scanning is highly accurate in the characterization and diagnosis of the angiomyolipoma lesions. In discussing this topic, it's also worth mentioning the Bournville-Pringle disease. This disease also is called the tuberous sclerosis complex, and it's really a rare genetic disorder. A combination of symptoms may include seizures, developmental delay, behavioral problems, skin abnormalities, and lung and kidney disease, with common formation of multiple angiomyolipomas. MRI is excellent at evaluating fat-containing lesions, and two main sets of sequences are employed. Firstly, fat-saturated techniques demonstrate high signal intensity of non-fat-saturated sequences and loss of signal following fat saturation. The second method is to use in-phase and out-of-phase imaging, which generates the India ink artifact at the interface between fat and non-fat components. This can occur either at the interface between the angiomyolipoma and surrounding kidney, or between the fat and non-fat components of the mass. India ink artifact, or the other name type 2 chemical shift artifact, it is an artificially created black line located at the fat-water interfaces, such as those between muscles and the fat. As I mentioned, one of the most serious complications of AML is rupture and bleeding. We can distinguish three main etiologies of AML rupture and bleeding, which is the Wunderlich syndrome, traumatic bleeding, and during the pregnancy. In terms of treatment, when AML increases in size and becomes symptomatic, embolization through the renal artery should be considered. And now we can see the CT scans after embolization, and there is the significant reduction of AML mass. In conclusion, AML is the most common benign mesenchymal neoplasm of the kidney. The lesion is most often sporadic and is detected incidentally on radiological examination. Less frequently, AML may occur in the course of pheochromocytomas, such as tuberous sclerosis or neurofibromatosis. And finally, larger AML may be associated with a risk of bleeding. For rapidly growing or symptomatic tumors, planned transarterial embolization of AML should be considered. Wunderlich syndrome is one of the less common complications of large-size AML and the rare cause of acute abdominal pain in patients diagnosed in the emergency department. Thank you so much for your attention.
Thank you very much for an interesting presentation, and now it's time for the questions.
A nephrectomy, loss of a kidney, but the patient survived. It is worth remembering in the case of procedures with the possibility of interventional radiology and embolization of tumor arteries. It is possible to help a sick person more often without the need for nephrectomy. But do you know of any side effects of the embolization of tumor arteries? Is it safe procedure? Could you answer, please?
Yes. I think that it's more important to help with the angiomyolipomas and to do the embolization because of the fact that they can rupture and give the bleeding, because it's really dangerous situation. So, but I don't know any complications after the embolization, because I know that it's beneficial and it's better to do it than to wait until the angiolipoma rupture.
Thank you, but sometimes complications happen, and the most common complications are kidney abscesses and bleeding from the embolized vessel. Yes? So thank you very much for your answer and presentation.
And I've got just one short question from clinical point of view. Do you know what was the level of hemoglobin in this patient just due to this bleeding? Was it a severe decrease in the level of hemoglobin?
No, unfortunately, I don't know. I just have the radiological examinations of the patient.
Okay, thanks a lot for the presentation.
Thank you so much.
And next work, entitled A Patient with Painful Neck Edema Case Report, will be presented by Ms. Wiktoria Silvanowska.
Good morning to everyone. Do you see my presentation?
Yes, the presentation is visible, but on your PowerPoint view, so you have to full screen it. Yes, excellent.
So again, good morning to you. I'm a student of medicine at the Medical University of Lublin. I'm going to present to you a thesis entitled Painful Neck Edema Case Report. Neck phlegmon is a rare diffuse bacterial infection of the soft tissues of the neck involving the deep interfacial spaces. Annually, there are from 4 to 15 cases per 100,000 people. The most common causes of phlegmon are oropharyngeal infection, purulent parotitis, and dental caries. The main symptoms include fever, neck pain, and generally malaise, and odynophagia or dysphagia. Neck phlegmon is associated with many serious complications, including descending necrotizing mediastinitis with mortality from 10 to 40%, internal jugular thrombophlebitis, acute respiratory failure, and sepsis or septic shock. And case report. A 54-year-old patient came to the hospital emergency department due to painful neck edema, limited neck mobility, and odynophagia. A CT scan of the neck showed the presence of diffuse infiltrations within the floor of the mouth, soft tissues of the neck, and partially the mediastinum of the left side. And the arrows indicate a diffuse infiltrate with gas alveoli in the left and in the right mediastinum. The patient was admitted to the Department of Otolaryngology with the diagnosis of odontogenic phlegmon of the neck and anterior mediastinum. Exploration of the neck was done with drainage of the anterior mediastinum, and the left molar tooth was extracted. Due to respiratory failure and shock, the patient was transferred to intensive care clinic. The patient was sedated in a severe condition. A tracheostomy tube was inserted into the trachea, left in the photo. antibiotic therapy and rinsing the drains with an antibiotic solution were implemented. A follow-up CT examination showed a significant reduction in the size of the drained reservoirs. In the right photo, we can see the drains and two drains in a neck. Another follow-up CT scan of the neck with contrast showed smaller drained reservoirs with encysted symptoms. Additionally, a CT scan showed segmental thrombosis of the left jugular vein and indicated in the photo with arrows. After 2 weeks, angio-CT examination showed the presence of residual encysted fluid reservoirs within the floor of the mouth, the soft tissues of the neck, and the left parotid gland, as indicated in the photo. Head angiography didn't show any loss of contrast in the cerebral arteries. The patient was transferred to the Department of Otolaryngology in good general condition. Due to the occurrence of fever, the patient was tested for COVID-19 infection, which was positive. The patient was transferred to the isolation department in an external center. To sum up, neck phlegmon requires urgent diagnosis and treatment due to the occurrence of serious complications that threaten the patient's life. In diagnostic, a key role is played by computed tomography with contrast, which allows to determine the extent, reservoirs location, and visualize local complications. The surgical treatment and antibiotic therapy may result in excellent prognosis. And thanks for your attention.
Thank you so much for your presentation, and now it's time for questions.
Thank you for your presentation. I have only one question, please. Doesn't matter very much what kind of antibiotics we use in this case, because the patient was treated with antibiotic. What kind of antibiotic was used?
Yes, at the beginning, patient get a lot of antibiotic because doctors didn't know which bacteria is caused neck phlegmon. And it was penicillin and I think, if I could remember.
Thank you. Thank you very much.
And do you think that COVID-19, it was just accompanying disorder not connected with a certain pathology of the patient, or could it be involved in the course of this phlegmon?
I think it could because the patient has internal jugular vein thrombosis. And I think COVID can cause it with neck phlegmon and infection. So yes, I think yes, definitely.
Yes, I would also think about such a possibility. So thank you for your presentation.
Thank you so much.
Thank you for the discussion. And now I would like to invite Ms. Emilia Sai to present her work entitled Giant Cell Arteritis, the Reason for Fever of Unknown Cause.
Good morning, everyone.
Good morning.
Is my presentation visible?
Yeah, we can see your PowerPoint presentation.
And are the slides changing?
Yes, it changes.
Okay, thank you very much. Good morning, everyone once again. My name is Emilia Sai, and I would like to present a case report, giant cell arteritis, the reason for fever of unknown cause. Giant cell arteritis is an inflammation of the arteritis, usually affecting the aorta and or its major branches, particularly the branches of the carotid and vertebral arteries. The etiology and pathogenesis are unknown. Environmental, infectious, and genetic factors are taken into account. Also, abnormal attacks on the artery walls by the immune system are involved. The disease usually begins with a headache accompanied by painful swelling of the temporal artery, especially at night, making it impossible for the patient to sleep. Histologically, the tunica media thickens and the lumen narrows due to the tunica interna fibrosis. Inflammatory cells can be seen invading the tunica media, especially lymphocytes and eosinophils. Now I would like to tell something more about the patient. A 66-year-old woman was admitted to the Department of Internal Diseases due to 2-month fever exceeding 38 degrees Celsius, headache in the occipital area, muscle pain, weight loss, and malaise. Initially, she was treated with an antibiotic at the GP outpatient clinic, and then, due to the lack of improvement in the clinical condition, hospitalized in the clinical cardiology department with the internal diseases subdivision, where despite the tests, CT of the chest, echo of the heart, bacteriological and virological tests of blood and urine, laryngological consultation, the cause of the fever hasn't been established. After a few days, the patient was discharged home. During this time, the patient performed an endoscopic examination of the upper and lower gastrointestinal tract and underwent gynecological and dental consultations, which showed no significant pathologies. The patient also had many tests for COVID-19, the results of which were negative. Due to the severity of her symptoms, the patient was admitted to the Department of Internal Diseases, where appropriate consultations and tests were ordered in order to find the cause of the symptoms described. The results of the laboratory tests show high values of inflammatory markers and a decrease in the parameters of the red cell system in the blood count. An extensive diagnostic imaging was also performed. Chest CT with contrast showed a 4 mm thick wall of the thoracic aorta. Ultrasound examination of the flows in the carotid arteries in the division of the left common carotid artery on the arterial wall showed a thickening of EM complex with calcifications to approximately 1.3 mm. In the ultrasound examination with the colored Doppler of the upper body arteries, the wall of the left temporal artery thickened to approximately 0.8 mm on a long run. The flow channel was clearly narrowed and susceptibility to pressure was reduced. This picture corresponded to the inflammatory changes in the temporal arteries, and giant cell arteritis was diagnosed. In the treatment, intravenous drip infusion of methylprednisolone in a dose of 250 mg was used, improving the clinical condition. Coming to the conclusions. Analyzing the above clinical description, it should be stated that in some cases, the path to determining the cause of fever of unknown cause is long and difficult. The diagnosis of giant cell arteritis is usually delayed, mainly due to the elderly age of the patients. It is important to diagnose and treat the disease in the initial stage of the disease, which protects against long-term consequences like blindness or stroke. Thank you very much for your attention.
Thank you very much for the presentation, and now it's the time for the questions.
Thank you very much. I've got one question as regards the treatment. In the treatment, the patient got only methylprednisolone intravenously, or she got some prednisone after methylprednisolone in the treatment. Thank you.
Firstly, the patient has the drip of the methylprednisolone, and then after this drip, the doctor prescribed this patient methotrexate to use.
Thank you for your answer. Thank you.
Thank you very much.
And I would like to ask you about your point of view according to the fever of unknown cause. What kind of pathologies should we take into consideration to find the background of this pathology in general? When you've got such a patient and see such a patient for the first time, what kind of the diagnostic tests would you perform? What would you think about?
Firstly, I would take blood test, and then, for example, a tomography, a lumbar function, because we have to think about an infection. In this case, it's also good to take, for example, a biopsy for the temporal artery. Like we can also make a tomography. And we have to also think about other vasculitis and other like rheumatology diseases, because in many rheumatological diseases we have a fever and muscle pain, malaise, weight loss, so we have to think about this.
Yes, I agree. It can be rheumatological, hematological background, or it can be just the cancer, so it might be quite a composed issue to resolve it.
Yes.
Thanks a lot for your presentation and for your
Thank
answers.
you very much.
Thank you for the discussion. Now I would like to invite Ms. Tea Strpac to present her work, Acute Myocardial Infarction in Young Patient.
Hello everyone, just a second. Do you see my presentation?
Yes, we can see it, but
Okay.
but we only see it
Hello.
on your PowerPoint view, so you have to full screen.
Yeah, I have it now. Can you see it? Full screen?
And now,
Oh, it is full screen for me. I will try it again. Is it now for you?
and now, but maybe you can try change the slide. We can check it.
Yes, I'm doing that, but I'm seeing your screen and nothing is changing by you. But
Yes, we have only view on your PowerPoint, and we can see your first slide.
okay, I will try again to share my screen from
Yes,
the
no
beginning.
problem. We can wait.
Okay, and now now.
Only the first slide, but so maybe maybe this way. You have to change the slides. Yeah, it's okay.
Okay, yes, I can. Oh, okay.
So you have to change to the first. Yes.
Okay.
Thank you.
Okay, now. Okay. Hello, everyone. My name is Tea Strpac. I'm actually now at my job, so I'm apologizing myself. I have to be very short. I will say something about acute myocardial infarction in young patient. Right here, this happened here in General Hospital of Zabrze in Croatia. So to start with, myocardial infection is a vital condition when myocardium is deprived of oxygen, as we all know, mostly due to coronary artery occlusion. So the most common presentation of MI here is pain in the patient's chest associated, of course, with ECG changes and elevated biochemical markers such as cardiac troponin. So MI in young patients almost exclusively occurs in male. So STEMI is the main presentation, so acute management is indicated. Now we move to the patient. It's a 21-year-old patient who came to the emergency department because of the pressing pain in his chest that woke him up at 4:15 a.m. of that day. So the pain lasted for half an hour and didn't spread to other regions. And he felt well after this half an hour, and all the parameters were stable. Patient had no other significant disease in his history or his family history. His family history is positive for cardiovascular diseases, and he was only an active smoker, but no chronic therapy was found in his history. An ECG was performed showing ST elevation up to 1 millimeter in leads D2, AVF, and precordial leads. So we thought it could be myopericarditis. So in order to exclude myopericarditis, we performed an ultrasound in which hypokinesia of the basal part of the anterior wall and the basal part of the interventricular septum of the heart was observed. So we were a little bit surprised, and after that an increase in the value of troponin to 1,747 was found, later even to 2,000, almost 3,000, suggesting acute myocardial infarction. So the patient was referred to a cardiologic clinic for invasive treatment nearby, that is a center of excellence. So we don't know what happened next. And I'm sorry, I didn't took a photo. It all happened in 1 hour. So I don't have, for example, the ECG and the other documents. But I want to say I have finished my study last year, and when this patient came in the emergency department, I was like, oh, he's young, maybe this will be an musculoskeletal pain or maybe some atypical type of COVID-19 infection. But in the end, it was very seriously and diagnosis is vital. So although rare, acute myocardial infarction should be considered, of course, in young adults presenting with chest pain. And MI in young patient presents a distinct clinical characteristic, different treatment and outcome with respect to the older group. So I'm that's it for me.
Thank you for your presentation, and now it's time for discussion.
Thank you for your presentation. You mentioned a very important issue. Just because we diagnose infarctions in young patients too, and according to the possible background of this situation in elderly population, we think about the atherosclerosis as the background of the infarction. And what kind of the risk factors can we consider in younger people?
Okay, I haven't mentioned, but I find it important. This man was a little bit psycho-organic, have a psycho-organic changes, but he has no history of some disease, for example, maybe genetic disease or something. Maybe this cardiac issue was first first manifestation of his genetic disorder that haven't been noticed in his family before, and he was a smoker. I said that, and he had his body mass index was a little bit higher, considering about his age. So but I think for this patient especially, I don't have his documentation after that and treatment outcome, but I think that maybe something about genetic here.
Okay, thank you a lot.
Thank you. One question more, please. The patient was very young, 20 years of old, 21.
Yes.
So this patient didn't have a serious arteriosclerosis, so genetic factors, but maybe something else. Thank you very much. Thank you.
Thank you for the discussion. And once again, I would like to invite the speaker, Mr. Łukasz Zaremski. So it was the second chance, and we have to carry on.
It was the last presentation prepared by the active participants of internal medicine session. We would like to express words of thanks for everyone who presented the results of their works. We hope that you enjoyed this time and that exchange of views and observations will contribute to your medical knowledge. We are grateful for the presence of scientific committee for all questions and debates over the prelections.
The important information for active participants is that the results of jury's assessments will be published today evening on the official Facebook profile of the conference. Therefore, we recommend you to follow the newest post on our profile.
We remind all participants who signed up for the workshops for today evening and tomorrow to check the place of your workshop and the time when it starts.
In addition, I would like to say that you are more than welcome for our lunch break.
Thank you for the participation and see you on the next events organized at the Medical University of Lublin.
At the beginning of the neurological, psychiatric and psychological session, let me introduce myself and my colleague. My name is Kamil Górecki and the co-chair is Karol Bocheński. We are going to guide this session, supervise the order of pre-elections, control the time of your speeches, and give you a hand if required. We have a great honor to solemnly welcome all active and passive participants and the neurological, psychiatric and psychological session within the 21st Century Medicine International Medical Congress for Students and Young Doctors. The conference is organized by Young Medics organization at the Medical University of Lublin and Department of Epidemiology and Clinical Research Methodology, together with the partners hereinafter referred to as the Organizing Committee. We are favored with all scientific papers that you have delivered to the Organizing Committee and that you took the decision to participate in our Congress.
We are delighted to kindly welcome the Scientific Committee, which the members are Doctor of Medical Science, Piotr Luchowski, welcome, and Doctor of Human Sciences, Beata Daniluk, which will be online. Before we start first prelection, let me remind you the principles and the rules of the presentation. Speakers on site will have their presentation turned on by the session leaders. Presenters are asked to deliver their presentations in front of the lectern. Speakers online are obliged to share their presentation on their own. In case of technical problems, we have your PowerPoint or PDF presentations on our computer, so we will share it with all participants during your prelection. In the moment you want to change the slide, just say next one. The oral presentation of the original work may last no longer than 10 minutes. The discussion no longer than 3 minutes. The oral presentation of a case report or a review paper may last no longer than 7 minutes, and discussion no longer than 2 minutes. The session coordinator reserves the right to stop the presentation or discussion in the event of exceeding the time limit. At the last minute, we will inform you about this fact by the special sound. In case of exceeding the time, the coordinator is privileged to first finish the presentation. In this case, the discussion does not take place. The online presenting person must be equipped with a computer, with operable camera and microphone. The camera should show the view of the participant, including the whole face and the upper limbs. And the presenting person is not allowed to move out from the camera view and mute the microphone during the whole time of presentation, discussion, and the time between the presentation and discussion. In the case the presentation transmission is interrupted and less than 60% of time has passed, the participant is allowed to come out again at the end of the current session, and if more than 60% of time given has passed, the presentation is evaluated and the participant is not allowed to answer the questions at the end of the current session. And the last rule concerning the assessment criteria obeyed by scientific committee, assessments will include the following: the summary, relevance of the topic, the use of research in practice, diligence of presentation, language of presentation, and time limit, and last, discussion.
These are all official rules that we need to observe. Do you have any question or something is unclear? Okay, we would be glad to answer any doubts you might have. Okay, the first work entitled Immunophenotyping of ENKT cells in the course of multiple sclerosis will be presented by Ms. Natalia Lechman, a student of Lublin Medical University. The floor is yours.
Good afternoon, my name is Natalia Neumann, and today I have a great pleasure to present a study about immunophenotyping of ENKT cells in the course of multiple sclerosis. Multiple sclerosis is the most common immune-mediated inflammatory disease of central nervous system, and it is a leading cause of permanent disability among young adults, especially women. And what is essential for our study, the contribution of T cells, especially with Th1 and Th17 bias, has been proven in many research. ENKT cells, also known as type 1 or classical NKT cells, which display properties of both T lymphocytes and natural killer cells, breach the innate and adaptive immune responses. They express a restricted TCR receptor, and ENKT cells are among the first cell type to respond to a pathogenic stimulus, and their cytokine production help to determine the course of the immune response. The first research suggesting the validity of distribution of T helper lymphocytes based on cytokine secretion pattern was performed in 1986, and it has become extended and widely used for this cell population. And currently we distinguished, for example, Th1, Th2, Th70 cells. An analogous division can be used for ENKT cells, and the expression of key transcription factors helps to classify these cells more accurately. This study set out to determine the characteristic of ENKT cells in MS based on cytokine secretion patterns. This study group included 29 patients diagnosed with relapse-remitting form of multiple sclerosis. 23 of them were in remission and 6 during relapse. Each participant had to meet the criteria indicated on the slide. And additionally, 15 age and sex matching healthy volunteers were included as a control group. Antibodies for self-sustaining were added to 200 microliters of whole peripheral blood, and then after 20 minutes of incubation in room temperature and darkness, the erythrocytes were lysed. After next 10 minutes of incubation, the sample was centrifuged and washed twice with PBS, and in the next step, after permeabilization, antibodies against intracellular antigens, for example, anti-interleukin-17A, interleukin-10, or interferon gamma were added, and followed by a 20 minutes incubation. And finally, samples were acquired using Cytoflex LX. Here we can see the gating strategy for ENKT cells. And here is shown the expression of selected cytokines and transcription factors by ENKT cells, how it was assessed. The statistical analysis was performed with GraphPath Prism 9, and the Kruskal-Wallis and Shapiro-Wilk test were used. Initially, the percentage of ENKT cells in peripheral blood was analyzed. Results show an almost twofold higher representation of these cells in MS patients compared to the control group. And afterwards, the analysis of subpopulations of ENKT cells based on cytokine secretion was performed, and we observed downregulation of ENKT1 cells compared to healthy volunteers, and the percentage of ENKT2 slightly increases during remission compared to relapse. And significant overexpression of ENKT10 cells between patients in remission versus control group was identified, and similarly the percentage of these cells increased during relapse. Also, MS patients in remission has statistically higher expression of E4-BP4 ENKT cells, when compared to the control group, and the overexpression of E4-BP4 in relapse was observed too. It was also noted that the ENKT17 cells increased in MS patients and rho gamma T tended to be higher in both remission and relapse. And in the case of remission, it was significantly upregulated in comparison to healthy volunteers. The existence of ENKT cells with various cytokine secretion might contribute to a framework for understanding the heterogeneous role of these lymphocytes in plenty of pathological conditions like multiple sclerosis in our study. In the present study, despite different distribution of ENKT cells subpopulations dependent on whether the patient was during a relapse or remission, 2 ENKT cell subpopulations and key transcription factors related to them showed the same pattern. In both stages of multiple sclerosis, the expression of ENKT10 along with E4BP4 and ENKT17 together with rho gamma T was higher in comparison to the control group. ENKT17 cells identified as rho gamma T plus apart from interleukin-17 secrete interleukin-22 as well. Interleukin-22 is one of 9 members of interleukin-10 family with receptors composed of 2 chains, interleukin-22 R1 and interleukin-10 R2. It is exceedingly interesting in the context of our current results, considering simultaneous overexpression of rho gamma T and E4BP4 in ENKT cells during the relapse of MS. And this correlation might be a new presumed key factor in the genesis of an active phase of multiple sclerosis. And thank you all for your attention.
Thank you for the presentation. Now it's time for questions to the prelegent and discussion. Questions can be asked either by members of scientific community or by other participants interested in topics. So, do somebody have any question?
Yes, I have. Thank you very much for this excellent presentation. Maybe it was a little bit too fast, even for me. I have one question. You just observed the changes in the level of the cells in the blood of the MS patients. Do you think that it may be the cause or rather the result of the relapse?
It's hard to say this after this one study because the cytokine patterns is different for relapse and remission. And relapse it has characterized of Th2 and Th1 and Th17 bias, while during remission we observe overproduction of interleukin-4 and interleukin-13, which is characteristic for Th2. Here we observed overexpression of cytokines and key factors for these cytokines, which are characteristic for relapse. So,
excellent, thank you.
Thank you.
Do somebody from the audience have any question? Okay, thank you for the discussion.
Thank you.
Okay, now I would like to invite Ms. Paulina Drożak. She will present the presentation titled 5-HTP as a natural alternative or an adjunct to traditional antidepressant drugs.
Hello, my name is Paulina Drożak, and I would like to present a work entitled 5-hydroxytryptamine, 5-HTP, as a natural alternative or an adjunct to traditional antidepressant drugs. So serotonin is a neurotransmitter in our brain that has many functions, including emotional regulation, impulse control, sleep, learning, and memory. The serotonin hypothesis is a hypothesis of depression that was formulated in the 1960s, and to this day it is one of the most leading hypotheses of this disease. It says that a deficit of serotonin that could be corrected by antidepressant drugs plays part in the pathogenesis of depression. The main hero of my today's presentation, the 5-hydroxytryptamine, or 5-HTP, is in fact a precursor of serotonin. Here we can see a pathway from tryptophan to 5-HTP to serotonin. 5-HTP is completely natural. It is available for us in the world of nature, and it is especially abundant in seeds of an African plant called the Griffonia simplicifolia, which we can see here. Now, the most funny thing, despite 5-HTP being as effective as antidepressant drugs, it is available over the counter as a dietary supplement, like this. I have one of these, for example, here. It says 5-HTP, mood and stress, promotes a calm and relaxed mood. So the aim of this work was to analyze the literature concerning the use of 5-HTP in the treatment of depression. A literature review of publications available on PubMed platform was conducted using keywords 5-hydroxytryptamine depression. So initially 5-HTP was discarded as a drug because of its poor pharmacokinetics. It has a very short half-life, only 2 hours. It has rapid absorption and causes gastrointestinal symptoms very quickly. But there was a solution to this problem, which was the use of a slow-release form of 5-HTP. So the slow-release form of 5-HTP eliminates the initial gastrointestinal symptoms and enables a safe and higher 5-HTP plasma level. This was confirmed in a study on mice and later in a study on humans. Now I will tell a few words about using 5-HTP alone. So clinical trials have found that 5-HTP is as effective as antidepressants, but with fewer side effects than antidepressants. A typical dosage is between 150 and 300 milligrams per day, and side effects of 5-HTP are mild and dose-dependent. Some people experience gastrointestinal symptoms like stomach pain, nausea, vomiting, and diarrhea. The newest study on 5-HTP effects on depression is this meta-analysis from 2020. So, in this analysis, it was found that depression remission rate after taking 5-HTP was 65%. And to compare, depression remission rate after SSRI, according to different studies, is between 35 and 40%. What is important, this meta-analysis included patients with different types of depression. Another very promising study is a study carried out among patients with Parkinson's disease. In this study, patients were taking 50 milligrams per day of 5-HTP for 4 weeks. And after taking those 5-HTP for 4 weeks, they experienced a significant relief of depressive symptoms, which normally accompany this disease. Now I will tell about 5-HTP versus other antidepressants. So there are several studies comparing 5-HTP with other antidepressant drugs, such as fluvoxamine, an SSRI, and imipramine, a TCA. When it comes to fluvoxamine, 5-HTP patients showed slightly better treatment response than the fluvoxamine group. 5-HTP patients had significantly fewer and less severe side effects. In case of imipramine, there was no difference between antidepressant effects of 5-HTP and imipramine. However, side effects of those two drugs were different. because in case of 5-HTP, the most commonly experienced side effects were gastrointestinal problems, and in case of imipramine, it was mainly mouth dryness and tremor. So now 5-HTP in combination with other antidepressants. It was found that 5-HTP could increase the antidepressant effect when taken in combination with other antidepressant drugs. There is evidence that 5-HTP enhances antidepressant effects of drugs such as selegiline and fluvoxamine. But here we should be careful because we could evoke serotonin syndrome. So 5-HTP with other antidepressants in combination should always be used with a big dose of carefulness. So combining 5-HTP with SSRI could serve as a novel strategy for treatment-resistant depression. Combining 5-HTP and SSRI leads to an increase in the level of extracellular serotonin beyond an effect caused solely by SSRI. In one interesting study, women with SSRI and SNRI-resistant depression were taking 5 grams of creatine monohydrate daily and 100 milligrams twice a day of 5-HTP for 8 weeks. After 8 weeks, they experienced a significant decrease of depressive symptoms. There is one study that shows a very interesting possible explanation why this happens. And in this study, it was concluded that, now listen to me carefully, even those who respond to SSRIs are dependent upon their brains producing adequate amount of serotonin from either tryptophan or 5-HTP.
The time is over. Please go to the conclusion.
So 5-hydroxytryptamine appears to be effective in treating depression, both alone and in adjunction to antidepressant drugs. 5-hydroxytryptamine works in various types of depression. 5-HTP is safe with fewer side effects than traditional antidepressants, and a slow release form of 5-HTP appears to be more effective than an immediate release form. Thank you.
Thank you very much for your presentation. Now it's time for questions to the prelegent and discussion. Questions, as before, can be asked either by members of scientific community or by all the participants interested in the topic. So, do anybody have any question?
I have a question. Thank you very much for also excellent presentation. Of course, natural drugs are much better than chemical drugs, but only if they are effective in the treatment. You mentioned that 5-HTP may be found in some food. Could you just say a few words more about this?
That it can be found in some food? I didn't hear. Can you repeat the question?
You mentioned that this drug we can find also in some food, not in seeds of some plant. I didn't remember the name of this plant, but also you can find this substance in some food. Can you just say a few words more about this? In what food we can, we can find this precursor, this drug?
Oh, I didn't tell that it can be found in food, but it can be found in the seeds of this African plant. I don't know about the food.
It is the only one source of this substance in the nature.
It occurs naturally in many different things, but the 5-HTP used on the market is extracted especially from that plant. Thank you.
Okay, the time for the discussion is over. Thank you for the discussion. Thank you very much.
Now I would like to invite Mr. Konrad Warchoł, who will present the work titled Academic Burnout and Coping with Stress Among Polish Medical Students, a cross-sectional study.
Thank you for your introduction. Dear listeners, Jerry, I'd like to begin with some definitions. The burnout is defined as a state of physical and mental fatigue associated with university studies, first developed by Maslach and colleagues to explain the occupational burnout, but was adapted to academic purposes. It is defined in 3 dimensions: the emotional exhaustion, when person develops insomnia, forgetfulness, impaired concentration, loss of appetite, or anxiety; depersonalization or cynicism, when person distances oneself from tasks or other people; and decreased satisfaction with professional performance or professional efficacy. Burnout decreases professionalism, ethics, quality of contact with the patient, and empathy, while increasing willingness to quit studies, risk of developing medical conditions, substance abuse, mainly tobacco and alcohol, and appearance of suicidal tendencies. It can be caused by many factors. For medical studies pose a considerable challenge, mainly due to enormous amount of material that needs to be acquired. Also, underlying mental and physical problems, external influences, for example, from the members of the family, behavior and attitude of teachers, contact with the human corpse, and lack of motivation. Rothenstein and Al-Sharani estimated the prevalence of burnout, of depressive symptoms among medical students to be around 27%, and Ishak, in his systematic review, estimated prevalence of burnout being between 45 and 71%. The growing awareness of importance of professional and academic burnout has resulted in increasing interest of researchers in this phenomenon, including ours. Therefore, we conducted a study to assess the prevalence of academic burnout and relationship between various factors in population of medical students of Medical University of Lublin. Materials and methods. Our study was descriptive and cross-sectional on a group of 773 students from 6-year Polish Division Medical Doctor program that were surveyed online from 8th of May to 18th of June 2020. Survey was self-administered and closed format and consisted of the following questionnaires. First one being general form split into demographic and academic related data. Next one, Maslach Burnout Inventory General Survey for Student tool used to measure the grade of a burnout in 3 major scales. Aforementioned emotional exhaustion, cynicism, and personal efficacy. The burnout is diagnosed when only when one of those factors is elevated. Next one being a coping inventory for stressful situation that uses STEM score, where values from 1 to 10 are corresponding to increasing degrees of involvement of a given factor in a person's behavior. And the results are presented on 3 major scales: the task-focused, emotions-focused, and avoidance-focused, with its derivatives, engaging in replacement activities, and seeking social interactions. All data analysis were made in statistical application with appropriate tests between compared groups. Strength of the relationship between the studied variables were split into 3 categories: the strong correlation above 0.7, a moderate between 0.7 and 0.3, and weak correlation with less than 0.3. Also, all results were considered statistically significant at p-value less than 0.05. To the results, beginning with the demographic data. Age of our respondents ranged from 19 to 32 years. Most of them were female, and majority of them were from the 1st and 3rd year. The reason of choosing to study medicine was mainly willingness to help other people, the easy access to job after graduation, and ambitiousness in this field of study. One-factor burnout criteria were met by 577 respondents, making astonishing 75%, or if you prefer, only 1 out of 4 students in this lecture are not burnt out. In emotional exhaustion and professional efficacy subscales, the majority of the students met a high burnout degree, respectively 368 and 472, with cynicism being 322. The 3-factor criteria for high burnout were met by 169 students, making about 22%. The age correlated negatively with exhaustion, positively with cynicism, with no correlation found between personal efficacy. The older the person were also more eager to use task-oriented and engaging in replacement activities styles. This means that the older the person gets, the less exhausted, but more cynical they get. And predictably, the similar results were found regarding the year of study. No statistically significant correlations were found between burnout and sex, the residence, the distance between university and a family house, employment status, and reason for choosing to study medicine. Majority of our respondents used 2 styles of coping with stress, being task-focused and emotion-focused. Please take notice that task-focused coping style correlated negatively with exhaustion and cynicism and positively with personal efficacy. This indicates that task-oriented style can be associated with lower level of burnout. The same can be said about emotions-focused style, with positive correlation between exhaustion and cynicism, and negative with personal efficacy. That means that emotions-focused style can be a risk factor for developing burnout. The avoidance-focused style, there were almost no correlation with this style and burnout, but its derivatives engaging in replacement activities could heighten the burnout levels, while seeking social interactions lowered it in department of cynicism and personal efficacy. To the conclusions. Our study found that burnout among medical students of Medical University of Lublin is unexpectedly high. Please take notice that the study was conducted at the beginning of a pandemic, so the results right now could drastically shift for the better or worse. The follow-up study are to be considered. There are certain factors that contribute to various degree of burnout, and certain coping with stress strategies can lower it, for example, task-oriented one. Therefore, anti-burnout prevention strategies and intervention tools needs to be utilized. Take-home message, lowering academic burnout levels is important for entirety of academic society. Thank you for your attention.
Thank you for the presentation, and now it's time for questions. Have somebody any questions to the prelegent?
Yes, I have a question. Thank you very much for this very interesting, very good work. So, you know, it's a very close problem, I think so. My question, you know, is, as you mentioned that more than 70% of medical students
That's right.
does have this problem. I have to say that among the doctors, it is the same level, you know, there is no change.
Precisely.
Unfortunately, of course. Unfortunately.
The main problem with this kind of study that we've encountered when gathering data was the lack of studies conducted on compared groups of medical students, because there is a kind of taboo regarding this topic. cultural differences. So the student from Europe can have different kind of problems from the students from North America or Middle East. When it comes to the doctor, this is kinda easier to assess. When it comes to the students, there is just lack of deeper studies.
So your group consisted of the students from the first year and the third year.
Right.
Can you just observe any difference between the first year and the third year?
There is one shortcoming that I have to explain right now. We've got age bias right now, so the further studies should focus mainly on assessing the results from other age groups, mainly sixth year. But using our data that we've gathered, we cannot assess the correlation right now.
Okay. Maybe you know any other results from the other, medical universities in Poland. So maybe the main problem is in our university, or maybe in the other, there is no such problem.
There was a proposition to do a multi-university study, but gathering the work group is hard.
Okay, thank you very much. Thank you.
Thank you.
Do somebody have also a question? Of course, thank you for the presentation.
Okay, thank you very much. The next person, Zuzanna Wujec, will present the paper called Susceptibility to Risky Sexual Behaviors in the Polish Population Aged 15 to 63.
Good afternoon, ladies and gentlemen. Are you able to see my screen that I'm sharing?
Yes, we can hear you and see your presentation.
Okay, that's great. So let's get started. Again, good afternoon, ladies and gentlemen, and today I would like to present to you the results of a study that I conducted with Katarzyna Żurek and Piotr Wojciechowski from Jan Kochanowski University in Kielce on the susceptibility to risky sexual behaviors in the Polish population aged 15 to 63. Risky sexual behaviors may refer to a variety of sexual behaviors such as, to enumerate just few, having sex without condom or any other protection, having sex after alcohol consumption or using drugs, or having multiple sex partners. Engaging in a risky sexual behavior increase the risk of unwanted pregnancy and sexually transmitted diseases, among other things. The things I have mentioned are a social problem, so therefore it is important to constantly monitor this area. We prepared a questionnaire that was completed by 295 respondents. Respondents represented a variety of genders, age groups, and education levels. We examined both single people and those living in relationships. The questionnaire was conducted in Polish. 84% of respondents have already undergone sexual initiation. We excluded the rest of the subject from further study. It is worth mentioning that in the survey we indicated that we meant one of three types of sex, vaginal, oral, and anal. How many sexual partners have you had in the past 12 months? As you can see, the vast majority of respondents, which is 74%, had one partner. We found no association between place of residence and number of partners, as well as we didn't find any association between number of partners and the age.
Sorry to interrupt you, but we still see the first slide. And can you do a full screen, because then we can see the other slides.
Okay. Well, I am on the full screen, so let me just quickly share it again.
Okay, now we can see next slides. So we see the slides, how often do you use condoms for vaginal sex? So sorry to interrupt.
Okay, thank you. So then when we asked how often respondents use condoms for vaginal sex, almost 30% declare that they use it always, 20% almost always, and almost 12% often, almost 16% almost never, and 16.13% never. The results were similar regardless of place of residence. And what's interesting is that we noticed that among those who in a previous question declared having 3 or more sexual partners within the last 12 months, as many as 21 out of 26, which gives us approximately 81%, always, almost always, or often use condoms during vaginal sex. To the question, how often do you use condoms for anal sex? The largest group of respondents, which is 62%, marked the answer not applicable. Always or almost always was marked by 18% of the respondents. As you can see, 16% of the respondents indicated that they never or almost never use condoms. Similarly, we asked about oral sex. Here we found that condoms are always or almost always used in both cases by 1.6% of respondents, and often by only 0.4%. As many as 73% of those surveyed never use condoms for oral sex, and another 7% hardly ever use them. The most common sexually transmitted diseases through oral contact are, for example, herpes, chlamydia, and syphilis. As we can see, 63.31% of the respondents do not use any contraceptive other than condoms. And among those who use methods other than condoms, over 90% of them use hormonal contraceptives. It is worth noting that among those who use other contraceptives, 15% use them simultaneously with condoms. There are also people who combine several contraceptive methods. Over 80% of the respondents haven't had sex after using drugs in the last 12 months. Over 13% of respondents indicated that this has almost never happened to them. 4.84% of those people often, and 0.81, which is 2 people, almost always, and 0.4, which is 1 person always. What we found is that each of these 3 people who tend to use drugs before sexual intercourse had more than 5 sexual partners in the last 12 months. Moreover, all of them lived in a city with more than 50,000 inhabitants, and they all often or almost always used condoms for vaginal sex, and often always or almost always for anal sex. When we asked about having sexual intercourse after drinking alcohol, almost 20% said never, and 40.32% said almost never. But as you can see, almost 36% said it happened often. Almost always, as you can see, 3.63%. Of course, the question was, again, about the last 12 months. We were also curious to know if the survey respondents were getting tested for STDs. As we can see, 60% of respondents have never tested for STDs. 28% have tested 1 or 2 times in their lifetime. Only 5% do it regularly when changing sex partners. It's, to be more specific, 12 people in total, and 10 of them have a higher education that gives us about 83%. And 7% of people who have periodical examinations at work, or they are, for example, blood donors, or had such examinations when they were pregnant. We would like to remind you that the tests performed in Poland during blood donations are, among others, HIV and syphilis, and, for example, HBV. And, dear ladies and gentlemen, to summarize, an alarmingly small percentage of the population tests for STDs. Only 5% of respondents test for STDs regularly when changing sexual partners. In addition, very few people protect themselves from STDs when engaging in oral sex. And the frequent use of alcohol before intercourse is also a concern. As I mentioned, over 35% of respondents do it often. Regardless of where they lived, the vast majority of respondents had 1 sexual partner in the past 12 months, which seems, at least in terms of STDs, a good tendency. Ladies and gentlemen, thank you for your attention, and that's it.
Thank you for the presentation. Do somebody have a question for the prelegent?
Okay, thank you very much for this very good topic. I have one question. You know, STD infections in Poland changes in the recent days. Can you just tell us what is at this moment the most common STD infection?
As far as I know, the most common sexually transmitted disease in Poland right now is HIV.
Okay, thank you. I didn't know that. Thank you. Do you think that is a really big problem in Poland at this moment, STD?
Could you please repeat the question?
Do you really feel that this kind of diseases is a real problem in our population, and we have to do something to change, some knowledge of the people?
I think it is considered a big problem because, like, when the person is actually infected with HIV, for example, it is a social problem because, like, if he develops symptoms of the disease, this person is needs a very expensive treatment, and sometimes is unable to work fully or at all. And I think it's cheaper and more effective to educate people about the topic than to actually treat and to fight the results. And in this case, I think unwanted pregnancy is also a very big concern. So it's not only STDs, but they both combined are a social problem, and maybe not in a huge scale, but it's definitely a problem.
I completely agree. Thank you very much.
Thank you.
Thank you for the discussion, and thank you for your presentation.
The next person will be Izabela Pilarska, which will perform the presentation called Suicide Attempts Among Children and Adolescents, Preliminary Results of a Single-Center Study.
Can you see my presentation?
Yes, we can hear you and we can see a presentation.
Okay. Good afternoon. My name is Izabela Pilarska, and I will present my work today with the title Suicide Attempts Among Children and Adolescents, Preliminary Results of a Single-Center Study. The work was created thanks to a grant financed by the Medical University of Warsaw. Suicide is a major public health problem that affects people of all ages, including children. Suicide attempts among pediatric patients are currently one of the most important issues of modern psychiatry and emergency medicine. A child's decision to commit suicide is influenced by many social and psychological factors, as well as mental illness and addiction. It is often emphasized that attempt suicide is a cry for help. The pandemic year 2020, according to foreign studies, had a big impact of the frequency suicide attempts among children. However, such studies have not appeared in Poland yet. The aim of our study was to analyze the frequency and causes of suicide attempts among children admitted to the Pediatric Emergency Department of the Medical University of Warsaw. What materials and methods did we use? The study is a retrospective analysis of the medical records of 155 children among admitted emergency department due to suicide attempts from January 2020 to July 2021. They were under medical care of a single center. Data is still being gathered. 155 children and adolescents were identified in this study. This study identified 50 boys who made up 20% of the group and 124 girls who made up 80% of the group. There were children from 8 to 17 years old in the study group. Suicide was usually attempted by children of age 12 to 16. There were 137 children at this age, which is over 88% of the entire group. Among boys and girls, the most frequently chosen suicide method was poisoning, 35% for boys and 47% for girls. Self-mutilation was ranked second among girls, 31%, and first from a height among boys, 26%. The presented graph shows up the method of suicide attempts by gender. As I said before, the most common among girls were poisoning and self-mutilation. The boys most often decided to poisoning and fall from a height. Less common forms of suicide attempts chosen by both groups were hanging and jump under the train. 3 girls decided to drowning, and 1 girl decided to intake a corrosive substance. We don't have an identified method of attempting suicide in 9 people. For 40% of female and 23% of boys, patients in the study had a previous suicide attempt. What's worth mentioning, 70% of boys and 78% of girls acted to take their own life. It is very important to act quickly and help children with mental problems. 61.94% of children were immediately admitted to a psychiatric ward after a suicide attempt. 16.30% of children are addicted to alcohol or drugs. Only 7% of children were under the influence of alcohol or drugs at the time of the suicide attempt. 30.97% of children are diagnosed with a mental illness. 23.87% of suicide attempts were caused by the SARS-CoV-2 virus pandemic. Conclusions. A child's suicide attempt is rarely based on a single impulse. Mostly, it is the results a long-term build of problems and fears. Early noticing the problems of children and adolescents and quick help are very important, reducing the number of suicide attempts. Children and adolescents attempt suicide under the influence of many social and psychological factors, as well as mental illness and addiction. Adequate childcare after the attempt suicide is just as important as preventing suicidal behavior. Children who have attempted suicide require the care of an interdisciplinary team, which includes doctors, psychologists, and parents. This is the end of my presentation. Thank you for your attention. If anyone has any questions, I will be happy to answer them. Thank you.
Thank you very much for your work. Now, do scientific community have any questions to our prelegent?
Yes, I have a question. Thank you very much for this very nice topic and very nice talk. Do you just observe the increase in the suicide attempts among kids in the recent years? Can you say a few words about this? Is it a growing problem?
Okay, thank you for interesting questions. I see you are listening to my presentation. I will try to answer this as best I can.
We have no connection.
You can hear us, right? Can you hear us? Isabella, can you hear us? Because we can't hear you right now. I think we've got a problem with Zoom, so we should wait for a little bit.
Okay, so maybe we will come back to the questions later on, after we get done with these problems, and we're gonna ask the next person, which is on site, and this will be Mr. Maciej Dobosz, number 11, and he will present the work titled "Is Alzheimer's Disease a Type 3 Diabetes?" Please welcome.
Dear committee, dear my medical colleagues, stationary and online, my name is Maciej Dobosz, and during my presentation I would like to show you why, in my opinion, In the near future, the work of diabetologists and neurologists will become more and more tight. Dementia, which is the main symptom of Alzheimer's disease, and type 2 diabetes are two great geriatric syndromes. And due to the rapid aging of the population, the prevalence of these two diseases will gradually increase. However, in recent epidemiological studies show that there are approximately 30 million people affected by the Alzheimer's disease and nearly 500 million people affected by diabetes. And there are projections that these numbers will double or even triple in the next 3 decades, which eventually may lead to huge medical and socio-economic problems. However, in recent years, there are more and more reports which indicate correlation between these two disorders, so the question arises if understanding this link may provide an improvement in the quality of life of many patients. Latest studies say that insulin resistance and type 2 diabetes significantly increase the risk of developing Alzheimer's disease. It was found that this correlation reaches even from 60 to 80%. Due to this fact, scientists started to wonder what pathogenetic basis of this correlation is, and there are considered two main trends. Firstly, it is known that diabetes causes fibrotic changes in the small cerebral vessels. This leads to chronic cerebral hypoperfusion and finally to vascular dementia and cognitive decline. Secondly, it is also known that due to insulin resistance, compensatory hyperinsulinemia promotes beta-amyloid production and tau protein hyperphosphorylation. Another key factor for brain dysfunction are oxidative stress and chronic neuroinflammation. In the case of diabetes, hyperglycemia, dyslipidemia, but also visceral fat leads to release of pro-inflammatory cytokines. There are also microglial cells whose role is to clear the brain area from the pathological proteins, but when they are activated, they lead to neuronal atrophy. Also, it was found that these microglial cells also promote the beta-amyloid production and tau protein hyperphosphorylation. Some opinions considered that the hippocampus is a structure that is somehow protected against the diabetic alterations. Unfortunately, it has been proven that the hippocampus of diabetic patients disappears almost at the same extent as it is during regular Alzheimer's disease. Right, okay, these were the basics, but are there any other mechanism underlying this process? Recent studies have shown that there is a marked decline in the number of insulin receptors on the neurons of people with Alzheimer's disease. In 2020, German scientists obtained for the first time 3D image of the protein amylin, so the protein responsible for the death of pancreatic cells, and they revealed that this protein is really similar to beta-amyloid. What's more, in their next studies, they discovered that these two proteins interact and increase each other's production. Another interesting discovery is that intracellular insulin deficiency affects also the GSK enzyme, causing the pathological phosphorylation of the tau protein, which leads nextly to neuronal atrophy. We also have evidence that the ID enzyme there is an ID enzyme that affects both insulin and beta-amyloid metabolism. And due to this background, the next question is if there is any appropriate treatment for diabetes that can prevent from dementia. Anti-diabetic medications present several neuroprotective effects. However, most of them were presented only in preclinical trials on animals. If it goes about human clinical trials, there are mixed outcomes and the results are not so satisfying. There are some limitations like correct timing of treatment or proper biomarkers that should be managed in future studies. But until there is no gold standard for treatment, we should focus on prevention. Recent reports show that in some countries with more public awareness, the number of people with dementia has decreased from 10 to 8%. So it means that fighting with obesity, promotion of healthy diet or healthy physical activity can have a huge impact in slowing the progression of Alzheimer's disease. And taking everything into consideration, I hope that I presented you that the link between these two disorders is so strong that sometimes Alzheimer's disease can be considered as type 3 diabetes. More research is needed on anti-diabetic drugs as potential treatment for Alzheimer's disease. But what I want to be my take-home message is that the early detection of hyperglycemia and its proper management can lead to, can be crucial in modulating the onset and later the progression of many sporadic Alzheimer's disease cases or dementia cases. Thank you very much for your attention.
Thank you very much for your presentation. And now, do science community have any questions to our prelegent? Okay, so there is, do somebody from the audience have any question? Yes, of course.
Yes, thank you. I have a question. Were there any clinical trials already done on using the anti-diabetic drugs in the treatment of Alzheimer's disease?
Yes, there were many clinical trials, but as I said, the results were not satisfying because it was interesting, because when it comes to small trials, the results were good. People have the less possibility of discovering Alzheimer's disease, but when it comes to larger clinical trials, because of the limitations that I mentioned before, like maybe not correct time of prevention and taking these medications, the results was mixed and there is no some significant change. So I think that in the future we should pay attention to maybe some biomarkers or to that correct time of this prevention to make some more satisfying results.
All right, thanks.
I hope so. Thank you very much.
Thank you for the discussion. Now I would like to invite Mr. Piotr Duda, and he will present the work entitled Ketogenic Diets in the Management of Epilepsy, Review of the Literature.
During your neurology classes, you might have heard a lot about the treatment of epilepsy. But have you ever heard that seizure control could be achieved using this? Good afternoon. My name is Piotr Duda, and today I am going to represent the Student Research Group at Chair and Department of Neurology, Medical University of Lublin. We performed our research through the PubMed database using the keywords ketogenic diet and epilepsy. We aimed to assess their efficacy and safety. Epilepsy is one of the most common neurological diseases. According to WHO data, it affects approximately 50 million people globally. Unfortunately, only up to 70% of them could achieve seizure-free status thanks to the proper use of anti-epileptic drugs. Therefore, more additional therapies are studied, including surgical and ketogenic diet methods. But first, what are ketogenic diets? In general, they are diets high in fat, low in carbohydrate, and adequate in protein. They're used to provide the organism into a state of ketosis, which from the metabolic point of view is similar to the state of fasting. The oldest and best evaluated ketogenic diet is the classic ketogenic diet, CKD. Its lipid, non-lipid mass ratio is as high as 4:1. That means for every gram of protein or carbohydrate, 4 grams of fat are provided. Please note, in such condition, 90% of daily calorie intake comes from fat. Apart from CKD, there are 3 major ketogenic diets. The medium-chain triglyceride diet, MCT, is similar to CKD, but it's based on medium-chain triglycerides that provide greater yield to ketone per calorie. For the patient, it means less total fat and more food choices. The modified Atkins diet, MAD, is less strict ketogenic diet with carbohydrate intake limited to 10 to 15 grams a day and no ketogenic ratio determined. The low glycemic index treatment, LGIT, is the least strict ketogenic diet with carbohydrate intake limited to 40 to 60 grams a day and a preference of products with glycemic indices lower than 50. So, does it work? In a Cochrane meta-analysis of randomized controlled trials regarding patients with pharmacoresistant epilepsy, 6.6% of the pediatric patients achieved seizure-free status, when 45.3% of them achieved at least 50% seizure reduction. Regarding adult patients, no one achieved seizure-free status, and at least 50% seizure reduction was not statistically significant. The author stated that ketogenic diets could be effective in childhood drug-resistant epilepsy, while the data regarding adults remain uncertain. However, the authors stated that due to small study populations, the evidence of the studies were low to very low. In another meta-analysis comparing the efficacy of ketogenic diets and corpus callosotomy in Lennox-Gastaut syndrome patients, it was shown that corpus callosotomy is more effective in providing the seizure reduction. However, it was also linked to more ratio of adverse and severe adverse effects, where severe adverse effects was close to be statistically significant. In another meta-analysis comparing the efficacy of CKD and MAD, a statistical analysis showed no statistically significant differences between these two ketogenic diets. What is important to the patient, MAD used in the place of CKD may present some great values like no need for hospitalization, better tolerability, and fewer serious adverse effects. In a prospective study, Sach et al. Took a different perspective, assessing how often good seizure control on ketogenic diets could allow the patients to move on drug-free diet treatment, DFD. Among 232 pediatric patients, almost 1/5 managed to achieve DFD for at least 1 week, and almost 1/7 managed to maintain it until the end of their therapy course. Among the patients who managed to achieve DFD, 63 were seizure-free. However, 1/3 restarted the use of anti-epileptic drugs due to increasing or stable continuing seizures. Another crucial question is, are ketogenic diets safe? Generally, they are considered safe treatment options. Their commonly reported adverse effects are diarrhea, constipation, and vomiting. However, the data from the randomized control trials shows that the patients on non-ketogenic diets also commonly report those gastrointestinal disturbances. The serious adverse effects are reported rarely. Well, ketogenic diets, and especially classical ketogenic diets, has some problematic aspects. They are most commonly seen in classical ketogenic diet, and its need for hospitalization require of specialists like neurologists and dietitian, and its low palatability. So, to conclude, ketogenic diets could demonstrate effectiveness in children with drug-resistant epilepsy, while their efficacy in adults remains uncertain. They can be beneficial treatment options for example, for the patients with pharmacoresistant epilepsy and the patients who are not suitable for surgical treatment. Comparing with corpus callosotomy, they are less effective in providing seizure reduction, but are linked to less adverse effects. And the efficacy of CKD and MAD is similar. For patients who cannot tolerate the CKD, MAD may be a beneficial substitute. Thank you for your attention. Do you have any questions?
Thank you for the presentation. Do science community have any questions to our prelegent?
Yes, I have a question. Thank you very much for this talk. You know, ketogenic diet is quite effective, especially in the pharmacoresistant epilepsy. However, it is not very popular, not only in Lublin, also in Poland. As far as I know, in Poland there are only one specialist that you know that is used this diet and the treatment of epilepsy in kids. What may be the cause of such a disease? Can you just explain it?
Well, I think there can be several reasons for that situation. This treatment option is still underestimated. There's no enough, I think, knowledge on this subject. For example, during studying for my neurology exam, I didn't find a word of ketogenic diets in the epilepsy subject. And well, that's also a limited efficacy because, as you see, it's not as powerful as anti-epileptic drugs, and it couldn't either replace them. What's more, I think it's some kind of reluctance from the neurological staff, because maybe ketogenic diets are something what's linked to a pseudoscience, and it may be associated like that. It's also hard to adhere to the ketogenic diets, what's problematic from the patient perspective.
Yes, I agree. Thank you.
Thanks.
Thank you very much for your work. Thank you.
Thanks.
Thank you for this discussion. Now I would like to invite Mrs. Julia Kwaśniak and to present the work Epilepsy Caused by Structural Changes in the Brain.
Can you see?
Yes, we can see, but make it a full screen, please.
Okay. Now I have full screen.
And please, because before we've got some problem, can you move the slides? Yes, we can see. Yes, we can see. Okay, so the time is starting right now.
Okay. Good afternoon. I'm Julia Kwaśniak, and I'm going to present epilepsy caused by structural changes in the brain, a literature review. And epilepsy is a brain disorder that is caused by excessive bioelectrical activity in nerve cells. It presents with different types of epilepsy seizures depending on the location of the abnormality, and etiopathogenesis of this disease is multifactorial. And post-traumatic epilepsy is caused by a traumatic brain injury, and incidence is 2 to 17%. And 21 to 34% patient after brain stroke developing post-stroke epilepsy, and early PSE diagnosis and treatment can reduce the risk of the future seizures related with morbidity and mortality. And 30 to 100% patients with brain tremors suffer from tremor-related epilepsy, and it depends on the tremor time. Seizures can be first symptom of tremors, and it shows the case of a 50-year-old woman who have seizures from first year of her life, and CT and MRI has shown the huge calcified mass in left temporal lobe, and the tumor was surgically excited, and the research has shown that is neoplasm with morphological and immunohistochemical features common with the diagnosis of plenty. And lissencephaly is a malformation which includes a range of severe brain malformation, and it includes absent gyri, broad gyri, and cortical band heterotopia. And also it occurs with a smooth brain surface, and epilepsy develops in the first of your life. 9 of 10 patients with this malformation, and it's caused by RXA gene mutation. Neurocytokaryosis is caused by swallowing Taenia solium larvae, and it is one of the most common central nervous system infection in developing countries. And in the case report of 25 Burmese men who have present seizures, and then he underwent MRI and CT, and it's shown 1 centimeter cyst in the brain. The patient was diagnosed with a solitary neurocytocercosis, and it was based on clinical manifestation and neuroimaging findings and positive serology. And also in autoimmune disease, antibodies to glutamatic acid decarboxylase, isoform GAD 75 kilodaltons, are often detected in the patients with epilepsy and diabetes type 1. And it was a study include 305 patients, and 205 has also these antibodies, and 13 of them has also diabetes and epilepsy. Neuroleptic infection are also factor of epilepsy. In case of 54 years old nurse who have worked on COVID-19 ward, she has in March 2020 fever, throat pain, and PCR for COVID was positive, and then she started having seizures, olfactory hallucination, and detachment from reality. MRI and EEG have shown irregularities, but after 20 weeks, carbamazepine, having carbamazepine for 20 weeks, patients that have improved, and EEG and MRI no longer shown any spikes and another irregularity. And then, in case amyloid beta and tau pathways are characteristic for Alzheimer's disease, and it is related to the molecular pathway that triggers seizures, and levetiracetam, which is anti-seizure drug, and it was reported to reduce abnormality in hyperactivity in the hippocampal DNA gyrus, and boost abnormality in hypoactivation in the entorhinal cortex, and improve performance on the scanning memory test. And conclusion is the multitude of symptoms and cause of epilepsy emphasize the need of precise diagnostic pathway and proper diagnostic of the etiopathogenesis of epilepsy and the type of epileptic seizures are significant to increase the chance of therapeutic success. Thank you. Do you have any questions?
Thank you very much for your work. And now, do Science Committee have any question?
Yes, I have a question. Thank you very much for this review paper. Of course, if we can see some pathology within the brain, it's very easy to just start initiate the treatment. However, you have to remember that in many patients, we can't see any changes in the brain. The patients after the first seizure in the life, and in such situation, we sometimes have a problem to initiate or not the treatment. You mentioned that during your presentation that stroke, tumor, and traumatic brain injury are the most common causes of the seizures, of the epilepsy. Should we just start the treatment after the stroke episode, for example, or traumatic brain injury as a prevention, or we should wait?
No, first we must wait, because if patients don't have any symptoms, we shouldn't give him any medication.
Okay.
In case they have symptoms, yes, we must start treating this.
Yes, thank you very much.
Thank you.
Thank you for your work, and discussion time have come to the end.
Okay, thank you for this discussion. Now I would like to invite to join online Mrs. Anna Szewczyk to present the work titled Neuropathic Pain, Does This Problem Only Affect Neurological Patients?
Dear committee, ladies and gentlemen, at the beginning I would like to thank you for the opportunity to present my work titled Neuropathic Pain, Does This Problem Only Affect Neurological Patients? My name is Anna Szewczyk and I am a PhD student at Medical University of Lublin. Why I choose this topic, I choose to say something more about neuropathic pain? Because our population aging, there is growing incidence of lifestyle disorders. For example, obesity rates also increase, and diabetic mellitus is also more seen than before, and increase in survival of cancer patients. What is important for you to know that neuropathic pain patients will present, for example, decreased quality of life, more mental health disorders, loss of productivity, sickness presentation, absenteeism, burnout. And with this presentation, I wanted to introduce when to suspect and how to diagnose neuropathic pain in our patients. Here, there is a definition of International Association for the Study of Pain. So neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. And what is important that it is not this is not a diagnosis, but a clinical description. And we should demonstrate lesion or a disease which can be connected with this neuropathic pain. So to show the lesion, we can use imaging, neuropathophysiology, biopsies, laboratory tests. Or when you will think about the disorder which can be connected with this pain, please think about stroke, vasculitis, or genetic abnormalities also. GRADIC system was created by the specialists in the field, and there is 3 different types of neuropathic pain. So at the beginning, it's possible neuropathic pain, which can be connected with the interview with our patient. And please don't forget about the distribution, neuroanatomically plausible with this pain. Then probable neuropathic pain and definite. And take-home message for you is don't forget to use questionnaires, because it can help you to think or to suspect neuropathic pain. And you can use, for example, Pain Detect or Douleur Neuropathique en 4 questions. And when your patient will describe you, for example, burning or hot electric shocks, yeah, or numbness and tinglings, they can be suggestive, but they are not pathognomonic for neuropathic pain. What's the prevalence of neuropathic pain? In general population, from 7 to 10% of patients. We have two types of neuropathic pain. So central, for example, connected with stroke or multiple sclerosis, and peripheral. So here we can mention, for example, post-surgical, post-amputation neuropathic pain. I don't want to say more about neuropathic pain in neurology because I choose to say something about different fields of medicine. Here, I choose to show this table because the etiologies of neuropathic pain are really nice shown, like it's very simple to understand it. So we have different etiologies of neuropathic pain, for example, mechanical, so compressive traumatic, metabolic or ischemic, inflammatory, so infectious or autoimmune, toxic, radiation, and hereditary. And here you have also different typical symptoms of all the etiologies. I will start with neuropathic pain in endocrinology and diabetology. So in diabetes, you can see neuropathic pain in up to 50% of patients, so half of our patients would have neuropathic pain. Then Fabry disease, pituitary adenoma, and thyroid dysfunction. So in hypothyroidism, about 40% of patients will tell you about neuropathic pain symptoms. Here I put this table to show you that there is a heterogeneous group of clinical types of diabetic neuropathy. So from generalized to autonomic signs to also to mononeuropathy. Yeah, so there is a lot of different symptoms which you will see in your patient. In rheumatology, you will see neuropathic pain in fibromyalgia syndrome, so up to 75% of our patients, so 3/4 of the patient. Rheumatoid arthritis, osteoarthritis, so also up to 70% of knee or hip osteoarthritis, ankylosing spondylitis, and perhaps also in complex regional pain syndrome due to central and peripheral nervous system dysfunction with hyperalgesia and allodynia of the limbs. In oncology, hematology, you will find neuropathic cancer pain. As high as 40% of patients will have this type of pain, and 64% of this pain is connected with cancer per se, and 1/5, so 20% by treatment, including like chemotherapy, radiotherapy, and surgery. In hematology, sickle cell disease, so from 25 to 40% of adolescents and adults. As other disorders, I can mention B12 deficiency, so up to 25%, mostly axonal neuropathy, HIV neuropathy, alcoholism, so from 25 to 66%. So please don't forget about this alcoholics, which cannot move because of the limb weakness. And chronic post-surgical post-traumatic pain, on average 30% of patients. So in conclusion, the patient with neuropathic pain should be treated by an interdisciplinary team to perform a personalized pain management plan. And when you will start the treatment, please verify if it's effective, if it's effectiveness, yeah? So please ask your patient if it's better, if it's not better, do you have secondary symptoms, yeah? And due to this grading system I showed you at the beginning, the percentage of correct diagnosis as neuropathic pain increased significantly. That's my last slide. Thank you very much for your attention.
Thank you very much for your work. And now do science community have any question?
Yes, I have a question. Thank you very much for this excellent talk. I have a question. You know, in the conclusion, you just said that the correct diagnosis is very important. How you can do the correct diagnosis in the neuropathic pain?
So what I said when I spoke about grading system, at the beginning you should suspect neuropathic pain. So we can use the questionnaires. We should speak with our patients. So just ask, for example, what symptoms you have. Is it painful? Is it not painful? When you have the symptoms, for example, can you wake up during the night because of pain? Yeah, so for example, electric shocks. Then please refer those patients to neurologists. Then we can do our imaging tests. So for example, MRI or CT scan, yes, when we will find, for example, stroke or multiple sclerosis. We can do electroneurography, electromyography also to find the place, yeah, when there is a lesion or disorder, yeah, so which will be connected with the place when we see the symptoms. We can also do some genetic tests. And then when we will be sure about the results, we can give the diagnosis of neuropathic pain.
Do we have the gold drug in the neuropathic pain?
We can. It depends of the age of the patient also. So, for example, pregabalin, gabapentin. So, I will choose pregabalin in older patients. We have also, for example, amitriptyline for the patient with depression. Sometimes we can also think about treatment against pain, yeah, but it's not the gold treatment. So I think that I will start from this anti-epileptic drugs, and then I will think to, for example, add something more if the patient will not have less symptoms than before.
Thank you very much.
Thank you.
Okay, time for the discussion is over. Thank you very much for your work.
Thank you again for this discussion. Now I would like to invite to join online Nina Kamińska-Słyk to present the work entitled Anxiety and Depression in Adults with Migraine and Treatment Strategies.
Good afternoon, ladies and gentlemen. My name is Nina Kamińska-Słyk, and today I would like to present you with a study titled Anxiety and Depression in Adults with Migraine, Treatment Strategies. So first, I would like to discuss the burden of migraine. In Global Burden of Disease 2019, headache disorders ranked third in terms of years lived with disability, with migraine being the most common headache. It has many comorbidities, for example, anxiety, which affects 25% of migraineurs, and depression, which is present in 23% of these patients. We have conducted a search through PubMed database using keywords such as migraine, depression, and anxiety. Studies must have been published between 2012 and 2022 in English, and the participants must have been over the age of 18. 90 studies were identified and screened, and 26 of them were evaluated as relevant. So now, what are the therapy strategies in migraine? There are two main routes, pharmacological and non-pharmacological interventions. They are both very important in the management of migraine. Pharmacological treatment of migraineurs with anxiety and depression has some few interesting aspects, such as choosing the right agent. For example, some agents are more effective in patients with these comorbidities than others. We also have to be wary of choosing the right doses. For example, in prevention of migraine, galcanezumab 240 milligrams decreases the number of headache days. However, 120 milligram dose is not effective in patients who suffer with anxiety and depression. We should also choose the agents that have been proven to lower the levels of depression and anxiety in patients with migraine, such as erenumab, lasmiditan, and botulinum toxin A. Preventative therapy, including beta blockers, reduces headache days more effectively in patients suffering from psychiatric disorders. Another really important aspect is dealing with anxiety and depression in patients with migraine. It is important as proper treatment of psychiatric comorbidities prevent progression of chronic migraine. We should choose the medication that is effective in both psychiatric disorders, such as amitriptyline and duloxetine in depression and flunarizine in anxiety. When specific treatment is needed, SSRI and SNRI medication prove to be a good choice. However, we should be wary that migraine is associated with lesser improvement in therapy of anxiety and depression. Now let's talk about non-pharmacological interventions. For example, acceptance and commitment therapy, ACT for short. Behavioral therapies have been proven to be effective in patients suffering with migraine. ACT is focused on mental processes, and the objective of this intervention is the psychological flexibility by cultivating 6 different positive capacities, such as acceptance, diffusion, sense of self, mindfulness, values, and committed action. 2 sessions of ACT caused over 50% drop in depression symptoms, and significant number of people no longer met the criteria for major depressive episodes. Patients who received 8 sessions of ACT compared to those who didn't had a 4 days migraine less and reduced medication intake by 3.8 intakes in a month. Now let's talk about other strategies such as biofeedback, which reduces headaches by 1.9 days in a month and improves depression and anxiety scores. Cognitive behavioral therapy had a positive impact on measures of headaches, depression, anxiety, as well as quality of life. 5 sessions of motivational interviewing, it is motivational calls, improved the rate of initiating cognitive behavior therapy appointments. Now let's talk about acupuncture and electroacupuncture. These procedures seem to be very controversial in treatment of migraine, but they have been both proven to lower the scores of anxiety and depression in patients with migraine. So, in conclusion, therapies for migraineurs suffering from anxiety and depression should be adjusted to their comorbidities. Choosing the right medication for both migraine and psychiatric disorders is desired, and it benefits the patient. Non-pharmacological actions seem to have promising results in migraine patients, especially if they are diagnosed with anxiety and depression. Further research is needed on the topic. New results might help integrate better strategies of treating migraine patients while also improving their mental state and quality of life. Thank you very much for your attention, and I would like to invite discussion.
Thank you very much for your work. And now, do Science Committee have any question?
Thank you very much. Thank you very much for this presentation. I don't have a real question. I have only one comment. You know, take-home message after this presentation to the audience should be that if you have patient with migraine and depression, You have to just use antidepressant as a prevention of migraine attacks. And if you have the patient with the anxiety and migraine, we just have to use beta blockers. So that's only this, just only from the practical point of view. Thank you very much.
Thank you.
Thank you very much.
Now I would like to invite to join online Mr. Łukasz Zaremski, who will present the work entitled Correlation between Bilingualism and Progression of Dementia and Other Cognitive Diseases.
Excuse me, is there Mr. Łukasz Zaremski online right now? Is he on our meeting at Zoom? Okay, so we cannot see it, Mr. Łukasz Zaremski, so next work will be presented.
So we would like to invite Ms. Magdalena Pruchnicka, and she will present the work entitled Can Vitamin B6 Prevent Postpartum Depression?
Hello, is my presentation visible?
Yes, we can see a presentation and we can hear you.
Okay, so I
Please
will
do a full screen.
Okay, do you can see the slide?
Yes, we can see the first slide, but please do the full entire screen because we can see every other tools. So.
Is it good now?
Yes, right now it's perfect. You can start.
Okay, thank you. So good afternoon, Honorable Committee. My name is Magdalena Pruchnicka and I'm representing the Student Scientific Group at the Department of Psychology at Medical University of Lublin. I would like to present to you my work titled Can Vitamin B6 Prevent Postpartum Depression? Postpartum depression is a type of mood disorder associated with childbirth, which can affect both sexes. Globally, PPD afflicts up to approximately 20% of women during pregnancy or after giving birth. Symptoms may include extreme sadness, low energy, anxiety, crying episodes, irritability, and changes in sleeping or eating patterns. Onset is typically between 1 week and 1 month following childbirth. PPD can also negatively affect the newborn child. According to the ICD-10 classification, its symptoms must appear within 6 weeks after giving birth. The mechanism of the development of depression is currently unknown. The cause is believed to be a combination of physical, emotional, genetic, and social factors. This may include factors such as hormonal changes and sleep deprivation. Risk factors include prior episodes of postpartum depression, bipolar disorder, a family history of depression, psychological stress, complications of childbirth, lack of support, or a drug use disorder. The most common screening test used for diagnosis is Edinburgh Postnatal Depression Scale. It is a standardized questionnaire consisting of 10 sentences. For example, I have been anxious or worried for no good reason. I have been so unhappy that I have had difficulty sleeping. I have been so unhappy that I have been crying. Or the thought of harming myself has occurred to me. In case of obtaining 13 points or more, a woman should consult a doctor in order to confirm or rule out the diagnosis. And this test is available on the internet for free. And there are now a number of therapeutic interventions for postpartum depression, including pharmacotherapy, psychotherapy, neuromodulation, and hormonal therapy, among others, most of which have been adapted from the treatment of major depressive disorder outside of the peripartum period. The most commonly used drugs in postpartum depression are the SSRIs. Let's move on to our clinical trials. This single-blind placebo-controlled trials was conducted on women who were at risk of PPD. The inclusion criterion was having at least one risk factor, which is the history of psychiatric disorders, marital relationship, antenatal anxiety and depression, absence of depression and clinical anxiety in present pregnancy, lack of social support, recent stressful life events, as well as an unplanned pregnancy. The risk of PPD was assessed using a structured clinical interview using Hospital Anxiety Depressive Scale, Social Support Appraisal Scale, and Holmes and Reich Life Change and Stress Evaluation Questionnaire. The Edinburgh Postpartum Depression Scale was used to assess the rate of depression prior to and 1.5 months after the intervention. 81 women were assigned to the control and placebo groups, and independent t-test results showed that there was no significant difference between the two groups. The case group of women received two 40 milligram pills of vitamin B6 daily from the 28th week to the end of pregnancy, and then one 40 milligram pill of vitamin B6 for 1 month after delivery. The control group received two placebo pills daily from the 28th week to the end of pregnancy, and then one placebo pill for 1 month after delivery. According to paired t-test results, it was found that the mean score of depression in the post-intervention group was significantly lower than that of the pre-intervention group. In the control group, the mean score of depression was not significantly different pre and post-intervention, and no reportable complications were observed in both groups. According to obtained results, vitamin B6 has a positive effect on reducing postpartum depression scores among mothers at risk for PPD. However, these arrangements should be seen as preliminary until this treatment is assessed in larger, multi-center studies of longer duration. And thank you very much for your attention.
Thank you very much for your work. And now, do science community have any question?
Do you have any questions?
No, thank you very much. I don't have a question. Thank you.
Okay, so that would be it. Thank you very much.
I think we have to just back to the student Izabela Pilarska. She presented now the study concerning the suicide attempts.
Yes.
Unfortunately, we don't see Ms. Isabella. She's not online with us. So I think we're gonna just proceed with that. And is Mr. Łukasz Zaremski maybe with us? No, also not. Okay.
So in that case, it was the last presentation.
prepared by the active participants of neurological, psychiatric and psychological session. We would like to express words of thanks for everyone who present the results of their works. We hope that you enjoyed this time and that the exchange of views and observations will contribute to your medical knowledge. We are grateful for the presence of scientific committee for all questions and debates over the pre-elections. The important information for active participants is that the results of jury assessment will be published today evening on the official Facebook profile of the conference. Therefore, we recommend you to follow the newest post on our profile. We remind all participants who sign up for the workshops for today evening and tomorrow to check the place of your workshop at the time when it starts. Thank you for the participate and see you on the next events organized at the Medical and University of Lublin. Thank you.
10, 5, 4, 3, 2.
Good afternoon, everyone. At the beginning of the gynecological session, let me introduce myself and my colleague. My name is Kasia Bień, and the co-chair is Iga Wieczorek. We are going to guide this session, supervise the order of pre-elections, control the time of your speeches, and give you a hand if required.
We have a great honor to solemnly welcome all active and passive participants at the gynecological session within the 21st Century Medicine International Medical Congress for Students and Young Doctors. The conference is organized by Young Medics organization at the Medical University of Lublin and Department of Epidemiology and Clinical Research Methodology, together with the partners, hereinafter referred as the Organizing Committee.
We are favored with all scientific papers that you have delivered to the Organizing Committee and that you took the decision to participate in our Congress. We are delighted to kindly welcome the Scientific Committee, which the members are Doctor of Medical Science Katarzyna Jankiewicz, who works in Gynecology Department of our University Hospital, and Assistant Professor of Medical Science Michał Bogusiewicz, Professor of Gynecology Department of our University Hospital.
Before we start the pre-election, let me remind you the principles and rules of the presentation. Speakers on site will have their presentation turned on by the session leaders. Presenters are asked to deliver their presentation in front of the lectern. Speakers online are obliged to share their presentation on their own. In case of technical problems, we have your PowerPoint or PDF presentations on our computer, so we will share it with all participants during your pre-election. In the moment you want to change the slide, you just say it like the next one. Or here is also remote control, if somebody wants to do it from here on their own. The oral presentation of the original work may last no longer than 10 minutes and discussion no longer than 3 minutes. The oral presentation of case report or review paper may last no longer than 7 minutes and discussion no longer than 2 minutes. The session coordinator reserves the right to stop the presentation or discussion in the event of extending the time limit. At the beginning of the last minute, we will inform you about this fact by the special sound. There will be a special sound.
In case of exceeding the time, the coordinator is privileged to force finish the presentation. In this case, the discussion does not take place. The online presenting person must be equipped with a computer or tablet with operable camera and microphone. The camera should show the view of the participant, including the whole face and the upper limbs. The presenting person is not allowed to move out from the camera view and mute the microphone during the whole time of presentation, discussion, and the time between presentation and discussion. In case the presentation transmission is interrupted and less than 60% of given time has passed, the participant is allowed to come out again at the end of the current session. If more than 60% of the given time has passed, the presentation is evaluated and the participant is not allowed to answer the questions at the end of the current session. And the last rule concerning the assessment criteria obeyed by the Scientific Committee. Assessments will include the following: the summary, relevance of the topic, the use of research in practice, diligence of presentation, language of presentation, time limit, and discussion.
So these are all official rules that we need to observe. Do you have any questions or something is unclear? We would be glad to answer any doubts you might have.
There is no questions. Perfect. The first work, entitled Pre-pregnancy obesity and characteristics of complications in mother-offspring diets, a single-center retrospective study in Latvia, will be presented by Mrs. Liga Korneta, Doctor of Riga Stradins University.
Hello, dear jury and audience. Can you see my screen and hear me well?
Okay, yes, we are seeing your screen, but not a full screen.
Okay. So now I hope you can see and hear me well. Hello once again, and let me introduce myself. I am Liga Korneta, and my research mentors are Dr. Anna Korneta and Professor Anna Miskova. And I'm here today to present my research, pre-pregnancy obesity and characteristics of complication in mother-offspring diets, a single-center retrospective study in Latvia. World Health Organization has acknowledged obesity as a non-infectious epidemic of the 21st century. Pregnant women with obesity compared to women with normal body mass index have an increased risk for maternal and perinatal complications. And moreover, patients with pre-pregnancy obesity followed by high gestational weight gain have even higher risk of pre-pregnancy complications. A retrospective case control study was conducted among patients that were admitted to the Riga Maternity Hospital in Riga, Latvia, for the delivery. The study period was 2 years, and we included in a case group 670 pregnant women with pre-pregnancy body mass index more than 30 kilograms per square meter. And in control group, we included 224 pregnant women with a pre-pregnancy body mass from 18.5 to 24.9. And statistical significance was defined as less than 0.05. Obesity is defined as body mass index higher than 30 kilograms per square meter, and it is further stratified into 3 classes that you can see on my slides. And in case group, most patients were presented in obesity class 1. It was 64% of patients, followed by classes 2 and 3 with 27% and 7% respectively. And here you can see also mean body mass index as well for both classes and both groups. Here in the first chart, we evaluate maternal age, and the groups are almost similarly distributed when looking at age. In both groups, majority of patients had their pregnancy before age of 35. But in the second chart, we can see patients' parity. And here we can see that in the case group, most of the patients had their second child. But in the control group, the majority of patients had their first child during the period of this study. And in the third chart, the most common gestational age in both groups was between 37 and 41 weeks. But unfortunately, obese women have 3 to 4 times higher risk of preterm birth compared to women with a normal body mass index. And as the first chart here shows, the frequency of labor and induction and elective labor induction and elective cesarean section in case group is almost 2 times more often than in control group. And in the second chart, we can see that vaginal birth is more common in control group. However, cesarean section and operative deliveries are more frequent in a case group. Statistical significantly difference between both groups can be observed when looking at induction of labor and a cesarean section. Here, I would like to point out the complication of pregnancy. In the obesity group, gestational diabetes was 6 times more common. Hypertensive disorder of pregnancy, for example, preeclampsia and gestational hypertension, were nearly 8 times more common. But intrauterine growth restriction and placenta abruption were 2 times more common. However, difference was not statistically significant. And also frequency of macrosomia was not also statistically different between the groups. But a statistical significance difference between groups can be observed when looking at the gestational diabetes and hypertensive disorder of pregnancy. Previously, we looked at the complications that were during pregnancy, but now I would like to talk about complications that are placed during labor and delivery. And here we can see that fetal distress, failure to progress in labor and delivery, and also perineal and vaginal lacerations and postpartum infections were detected more often in women with obesity compared to women with normal body mass index. And uterine atony and cephalopelvic disproportion were more frequent in control group instead of cases. However, from all of these complications, only fetal distress was the significantly statistically significant difference between both groups. And in conclusion, I would like to say that the results on this large national cohort of pregnant women confirmed that pregnant women with obesity have an increased risk of various complications during pregnancy and childbirth. We need to pay greater focus on preventing, screening, and diagnosing, as well managing obesity in pregnancy. Obstetricians should be aware of this risk and modify patients' care before pregnancy, during pregnancy, and postpartum to reduce the risk of these adverse outcomes. And at the end of my presentation, I would suggest that raising awareness within society could encourage women who plan their pregnancy to pay attention to their body mass index. Thank you for your attention.
Thank you very much for the presentation. Now is the time for questions to the prelegant and discussion. Questions can be asked either by members of scientific committee or the other participants interested in the topic. Do you have any questions?
Yes, I have one question. First of all, congratulations, very nice presentation, very interesting. And I have one question regarding the methodology of the study. How did you choose a patient for the study? Were there consecutive patients or randomly chosen among patients from 2 years of study period?
Thank you for your question. In a case group, we took all the pregnant women that delivered in those 2 year period in this specific hospital. And those were only the patients who had maybe one children. We excluded the patients who had twins or more.
Okay, thank you.
Do you have any questions? Okay, thank you for the discussion.
Okay, now I would like to invite Mrs. Anna Zwierzyńska, the student of Jan Kochanowski University, to present the work entitled Abnormal Pregnancy Bleeding.
Good afternoon, ladies and gentlemen. Please tell me if my screen is seen.
Yes, is everything okay with your screen?
Thank you. First of all, thank you for the possibility to be the member and the speaker in this conference. The subject of our presentation is abnormal pregnancy bleeding, which is my and my colleague Jakub Gruszka. Our supervisor and mentor is Dr. Olga Adamczyk-Gruszka. I hope you will like our presentation. The presentation outline, I will tell something about the introduction, first trimester bleeding, late pregnancy bleeding, and conclusions. The bleeding in pregnancy is a fairly common problem. It is extremely important to identify the factor that causes them, and it is also important for the development of the fetus and the cause of pregnancy. Numerous scientific reports confirm that the occurrence of bleeding in the first trimesters of pregnancy may be adversely affect its future course and may be a risk factor for conditions such as pre-labor rupture of membranes or perinatal bleeding. The first trimester bleeding, 25% of pregnant women can experience the bleeding during the first trimester of pregnancy. It is usually no cause for alarm. Physical examination, laboratory testing, and the ultrasonography can be very useful during the diagnosis of the first trimester bleeding. A review of the menstrual history and prior ultrasonography can be also helpful. It is very important to note the possible causes of the first trimester bleeding, and so they are the implantation bleeding, pregnancy bleeding of unknown location, ectopic pregnancy, early pregnancy loss, molar pregnancy, cervical changes, and infections. The most common cause is implantation bleeding. It usually happens from 6 to 12 days after the fertilization. It can be mistaken for periods. Usually it's very light bleeding and it lasts a few hours to a few days. The pregnancy of unknown location, it is the pregnancy, it is the situation where the pregnancy test is positive, but neither intrauterine nor ectopic pregnancy is shown on the ultrasonography, and it is very challenging diagnostically. We have to monitor the symptoms. The ectopic pregnancy, its incidence is from 1 to 2%. It is a cause of 6% of all maternal deaths, and risk factors of the ectopic pregnancy are a pelvic inflammatory disease, previous tubal surgery, previous ectopic pregnancy, in utero exposure to the diethylstilbestrol. The early pregnancy loss, previously called as spontaneous abortion, its possible causes are chromosomal abnormalities, immunologic causes, infectious causes, underlying maternal risk factors. And the late pregnancy bleeding, it is bleeding in the second or third trimester of pregnancy. It can be signal of a problem. The effective management of vaginal bleeding in late pregnancy requires recognition of potentially serious conditions. It is associated with maternal and fetal risk, and very important is the timely intervention. The possible causes of late pregnancy bleeding are placenta previa, placental abruption, uterine rupture, vasa previa, premature labor, injury to the cervix of vagina, cancer, and polyps. Placenta previa, a placental implantation that overlies or is within 2 centimeters of the internal cervical os. transvaginal ultrasonography is very important during this placenta previa, and risk factors are chronic hypertension, multiple gestation, older age, previous cesarean delivery, and tobacco use. Placental abruption risk factors are chronic hypertension, multiparity, preeclampsia, previous abruption, short umbilical cord, sudden decompressions of over-distended uterus, tobacco use, cocaine use, or trauma. Vasa previa is a very rare condition. Fetal vessels are crossing or running in close proximity to the inner cervical os. High rate and fetal or neonatal death when it's not diagnosed attendishly, and it's also abnormal fetal heart rate. And last but not least, the short summary. And as I mentioned before, 1/4 of pregnant women will experience bleeding in the first trimester of pregnancy. Possible causes are early pregnancy bleeding are implantation bleeding, early pregnancy loss, ectopic pregnancy, or pregnancy of unknown location. Late pregnancy bleeding can be a signal of a problem. It requires recognition of potentially serious conditions. And the references. And thank you all for your attention.
Thank you for the presentation. Now it's time for possible questions.
Good afternoon. Thank you for a very interesting presentation. I have one remark which maybe I think it's interesting. Do you know what proportion of ectopic pregnancy may resolve spontaneously without any treatment?
I think about 30%.
About 2/3, about 65%. That's really interesting. Thank you.
Thank you.
Now I would like to invite Mrs. Adrianna Gorecka, the student of Medical University of Lublin, to present her work entitled COVID-19 Infection in Pregnancy, Complications. The floor is yours.
Good afternoon, everyone. My name is Adrianna Gorecka. I represent Student Scientific Group at the Department of Obstetrics and Pathology of Pregnancy, Medical University of Lublin, and I'm going to present a review study entitled COVID-19 Infection in Pregnancy, Complications. The COVID-19 pandemic is an ongoing global pandemic caused by severe acute respiratory syndrome, coronavirus 2. The novel virus was first identified at the end of 2019 in Wuhan, China. Since then, it spread to other countries, including Poland, where the first case of the virus was identified 3 months later. To date, more than 5,500 million people were infected worldwide. The symptoms of the virus are known to all. Still, I gathered the most common ones here. And what is worth emphasizing is the fact that symptoms may vary in individuals from none or mild to severe illness that may even lead to death. The group of patients at particular risk of severe infections and complications are pregnant women. The aim of the study was evaluation of impact of COVID-19 infection during pregnancy based on the review of newest medical literature published between 2020 and 2022. First, we check women in which trimester are admitted to hospital most often. The studies corresponded with each other, and as we can see on the diagram, the biggest group are patients in third trimester, which constitute for over 60% of all. When it comes to differences between COVID-positive and COVID-negative pregnant women that are admitted to hospital, we can see that the first group is statistically younger and the BMI is statistically higher than in the second group. It can be also observed that, representatives of the first group most often have comorbidities such as chronic or gestational diabetes. We can also see that majority of pregnant women admitted to hospital due to COVID-19 have mild infection. Still 15% of them require admission to intensive care unit or treatment with high flow or invasive ventilation, which is a higher percentage than in general population. Drawing on the literature, we compared two groups of pregnant women that required hospitalization with mild or moderate infection and those with severe infection. In the table, we gathered the most common values for both groups. And as we can see, there is a higher percentage of obese women in the second group. We can also observe that there is almost 10 times higher likelihood that they will give birth preterm, which we can see on the last paragraph. When it comes to statistical significance, age equal or older than 30 years, overweight, gestational diabetes correlate with an increased risk of severe COVID-19, which increases adverse outcomes for both mother and baby. Complications of coronavirus disease in pregnant women are similar to those in non-pregnant patients, though we should pay special attention to them as the illness, especially symptomatic one, may lead to side effects in children. The younger the gestational age, the more severe side effects in children occur. The most frequent ones are preterm delivery, which happens 3 times more often than in general population, and decreased gestational age, when babies are smaller than expected, in particular weak. Moreover, babies born to mothers who fell for COVID-19 during pregnancy are 12 times more probable to be admitted to neonatal intensive care unit, which is a result of the reasons mentioned above. It is all associated with lower fetal survival and lifelong health problems. A potential mechanism that could account for worse outcome with SARS-CoV-2 infection earlier in gestation is increased levels of angiotensin-converting enzyme 2 in the placenta earlier in pregnancy, because the virus spike protein interacts with ACE2 and enters human cells. So the earlier in pregnancy, the more ACE2 and the more severe outcome for the baby. COVID-19 infection in pregnancy also may cause inflammation and damage to the placenta, which can lead to abnormal perfusion and placental insufficiency, and hence contribute to worse effect. And summing up, COVID-19 in pregnancy may increase the risk of adverse effects in both mother and child. Prevention of the disease is of great importance in minimizing severe infection and therefore serious side effects, and pregnant women should be a prioritized population for vaccinations, and all of them who undergo the infection must be taken into special prenatal care regardless of the trimester. Sources. And that's all. Thank you for your attention.
Thank you for the presentation. Now is the time for questions to the prelegent and discussion.
Thank you for a presentation. I have one comment. It's very difficult to prepare such a presentation because the data and knowledge around about COVID-19 is changing rapidly, and that's something which was interesting for me. Did you find any data that the virus may transmit from mother to the fetus, particularly? Any proven data?
To be honest, I did not find any of such data.
Me too.
So I don't know what to say. If it's not possible, I just didn't come up with any.
It's very little probable that there is a transmission. That there were some case reports, but they are, for me, were not of great value. Thank you.
Thank you.
Thank you for the discussion.
In the meantime, I would like to get your attention to the patrons and sponsors of the 21st Century Medicine International Medical Congress. The honorary patronage for our Congress was granted by Mr. Krzysztof Żuk, the Mayor of Lublin City. The honorable group of sponsors includes publishing houses Celej, Medycyna Praktyczna, MedCases Company, and Lek Exam Company.
Now I would like to invite Mrs. Nina Kamińska-Słyk, the student of Medical University of Warsaw, to present her work entitled N-acetylcysteine supplementation in patients with polycystic ovary syndrome.
Good evening, ladies and gentlemen. My name is Nina Kamińska-Słyk. I'm a student of Medical University of Warsaw, and today I would like to present you with a study titled N-acetylcysteine supplementation in patients with polycystic ovary syndrome. So, first of all, what even is N-acetylcysteine, NAC for short? It derives from the amino acid L-cysteine, and it has been proven to have strong antioxidative properties. Thus, it is used in many conditions, such as acetaminophen overdose and mucolytic therapy. So what are the main problems of patients with PCOS? There are many, but the most common and problematic ones are oligo-ovulation or anovulation, meaning lesser or no ovulation present, and lower quality of oocytes, metabolic problems such as hyperandrogenism and increased insulin resistance, and polycystic ovarian morphology, which is present in some patients, but not in all of them. So we have conducted a search through PubMed database using key phrases such as polycystic ovary syndrome, PCOS, N-acetylcysteine, and acetylcysteine. Studies must have been published between 2002 and 2022. Thus, we identified 12 relevant articles, 11 of them were clinical trials, and one of them was a review. So first, let's discuss results concerning ovulation and pregnancy rates in natural, induced, and IVF cycles. So NAC, compared with placebo, improves both spontaneous and induced ovulation rates. There have been 3 studies comparing NAC supplementation to metformin, which is a diabetes drug known for decreasing insulin resistance. 2 of those studies have shown no statistical difference in ovulation and pregnancy rates between NAC supplementation and metformin, and one of them has proven metformin to be more effective. In IVF cycles, NAC supplementation seems to decrease number of abnormal oocytes and increase number of good quality embryos. So what about other problems present in PCOS patients? NAC supplementation between 12 to 1800 milligrams per day is reported to improve lipid profile, raise HDL levels, improve fasting blood glucose and OMA index, reduce hirsutism, lower testosterone levels, improve insulin area under curve in OGTT in hyperinsulinic patients, as well as improve endometrial thickness. In stimulated cycles, it improves number of follicles over 18 millimeters, which is very beneficial, and also it improves menstrual pattern and decreases abnormal uterine bleeding. So, as you can see, it helps with many problems present in PCOS patients. So, in conclusion, N-acetylcysteine supplementation seems to improve many problems present in PCOS patients. It may be beneficial in stimulation of ovulation as well as in general metabolic profile of these patients. However, further research is needed on the topic as the studies are only a few and they differ in methodology. For example, duration, doses, and inclusion criteria of patients. New reports would help integrate NAC supplementation into guidelines and clinical practice, and also assess truly how beneficial is the NAC supplementation. However, the data we now have is very promising. Thank you very much for your attention, and I would like to invite discussion.
Thank you for your presentation. Now is the time for questions.
Thank you once again. It was a really good presentation, and it's something important for all people doing all these procedures as induction and all things like this. And I would like to ask if it is some data about induction of ovulation with gonadotropins using this substance. Do you have some maybe info about it?
So there's not really a study of inducing ovulation just with gonadotropin. However, the study we have, which is on IV vehicles, we know that they use gonadotropin to stimulate the patient. And it seems very promising, the data, especially from this study, because it improved the numbers of good quality embryos, of good quality oocytes, so it might be very useful in this field.
Okay, thank you.
I have one question. Do you did you find any data on side effects of using acylcysteine?
Excuse me, once again, I haven't heard.
Adverse effect of this substance?
So side effects are mainly like the indigestion, like problems with the gastrointestinal system, because it is quite irritating for the gastrointestinal system.
Thank you very much.
Thank you.
Thank you for the discussion. The following work, entitled "The Rare Case of Patient with a High-Grade Fallopian Tube Carcinoma in the Low Stage," will be presented by Mrs. Karolina Frankowska, student of Medical University of Lublin. The floor is yours.
Dear jury, dear audience, my name is Karolina Frankowska, and it's a great pleasure for me to present the case study about a patient with primary fallopian tube cancer, on the basis of which I want to say a few words about the diagnosis and differentiation of unobvious adnexal lesions. 3 to 10%. According to the literature, that's the appropriate diagnosis rate of primary fallopian tube cancer. And when to the needs of today's presentation we found this data, we asked ourselves a question, what's the reason of such low detection? And actually, PFTC seems to be a serious diagnostic problem, as because of its low prevalence of approximately 1% of all gynecological malignancies, because of low detection in imaging studies, and also due to difficulties in differentiation it from epithelial ovarian cancer. And that's why we're interested in history of our patient. And now let's move on to the silhouette of her, which was as follows. A 55-year-old postmenopausal woman with no symptoms pointing on likelihood of cancer development and with no abnormalities in the gynecological examination. But the patient also underwent ultrasound examination, and its results were crucial in the diagnostic process, so I highlighted it here for a reason. As far as the first ultrasound scan revealed the presence of lesion in type of maybe paratubal cyst. Then another ultrasound projection revealed the presence with very strong vascularization, which according to the IOTA simple rules suggested the presence of some malignant feature of the lesion. Additionally, some laboratory tests were performed, but besides slightly elevated levels of CA-125, no other abnormalities were observed. And considering the CA-125 and HE4 values, as well as the postmenopausal status of the patient, the ROMA test was done to assess the ovarian cancer risk, but its results revealed the low risk of this malignancy. And the patient was qualified for the laparoscopic operation, during which the tumor of the left fallopian tube was found, about 3 centimeters in diameter, and intraoperative histopathological evaluation revealed the presence of a poorly differentiated cancer of the fallopian tube, but it was supposed about ovarian origin of the lesion. So based on the overall clinical picture, the case was qualified as FIGO 2A due to the infiltration on the fallopian tube. So the decision of the extent of the surgery range was made, and total hysterectomy with omentectomy were performed, as well as the excision of the para-aortic and pelvic lymph nodes. But only detailed histopathological diagnosis led us to make the final diagnosis, as finally no tumor cells in the left ovary were found. So the diagnosis of high-grade primary fallopian tube cancer was made, and also there was a tumor tissue on the outer surface of the fallopian tube, so the case was qualified as FIGO 1C, but such downstaging did not affect the final proceeding, because in the post-operative period the patient was qualified to receiving adjuvant chemotherapy according to the standard protocol, and taking into consideration the NCCN guidelines, in both cases the proceeding will be the same. And when we remind ourselves the symptoms of our patient, we see that it was very difficult to differentiate between these two types of cancer, as PFTC and EOC present extremely similar characteristics. But there is a question, where lies the difference between EOC and PFTC, and there are reports about significant difference in 5-year survival rates between PFTC and EOC, and we know that it may affect the preoperative psychological states of the patient. And there are reports about successful use of MRI in preoperative differentiation of such lesions as PFTC and epithelial ovarian cancer. And when it comes to the conclusions, there is some highlights worth to remember based on it. Firstly, an accurate basic diagnosis is crucial in PFTC detection, as in our case, the whole uterine appendages projection and the using of color Doppler led us to detection of this lesion. And secondly, the clinicians should remember about consideration of PFTC during differential diagnosis of ovarian cancer, and about detailed samples collecting for histopathological evaluation. And finally, we should not forget about rare statements as PFTC belongs to. Thank you very much for your attention, and if you have any questions, please feel free to ask me.
Thank you once again for your presentation. It's really nice for all our surgeons, for gynecologists who have to deal with all these cancers. And I think it's really important to see before surgery if it is really cancerous of ovary or oviduct. And I would like just to ask about procedure. It was done during laparoscopic procedure, yeah? The surgery?
Yes, all the surgery was done by laparoscopy.
And it was some endovac during this procedure. It was used.
Yes.
Okay, it was. And do you think it is a difference during procedure this procedure when you use endovac or not for the later let's say treatment about this endovac using or not?
Yes, it's important in case of especially malignant lesions to avoid the further spread of the lesion.
Yeah, of course. Thank you.
Thank you.
Okay, thank you for the presentation and for the discussion. Now I would like to invite Mrs. Aleksandra Ziłkiewicz, the student of Medical University of Lublin, to present her work entitled Iron Deficiency, Anemia in Pregnancy, Rules of Conduct.
Good afternoon. Is everything visible?
Yes, we can see the presentation, but not the full screen yet.
Okay. So I'm Victoria Garbacz, and I will be presenting the presentation. So my today presentation is about iron deficiency anemia in pregnancy, rules of conduct. First of all, I will talk briefly about physiological changes and morphology in pregnancy. The erythropoiesis in the bone marrow increased, which is manifested by an increased number of reticulocytes in the peripheral blood. There is also a slight decrease in the mean plasma platelet count during pregnancy. The reduction in the number of platelets is due to increased platelet consumption. Blood volume increased by 50% compared to the pre-pregnancy value. Hypervolemia is presented because of blood supply to the significantly enlarged and richly vascularized uterus, providing nutrients and elements to the rapidly developing placenta and fetus, and reserve bleeding in case of perinatal blood loss or hemorrhage. The increase in circulating blood volume leads to a decrease in the hematocrit value. This condition is referred to as a physiological anemia of pregnancy, which is accompanied by an average hemoglobin of 12.5 gram per deciliter. Every pregnant woman should have her own blood count checked at least 5 times during pregnancy. The gynecologist first order it during the pregnant woman's first visit, usually before 10th week. Anemia is defined as a medical condition in which the number of erythrocytes, the amount of circulating hemoglobin, fall below the optimal values for the body to ensure proper oxygenation of peripheral tissues. It's diagnosed when hemoglobin concentration is below 11 gram per deciliter in first trimester or below 10 gram per deciliter in second and third trimester. Pregnancy increases the mother's requirements for iron for 3 reasons. The plasma and blood volume of the mother increases. In addition, the fetus needs iron for its own metabolism and oxygen supply, and to load up relatively large stores of endogenous iron, which will be used during first 6 months of life. The occurrence of anemia in pregnancy can adversely affect the course of pregnancy and labor, as well as the well-being of the fetus, newborn, and infant. There is an increased risk of miscarriage, intrauterine growth restriction, uterine fetal death, abnormal uterine contraction during labor, and impaired contraction after delivery. In newborns, it is associated with lower APGAR scores. Low maternal iron intake at conception is associated with a higher risk of autism in the offspring. In the second trimester, increases the risk of schizophrenia and preterm birth. And in the third trimester of pregnancy, it alters the brain structure of the newborn. Infants born with low serum ferritin levels have poor recognition memory at birth and at later age, poor academic performance, planning skills, and attention difficulties. Pallor, fatigue, shortness of breath are possible symptoms in patients with anemia. In the diagnosis of anemia, the examination remains the evaluation of the blood count and the determination of the erythrocyte indices and the number of morphotic elements based on this. During pregnancy, iron deficiency is relatively common because of increased iron requirements and because many women begin pregnancy with weak or depleted iron stores. The primary treatment for iron deficiency anemia is oral preparation at a dose 100 to 300 milligrams per day. Commercially available iron preparation are halates, sulfate oxide, and magnesium compounds. Iron preparation work more efficiently when taken on an empty stomach. This treatment is administered until normal hemoglobin concentration is achieved and have to be continued for at least 3 months. The effectiveness of the treatment is demonstrated by increase in the reticulocytes count after 7 days and in the hemoglobin concentration by about 2 grams per deciliter after 1 month of treatment. If there is no effect, another treatment should be considered, for example, switching from oral to intravenous iron, but not in the first trimester, changing to erythropoietin, or diagnosing other causes of anemia. A low molecular weight iron dextran is given intravenously 1,000 milligrams per hour in the treatment of anemia in pregnant women in the second and third trimester. Prophylaxis of iron deficiency anemia involves adherence to a healthy, balanced diet and daily oral intake of 30 to 60 milligrams of iron throughout pregnancy. The Polish Gynecological Society recommends iron supplementation for women with anemia identified in the preconceptual period and 9 weeks to the end of the pregnancy. For pregnant women at risk of anemia, for example, vegetarians. For pregnant women with hemoglobin concentration lower than 11 milligrams per deciliter and during breastfeeding. The iron supply should be 18 milligrams outside pregnancy, 26 milligrams during pregnancy, and 20 milligrams during lactation. For a pregnant woman with anemia, the iron dose should be increased to 60 to 120 milligrams per day. And conclusion, early detection of anemia is essential to prevent fetal morbidity and mortality. For this purpose, thorough physical examination and laboratory tests should be performed. Oral iron preparations are more commonly used because of their efficiency and low cost. Parenteral treatment should be isolated to treat moderate to severe cases of anemia when rapid iron supplementation is required. Thanks for your attention.
Thank you for the presentation. Does scientific committee have any questions?
I have no questions. I have only one comment because the recommendation for supplementation of iron in every pregnant woman at the moment has been changed a little bit because there are some data that supplementation of iron may cause insulin resistance. So it's sort of discussion now whether we should give this supplementation to each patient. Did you read anything about it?
No, I didn't find any research about this.
Okay, thank you.
Okay, thank you for the discussion.
Thank you.
Now I would like to invite Mrs. Justyna Ostojewska, the student of Medical University of Lublin, to present her work entitled Pregnancy After Heart Transplant.
Good morning, my name is Justyna Ostojewska and I would like to present a case report about pregnancy after a heart transplant. The work was made on the behalf of Student Scientific Association at the Department of Obstetrics and Perinatology of the Medical University of Lublin under the supervision of Dr. Magdalena Słodzińska and Professor Bożena Leszczyńska-Gorzelak. The patient was 25 years old when became pregnant, and it was 5 years after heart transplant, made because of dilated cardiomyopathy and numerous supraventricular and ventricular heart rate disturbances. Here I would like to tell a little bit about what should we take into consideration while having a patient after heart transplant who is planning to be pregnant. Firstly is time after procedure. According to American Association of Transplantologists, first 12 months after the procedure is the most dangerous period of time because of the highest risk of acute rejection reaction of transplanted organ. And that's why in this period of time the woman should take 3 drug scheme of therapy, including mecophenolate mofetil, that is very teratogenic. That's why in this period of time we should recommend the woman to take contraception, but on the other hand we should also inform the woman not to wait too long with the pregnancy, because 5 years after the procedure there is increased risk of long-term complications such as vasculopathies, and also the time of survival after such a procedure in this group of patients is estimated 15 to 20 years, so we should tell the patient not to wait too long, also to prolong the term of childcare. Also, the next problem is risk of infection that is the highest at the beginning, also in the first year after the procedure. We are the most worried about opportunistic infections such as CMV. Of course, it can be used prophylaxis, antibiotic and antiviral prophylaxis, but it's not fully safe both for the woman and for the child, so we should recommend just waiting a little bit longer to stabilize the immunosuppression. Also, the risk of anemia is high due to taking the immunosuppressive medication, and also during pregnancy the volume of blood is higher. That's why we can have the problem with anemia, and we should supplement the iron. She recommend the supplementation. The control of the woman was in the form of 3 days hospitalization every month, and it was made ultrasound of the fetus to check the well-being of the baby, also the growth of the baby, to check the kidneys, the circulatory system. Also the blood test was made to check the count of cells and to check the level of hemoglobin, and also biochemical test to check the state of kidney and liver. Urine test, cardiological control, of course, with echo and electrocardiography, and very important, level of tacrolimus in the blood, because it have to be stabilized, because it can cause preterm delivery and hyperkalemia in the fetus. Here we can see some blood examination of this woman. We can see hemoglobin level just after the procedure. It was very, very low. That's why before the pregnancy it was supplemented the iron, and then during the whole pregnancy the level of hemoglobin was quite low, but in quite good state, and what is the most important, it was stable. Also, as we can see here, the 3 drug scheme of therapy was changed into 1 drug, and it was used tacrolimus, and that doses was changed to maintain the good level in the blood, and also mecophenolate mofetil was stopped because it can cause a lot of miscarriages and severe defects defect in the child. I think it's worth mentioning here that is important to work in multidisciplinary team when taking care of this woman with perinatologist, transplantologist, obstetrician, cardiologist, and neonatologist. And here are some statistics. Every year, 30 women in Poland undergo heart transplant. It's not the main group that is qualified to this kind of procedure, but I think it's quite a large group, and we should know what to do with all those of these women that can be pregnant and can have a higher risk during pregnancy of hypertension, preeclampsia, gestational diabetes, infections, hemodynamic disturbances, uterine growth restriction, and also preterm delivery and due to immunosuppression, malformations of nervous system and craniofacial region. Another problem is to choose a vaginal delivery or cesarean section. There are advantages and disadvantages of both of these methods, and also we should take into consideration psychological aspect of the patient. In vaginal delivery, the problem is that we have to check all the time, monitor the heart rate of the woman, and there are more problems with circulatory system. But also in cesarean section, we have higher risk of infections. In our case, we chosen cesarean section with extended antibiotic prophylaxis. This child was born in a 37 week of pregnancy with Apgar score 7, 8, 8, and 9 due to respiratory disturbances that I will tell about in a moment. The woman was under the psychological control due to the stress associated with the whole procedure. And it's worth mentioning that breastfeeding here is not recommended, and it was stopped by bromocriptine in this patient. Okay. And here we can see that just after delivery we had a problem with respiratory disturbances in the child, but it was used CPAP, and after 8 hours it normalized, and also it was recommended cardiological consultation. In physical examination, there were no heart murmurs, and baby was circulatory efficient. And during echo, it was found mild aortic and tricuspid regurgitation, and also mild atrial septal defect, but it wasn't severe. So after 7 days, the baby was discharged home with good condition, with circulatory and respiratory efficiency, and with recommendation of cardiological control in 6 months. Thank you very much for your attention.
Thank you for the presentation. Now is the time for questions.
Thank you very much. It was a complete presentation, but I have to ask you about one thing. I think the doctors just controlled the level of tacrolimus during the pregnancy, and the dose has been changed, as I noticed. Do you have any knowledge about the postpartum period? Was it any need to change the dose?
Yes, because of pregnancy, the doses had to be higher because also of placenta and of metabolism of the medication. And later, after delivery, the level of the dose of tacrolimus was lower, but the dose in the blood was quite the same because of metabolism of the drug. So it was between 5 and 10. It should be between 5 and 10 nanograms.
Thank you.
Thank you very much.
Thank you for the discussion.
And the last work, entitled Trisomy 47XXX, a common but rarely diagnosed cause of infertility, will be presented by Mr. Mikołaj Makarychev, student of Medical University of Lublin. The floor is yours.
Good evening, my name is Mikołaj Makarychev, and thank you for introducing me and my team. Special thanks to our supervisor, Dr. Isabella Winkler. Today we are covering the trisomy 47XXX. It's a common but rarely diagnosed cause of infertility. First of all, X-chromosome trisomy is common but rarely diagnosed disorder. It was first time described in 1959 by Jacobs and others. The most common cause of 47XXX syndrome is a non-disjunction during meiosis I, which is increasing with the age of mother. It is characterized by the presence of a number of symptoms, such as tall stature, renal dysplasia, diagonal wrinkles, and decreased intelligence level, or clinodactyly, and many others. Let's talk about our case. The first miscarriage occurred at 12 weeks of gestation in 2019, and the second at 8 weeks of pregnancy 2 years ago. In clinical examinations, we have found MTHFR and PAI1 mutations. One of them is in homozygous system, which is very important. Lupus anticoagulant was absent. Cardiolipin antibodies were normal, while the titer of cardiolipin IgMs was about 65. The patient's AMH, which is anti-Mulleran hormone, level was about 0.5, while FSH was elevated to 13. What is more, ultrasonography revealed an atrophic endometrium and atrophic ovaries. All these symptoms lead us to cytogenic examinations. It shows the patient was found to have an abnormal female karyotype, 47XXX. And the main question of our case is, what kind of gynecological problems does the trisomy cause? Firstly, the patient presents mainly with gynecological symptoms, while the characteristic symptoms of the trisomy 47XXX are only few. The most important disorder of our patient is POF, I mean premature ovarian failure. It was diagnosed due to elevated FSH, lowered AMH, and reduced size of ovaries. Additional factors that increase the risk of miscarriage are positive antinuclear antibodies and presence PAI1 in homozygous status mutation. Is important because look at this fact. Presence of PAI1 in homozygous status is important, while mutation in MTHFR in heterozygous status is not a risk factor. It should be in homozygous status 2 to be a risk factor, such as PAI1. What is more, the patient with trisomy 47XXX produce normal gametes. To sum it all, being aware of the fact how complex medicine is, we should be aware that in our cabinet, during our work, there will be some patients who will demand very complex treatment from different fields of medicine. Because of the wide spectrum of symptoms and potential complications of trisomy, each patient should be individually diagnosed and treated. Thank you for your attention.
Thank you for the presentation. Now it's time for questions.
I have one question. Do you know any reports on successful pregnancy in patients with this abnormality?
The frequency of this mutation is one newborn to 1,000 of all female newborns. It's really common.
Yes, but I was asking if any women with this abnormality gave birth to living baby.
To be honest, I don't have such a data, but I know that our patient was qualified to in vitro procedure, but it fails.
Okay, thank you.
It was necessary, but in vitro fails about 2 or 3 days ago. I called her and she told me that.
Okay, thank you.
Thank you.
Okay, thank you for the discussion. It was the last presentation prepared by active participants of gynecological session.
We would like to express words of thanks for everyone who presented the results of their works. We hope that you enjoyed this time and that the exchange of views and observations will contribute to your medical knowledge. We are grateful for the presence of scientific committee, for all questions and debates over the pre-elections.
The important information for active participants is that the results of jury assessment will be published today evening on the official Facebook profile of the conference. Therefore, we recommend to follow the newest posts on our profile. And we also remind all participants who sign up for workshops tomorrow to check the place of your workshop and the time when it starts.
Thank you for the participation and see you on the next events organized at the Medical University of Lublin.
Thank you.